Hello, is everything good? Hello, all good.
Check, check, hello, hello. Check, check, check. Hello, hello. Check, check, check. Hello, hello, hello. Check, check, hello, hello. Check, check, hello, hello. Check, check, check. Hello, 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 hello.
15. Thanks to the 2 or 3 people who are here to listen to us. Okay, sure. Suchi, can you please take one clip while we are sitting? From my cell. Can you take from my... Yeah, yeah. I will. Yeah. Thank you.
No, just with yours. Yeah. Are we ready? And the
Thank you, Suchi. Thanks a lot.
couple of yeah, yeah. Are we taking some closer because वो lighting जैसे back में जैसे uh, I don't get it. Stay like this. No, light को जैसे करो.
Thank you, Suchi.
Maybe put it on the group. Yours will be better with dark.
She was saying that the lighting is dim, right?
Okay, I'm gonna get started in 2 minutes then, right? Are you laughing at us? Did you put it on Twitter? I sent it to my to your okay. I don't have it on my phone. Okay.
Pendrive slides in there.
I usually do at the same time the keynote video. Even the keynote stuff. Sure. Okay. Well, good morning to all my fellow panelists, and thank you so much for agreeing to be here today. And thanks to all of you, the students, and some of the key people that I'm seeing on the audience. It's really gives a motivation really high for today. And also, this is your first year of the World Health Summit. So we do understand that there are palace sessions that are currently ongoing, and we feel really thrilled that you chose us today to hear us. And thanks to all the panelists who are patiently waiting here and to share their insights with us today. So this panel is going to explore some of the economic insights, some of the messages around, and specifically evidence-based messages around equity, both in terms of identifying what are the key gaps and also identifying what are the key solutions around it for fostering resilience in vulnerable population. I think this panel and the discussions that we're going to have today is really important because in 2025, global leaders, be it public leaders or private leaders, they are tasked with challenges of reviving the growth of the economy, currently in a very highly volatile environment, When I say volatile, because there's economic crisis going on at one end, we are in the edward of climatic crisis on the other, and in between, governments are also dealing with internal and external conflict. It becomes extremely crucial to ensure that the vulnerable population, they are not going to be exacerbating in terms of their inequities and inequalities that they face already within this population in the face of all of this, challenges that we're currently facing. Evidence-based approaches become really crucial when we talk about equity for two reasons. First of all, the data and insights, they help us identify where exactly are the inequities, what exactly are the inequities that the people are facing. More importantly, also help us in identifying what are the key solutions which are effective in overcoming those inequities. And at the same time, evidence-based approaches, they also bridge the gap between theory and practice to help identify where exactly are the inequity gaps. And how can we ensure that when we talk about solutions, it makes sure that the voices of the people, the vulnerable people, they are heard back while these solutions are being implemented and also when they are being designed. Today we have the experts from various organizations, and also they bring expertise across the various sectors. And today we will be trying to understand, first of all, I just want to mention that we are not going to be listing down solutions today, but what we are trying to achieve here is to identify what solutions exist and how can we ensure that they are scalable in terms of collaborations, and how can we work together in making those solutions being talked about and being implemented to a wider audience. So that's the aim that we come together as a panelist today. We have five panelists today with me, including myself. I will be talking more about the evidence-based approaches and what evidence exists, where exactly are the gaps. We have fellow panelists, and I'll introduce and invite their talk as I call on to invite them while they are giving their talk. And the idea was that each of us will be talking about our areas for 5 minutes. We will have some guided questions, and then we might be able to take some questions if we get more audience by the end of the session today. I'm going to start with the quick overview of what I wanted to speak on. Okay, so whenever we talk about, equity, vulnerable population, I think one thing that does comes into our mind is specifically if we are talking about solutions that are related to settings which are already resource constrained, is what are the effective solutions that have been, implemented or have been contextualized elsewhere that we can probably use and start implementing in our own settings. So today I'm going to be talking about three important evidence-related resources that I worked on, and to help you identify where exactly is the evidence and what are the gaps around it. So what you see here on the screen right now is a tool which is called as evidence and gap maps. So evidence and gap maps, in a very layman language, if you understand, it basically helps us visualize the evidence on a topic, on any sector probably. It could be related to health, it could be related to equity, for example, people with disabilities. It could be related to women, children, and adolescent health. It basically is a first step in bridging the gap between academician and people who are actually sitting at the policy spaces or decision-making spaces, or probably the managers, because it basically helps you in a very simple language visualize what exists and where exactly are the gaps. These have been found to be really effective for funders, and we have really good case studies where funders have actually used these kinds of tools and have developed evidence using these resources already. So the different bubbles that you see here, it basically collates about what quality of evidence it is. And when I say quality, it basically means the confidence that I have in the findings of that particular research. So when we say quality, it basically helps you assess how reliable are the findings of that particular evidence. So the one which you see in the red, will tell you that it's a low quality evidence. The yellow areas is basically helps you identify it's a medium confidence, and the green one will tell you that it's a high confidence area. The matrix that you see, basically the rows and the columns, it basically helps you understand the interventions and the outcomes. So whenever we implement an intervention, it has to affect certain outcomes, and that's exactly what this shows you. The map snapshot that you see here is of an evidence and gap map that we did way back in 2019, and this has been updated a number of times, I think 3 times already. This was on people with disabilities, and it includes everything under when we talk about intervention. So it includes health intervention, livelihood, education altogether, and all the outcomes are currently structured around this. So you can see that, and this evidence and gap map was solely for low and middle income countries. So all the evidence that you see here can be actually, see how effective it is and how confident are we in terms of finding and can be implemented. So this particular evidence and gap map included 117 systematic reviews and 170 impact evaluations altogether. And the good thing about this evidence and gap map was that it actually led to creation of number of evidence product as a result of it. So the whole idea of evidence and gap map is not to create something which is completely, unique or completely isolated, but to use that evidence and gap map to create number of other resources. So this map was then used to create and identify areas where we did not had any evidence synthesis, for example, systematic reviews, and 4 systematic reviews were conducted as a result of using that. And more importantly, in terms of policy, is that those systematic reviews, because when we talk about policy decisions, it should be based on not single set of studies, but it should be used based on something which is called as pooled evidence. So these pooled evidence are basically called as systematic reviews in layman languages, or for some people it is usually also very easy to say it as literature review, which is not the same as systematic review. So all of these evidence that were out there, for example, 117 impact evaluation, 117 systematic reviews, we use them and identify where exactly the gap exists, which existed around education, livelihood, social inclusion, and empowerment. We conducted rapid reviews around this. This was then converted into systematic reviews, and now they are being used to create something called as disability evidence portal. Now, this is something which is really key for policy makers, because it helps points very clearly that what intervention is effective, what is the cost of that intervention, and in what settings that intervention have been used. So this is one of the key tools which have been used previously, have been used very widely for policy decisions. I can't say policy decision because it's a very tricky and a very, nuanced area where you actually need a lot of, understanding, but these have been used for funding decisions and have been used sporadically by members of the FCDO and other funding organizations to create their own advocacy around this evidence. So, as I was mentioning, that we conducted 4 systematic reviews around using that evidence that we created in the evidence and gap map. So one of the key bits about that you see here is that this systematic review that you see on the screen is of a review called as social inclusion for people with disabilities. What we wanted to understand that are there effective interventions available that tell us that certain interventions are effective when we talk about including people with disabilities into the public or into the community or into the relationships. So we conducted this systematic review. We included 25 to 26 studies. Some of the studies and had information where we could use that to pool the information. And this is the result. So what you see here is, it might look a bit tricky, but it's in very simple languages, it is called as meta-analysis. So the individual lines that you see here, they are individual studies. The triangle that you see here is basically the pooled evidence. The overall, what it tells you is that the interventions that are used for social inclusion, they are quite effective and they have a very large effect. So you can see it from 0.73, the effect sizes. The overall picture that I wanted to show you when I talked about this is that this particular review shows that the interventions that are out there, for example, social and communication skills training, interventions that improve relationship between people with disabilities, that are found to be very effective overall. And this is all coming from low and middle income countries' evidence. Similarly, this is another forest plot that again shows us the interventions. They are effective in improving the social and communication skills of people with disabilities. There's another evidence and gap map that we did. This was funded by PMNCH, which basically included the target population for this was women, children, and adolescent health. And this was entirely on economic evaluation. So, it basically put a cost to the interventions, so whether the intervention are cost effective or not. And again, this again is a very good resource when you talk about evidence because it included 181 economic evaluations from Southeast Asian region alone, with 62 evidence coming from India altogether. And most of these India evidence, that out of 62, 80% were high confidence evidence that was coming from here. And 19 of these records were explicitly focused on vulnerable population, for example, people with disabilities and internally displaced population. The idea for showing all of this evidence is that when we want to base policy decision, a lot of time policymakers, they struggle with thinking that where is the evidence? So this is basically the evidence that exists. There are organizations, there are resources that are out there where you can find this kind of evidence from India and South Asia alone. And now the further discussions with my colleague, they are going to be talking about what policies are being built around people with disabilities, vulnerable populations like women and children, and what evidence are they using when they talk about policy decisions here. I'm going to stop here, and probably we can take it forward when we go through the talk.
I like to thank Ashrita Saran ma'am for her valuable words and insights and her precious time. I like to welcome Akshay Sethi ma'am to deliver the presentation.
Hi everyone, I'm Akshay and I'm the founder of Sense Kaleidoscopes, and we are located in Bangalore. I'm just waiting for the presentation to come up, so just give me a second. Thanks, thank you very much. Just to set some context, we are the first art college in this country specifically dedicated for those with autism and Asperger's syndrome, but we essentially work primarily in the autism area. What I'm showing you is a very quick snapshot of the different tasks that we actually have put together in the last few years. We are a high skilling center. We develop curriculum. You're looking at artworks created by my students anywhere between the ages of 13 and going up to 30. Most of the art that has been created is created by students on the spectrum who essentially were told that they could not work with fine motor skills, or they did not have the cognition to be in a regular setup, or do not have the regulation or the social emotional skills to actually be integrated into society. The process in the last 10 years has been about taking these individuals into a nurturing setup, working with environments that work on attachment-based theories, focusing on what would work for them, essentially catering specifically to their unique needs, to their unique neurology. And the result is in front of all of you, as you can see. As a high skilling center, we also went into essentially working for access to arts, a space in India that is not given too much significance or importance. And the possibility of using the arts not just to develop a skill, but to work with cognition, to work with social emotional skills, to work with an awareness of the environment and the world that exists around them, for them, in whichever way. You will see that each of the artists has a very unique and distinctive style. So despite the fact that they all have gone through a similar curriculum, there is an expression of the individual that is being put out over here on the screen for you. I want the work to speak for itself. You will be able to identify the different styles by just looking at the artworks. And that's essentially where we work. With the young adults, space essentially where there are no solutions. All of the artists that work with us are showcasing nationally and internationally, and to further their livelihoods, we also ensure that we position their works in the disability artist market in a certain manner so that they are able to understand how the livelihoods will come together in this space. That's essentially what we do, and that's my time. Thank you.
Thank you so much, Akisha. That's really interesting.
Thank you, ma'am, for your speech. Now I welcome Kiran Modi, ma'am, on the stage.
Good morning, everyone. And first of all, I must congratulate Campbell and Global Development Network to participate and help us participate in such a big gathering. I mean, gathering means all the halls, and many sessions are going on. So it's a good opportunity. And I'm glad that the students of NMIMS also there. So very good. So actually, you know, Udayan Care is a 31-year-old organization, and we have several programs. But I'm going to be speaking about only the one that are addressing the alternative care or family strengthening. Alternative care would mean children who do not have parental care, who do not have parental support. So our first program for family strengthening and alternative care models is called Udayan Ghars. These are residential homes for children. There are 11 in 4 states. Then residential aftercare. When the children become 18, they have to be promoted to aftercare. They cannot stay with the children. So there are 4 residential homes. And we always believe in researching and finding out more data, what is happening, what are the gaps. So we did a study way back in 2018, which was published in 2019, to look at the aftercare possibilities for youth who are coming out of children's homes. And we realized that there was such a big gap. Children were not getting anything, and you become 18 and you go out and you be on your own. So that's when we started this aftercare outreach program. So these are youth who are coming out of different children's homes, and we have already established in 6 states, and 650 youth are getting all kinds of support. I mean, imagine if you were 18, what would you do if there was no support? So we are trying to do that so that they can also thrive in life. We also realized that, you know, communities where the resources are low, the awareness is so meager, and the people really need to be strengthened so that the children don't get separated from them. So with this idea of prevention and those children who are in the institutions, how can they be restored back to their families? We started working in families and communities, and we are covering 3 districts of Delhi right now. It's a very busy slide because I was told to bring only 1 or 2, so don't worry. I will just say across all these programs that I talked about, there are these legislative frameworks which guide us. Juvenile Justice Care and Protection of Children Act 2015, which talks about all the standards of care that a child must be given. Mission Vatsalya, which goes a step further. It's a scheme, but it talks a lot about disability. And also Rights of Persons with Disabilities Act 2016. If you look at on the top where I've written in the Udayan Ghars, when we started 28 years back, there were children only of, you know, disabilities. There were maybe 2 to 3% amongst the whole number of children that were given to us, but at this moment it stands at 40%. So more and more children with disabilities are coming into children's homes. But our first commitment to UNCRC as well as to Indian government is children should be in the families. And there are so many challenges which I will talk about in restoring them back into families. So NFHS 5, which was 2019 to 21, the data they covered, they talked about disability prevalence of 93%, with 5.11% of households at least having 1 person with disability. So disability is rampant, and we really need to recognize in the communities and in the children's home, as I said, going by our children's home, and I'll be giving you data in the next slide, where we did 33 children's homes study, and we found 55-60% children with disabilities and with no proper planning or rehabilitation plans for them. So when you want to integrate them, reintegrate them back to the families, because children who have stayed in a children's homes, and when you want the families to claim their children back and take them back, there are socio-economic, cultural and environmental barriers. Socio-economic, because the families are already poor, reeling under poverty, and socially also they are not advanced, so they find it very, very difficult. Culturally, children have gone away from the culture. They've been raised in a children's home. So when they come back, it's so difficult for them to get adjusted culturally, food-wise, or even, socio-emotionally. Environmental barriers, we know that all the time environmental issues are there, which is again making it very, very difficult for families to take their children back. How do you prevent children who are already in families, that the families don't disintegrate and children go into institutions? So we are working, twofold. We are working on children in institutions, how to restore them back with families and those with disability. And also we are preventing families to give up their children, that there is no way I can look after the child, and they want to give up the child. And then the child lands up in a children's home. So these are the two ways we are working. And one can understand when the child goes back to the family, what a burden it is for them, where they have very limited access to support. Even for school admission, we found, it was so difficult when we started working in communities. The children who went back from the children's homes, they didn't have their Aadhaar card right, they didn't have a bank account, they didn't have any other identity papers. Actually, children in an institution, they get culturally lost. So how do you bring their culture back to them? It's a lot of support services needed, and there is a stigma in the community about children with disabilities, and they feel excluded. They don't get that kind of a support, and there are so many systemic and policy gaps. When I talk about these legislative frameworks, you can understand, Juvenile Justice Act and Rights of Persons with Disabilities Act, they should be speaking to each other when they are dealing with children with disabilities. And there are so many discrepancies, which are all there, on papers you will also find. Then awareness and accessibility gaps. Government says that there are so many schemes, but what kind of awareness the communities have? That, okay, for my child with disability, I can access these schemes. And the problem is awareness is not there, and accessibility. How do you fill up the forms after forms, keep on visiting when there is so much of stress at home? It's very, very difficult for them. And the worst is there is no data available even in childcare institutions, how many children with disability are there. So we really want to start a big study on this based on the study that I'm going to be talking about in the next slide. So how do we create, for whatever we work with, we try to create evidence through vulnerability mapping. We have done it in MP and in Bihar and in communities in Delhi. So what kind of vulnerabilities are there which can persuade the family to give up their child? So this vulnerability mapping is really helping. And then, feasibility mapping. If we restore a child, will the family be able to look after if they get some added support? We have developed toolkits like mental health and family development plan, youth development plan, IDP is individual development plan, and each format is filled up in participation with the family. Targeted support is for children and families with special needs. And we try to align them with education, health. We try to get them disability cards, pensions, livelihood, linkages to welfare schemes, employment and entrepreneurial venture. We've been able to get many of these women in the community who have disability to get their own entrepreneurial venture started. There's a lot of mental and physical health interventions. We try to do parenting skills upgradation continually. We talk to in groups and individually, and we collaborate with the child protection functionaries, integrated schools, healthcare, allied services, donors, and volunteers. And there is a continuous evaluation process. So we've developed this circle of care and protection. There are 10 domains under which each family, each youth, each child is assessed on a quarterly basis. And we can see what's happening. There are, like mental health, there is education and vocational training, child self-awareness, community and social connection. It's so interesting. We've been doing this genome theory with the communities where we talk to them, who are the people you can depend on. They say nobody is there. When we sit with them for 2 hours, then things start coming out that there are possibilities of going ahead. So this is a small mapping study we did in the CCIs in Bihar, and we realized no structured educational or vocational training access was there, lack of specialized resources like therapies, trained staff, long-term institutionalization, which is not good for anyone. And what does it implicate? Children with special needs in CCIs experience chronic neglect. They are institutionalized beyond legal age. They lack transition support. Urgent need for robust state-level transition is needed. Frameworks which can support children and youth with disabilities. Thank you very much.
I like to thank Kiran Modi ma'am for her golden words, and I believe that everyone will recognize this topic as important. Now I welcome the Varnovili sir on the stage.
So good morning, one and all present here. I'm truly honored to be here at the World Health Summit. I thank you so much, Dr. Harshita Saran and Campbell South Asia and the organizers. So I'm from Amrita Vishwavidyapeetham, an academic institution from the south, that is Tamil Nadu, and we have campuses across the country. The new campus is at Faridabad, and I am based out of here, and I'm representing the School of Social and Behavioral Sciences. So, as Ashrita said, we are not here to talk about the solutions, but about best practices which we have come across. So, I'd be sharing some of the best practices which I have seen from my experience of the past 1 decade. So, I have worked with various organizations and various stakeholders, right from the tribal areas of Wayanad, Nilgiris, and remote rural areas in Tamil Nadu, Andhra Pradesh, and Odisha, such as Raigada, and also Jorhat in Assam. So, from my experience, I'm here to talk about how we can strengthen health equity through community-driven measures. So before that, I would like to highlight few data points with respect to NFHS 5, and then with that we'll be sharing few experiences along with that. So if you see, according to NFHS 5, 35.5% of children under 5 in India are stunned, reflecting chronic undernutrition. And this number is even higher in tribal dominated areas such as Madhya Pradesh and also in Jharkhand. And the next one is with respect to anemia among women. So nearly women aged between 15 to 59 has increased to 57% with higher rates among rural and tribal populations. Anemia. Then when we come to pregnant women, only 23.3% received full antenatal care, which includes 4 ANC visits and iron folic acid tablets. Then when we come to differently able and especially women, the literacy rate among differently able women is just 45% when we compare to the general population of 72%. We should not see this as just numbers, but if you see, they are structural exclusion that which over the period of time we have made. So now I would like to highlight a story that which I've seen during my visit of time and motion study, which I was part of, which took place among village health nurses in Nilagiri district. So Nilagiri district in Tamil Nadu is a remote district where you have nearly 3 tiger reserves, and it itself is a biosphere reserve. So this particular village is located in Kunnur, and when we approach this particular VHN, I don't want to name her. This Kunnur is a place where you have completely tea estates. The entire forest has been, vanished. They are completely tea estates. You have corporates and various other small estates as well. And this particular VHN, she travels. When I say travels, she walks, literally walks 7 kilometers up and down, total 14 kilometers every day to visit these estates. And these estates have migrant workers only. They are not, workers or people live in this particular region. Most of them, or when I say all of them, are from northern part of the country, and they live in a very unhygienic situation. They don't have access to healthcare, and children don't have access to education. And this particular study took place in 2022 after pandemic, and she keeps visiting every day, and during every visit the estate authorities doesn't permit her, they don't allow her inside, because she will collect information and it will be fed into the system. So with with consistency, nearly 2 years, she was keep on walking every day, and she made sure the authorities see her every day. And finally, with her work, the estates started having their own medical system, so that they are having in par with all the indicators. So then they started slowly coming into the health system of our state. She ensured that every women there are registered into the PICNI system, that which Tamil Nadu government is using. And she also started, because of this intervention, they also started bringing in the data of teenage pregnancy, because most of the women there, it is child marriage. They get married in before 18 years of age, and this data of teenage pregnancy is also brought in. And when I say she walks for 14 kilometers up and down, it is not just a terrain of steep walk, but remember that it's a tiger reserve. And if you see, there have been several situations where the workers and women have been attacked by bear, uh, cheetah, leopards, and also sometimes tigers. So it's such a extreme dangerous situation in which this particular VHN was doing a duty. And when I say it is not, this is not the rarest one, okay? There has been hundreds and thousands of such workers would be present in this length and breadth of the country. But this country is such a diverse and vast, we sometimes miss out such important souls. So because of her intervention, right now in Nilgiris we have the database of women and children. Otherwise, no, especially in this particular block, and it was even registered with the government. So this is something that which I really wanted to highlight. And further important thing is, when I would like to share my experience of having COVID, and I was treated in Kerala primary healthcare system. I am the first among my organization to get infected by COVID, and in the first wave itself. And you know how the first wave was, and because we are in this particular generation, is first time we are getting engaged to that particular pandemic, and it's very new. But government of Kerala, the health system in Kerala handled it very well. They ensured that every individual in that village, in the municipality, got healthcare, food, and shelter. I was treated in the primary healthcare system, not in a private hospital. I was staying in one of the hostels. It's a girls' hostel in a government college. They ensured that we get proper food, and every day a counselor from the telecounseling unit of the municipality calls and ensures how I am. And it was in similar cases, whoever were with me from nearby villages, they also received the call every day. So how this change is happening in Kerala? It is because of the local self-governance, LSG. It is very strong in Kerala, and when I say why so, and the difference, if you see, for me, I recently migrated from south to Delhi. Now I live in Faridabad. I could see the roads, potholes, and it's not laid proper. And it's been a year, still it is the same. But if you come there in Kerala, if you see a pothole, the next day or in 2 days it will be changed. It is not because the government is, prompt. People are prompt. People ask. If it's not changed the next day, everybody will be in front of councillor's house or MLA's house. They cannot take a step forward. So it is people driven. So what I'm trying to say is, just to conclude my opening remarks, with respect to community, driven, it is people, and people need to be empowered. So in due course during the discussion, I'll give you more insights with respect to that. Thank you.
Thank you, sir, for your precious time. Now I'd like to welcome Ankur Mutreja, sir, on the stage.
Well, thanks very much to the organizers, Campbell South Asia, for having me here on this esteemed panel. It's fantastic to hear all the insights from you all so far, the work that you do to address the vulnerable populations and improving the access to them. I'm Ankur Mutreja. I'm the Director of Strategy, Partnerships and Communications at PATH. PATH is an international organization, international NGO that works in about 70 countries around the world. So India is one of them. We are the largest office of PATH, India office. And India office actually caters most of the Asian countries as well. We are also a 50-year-old organization. We work in the health equity space. So everything and anything that requires equity on the health front, we have either done it or we are thinking about it at the moment. Just to give you some examples, our mission statement really is to improve the equity and access through innovations and partnerships. So we are really big on using the technology, using the innovation to improve the access to the healthcare services, also improving the general health and well-being of the population, whether living remotely or even in urban areas. There are issues of people getting access to the healthcare services. Just to give you some examples, and I think there'd be an exciting panel discussion after the opening comments. We work across the health security landscape, right from looking after the immunization of children through the UIP, Universal Immunization Program of Government of India, or the EPI expanded program of immunization, which is followed globally. We've helped most of the countries around the world in implementing their immunization schemes in the best possible manner. Not just in the immunization, but also upstream of that, we've helped manufacturers and governments around the world do the R&D and clinical trials, and also then the follow-up surveillance for vaccines and other therapeutics as well. So we've provided end-to-end services in improving access to vaccines. Similarly, on the diagnostics, if you recall, during COVID, there was a huge crisis when diagnostics were quite scanty, surveillance was not happening, so we helped most governments around the world in doing that surveillance and diagnostic implementation to the best possible, in the best possible manner. And then also to give you an example from other end, we've also helped Government of India implement its Anemia Mukt Bharat program, under which India government is supplying fortified rice to address micronutrient deficiencies and address anemia to about 800 million people on a regular basis. So we've been a key partner in that program for Government of India, not just in improving the supply chain of the fortified rice, making sure that they get to the people right from the manufacturers where the fortified rice are prepared, but also in making sure that the quality of that is maintained. But because I think access is not just about getting someone something, it is about ensuring quality of the products, of the commodities as well. So I think that's also something we've focused quite heavily on. Then also to cite some examples on access, there are a lot of communities that feel not necessarily comfortable visiting healthcare services, primary healthcare services in various districts as well. So we've helped various government agencies, manufacturers, private, public, etc., in developing self-testing kits, so that some people who do not feel comfortable going to the health services for whatever reasons, either they're not empowered or they have some sort of restriction, or the problem is something that they want to keep it discreet. We have helped develop self-testing kits so that they can use those, learn for themselves that they have a problem, and then raise a trigger to the healthcare services that they need help. Otherwise, they would end up just being the sufferers. So I think along those lines, I think there is a discussion coming up as well. I'm really looking forward to it. But PATH is really committed on ensuring the equity and access to health to anyone and everyone, whether remotely placed or even in the most urban parts of the world. Thanks very much.
Great. Thank you so much, all the panelists. This was really interesting to hear the different perspective and the different solutions that are being talked about, implemented across organizations and across the various sectors that we're all working with. I think I'm going to start with you, Akshay, because you showed us some of the amazing artworks done by these amazing people out there. And if we talk about evidence in that sector, I think one of the key gaps that is there is that majority of the interventions that are being talked about or research are around to improve people with disabilities. So it's mostly around personal areas, how can you improve your communication, how can you improve your skill. But nobody's really talking about the community level areas, or maybe the policy level areas where you actually talk about stigma reduction, or actually talk about these wonderful things that people with disabilities have the capability to do and nobody talks about. So probably from your experience, can you talk about some of these successful examples of disability inclusive policies, or that you have seen in your organization, in your probably within your working experience, that have actually worked well for people with disabilities in terms of their empowerment?
Hi, okay, it's working. Thanks for that, Ashita. And you're right. I think when we are talking about autism specifically in India, we are always talking about what is not possible. What are the challenges in that community about how they can engage, how they can work. A lot of chat is about development, and we are looking at early development primarily. Most of the work that happens in the country for autism is early interventions. What can we do in that space? What is the immediate thing that we can push in? And we have somehow lost track on what should then continue so that we can create sustainability with development. I specifically pulled out those images and I put them outside because I want everybody to focus on what is possible and not what is not possible. So I think a lot of the, some of my experiences with working in this space is even the parents, they also do not have the idea or the understanding of the possibilities, because they're listening to a lot of what is not going to happen. When we were working, then we were saying, okay, we're going to work with young adults. We were talking initially we were looking at behavior complications. We were looking at how are we going to cope with the fact that a child who is and a young adult who is 20 years old but is functioning with the cognition of a 6-year-old. How do you manage somebody like that in an environment? Whether it is an educational environment, whether it is to do with benefits for health, whether it is to do in a family space, in a community space, how do you manage somebody with that? If there is communication impairment, there is sensory impairment, then what happens at that point in time? Looking at all of these things, I think the target for SENSE became, right, let's start putting in interventions that can help us work at the policy level so that we can put an implementation plan in place. What is the way that we can say, yes, there is this possibility. We also know that autism globally has created some examples that people actually look up to, that the possibilities are there. Then why is it that we are not able to do it over here? That became the core focus for Sense. So whatever we did in this space, and it's really funny because we started working with young adults, and then we realized that, okay, so there is a huge gap in cognition, which means that an individual cannot be aware or cannot understand their environment. And Kiran ma'am was talking about it. This gap, the cultural gap, the lack of awareness of how things work around me can lead to a lot of imbalance in an individual. And I think it shouldn't matter whether that individual has autism or not. It'll happen to you and me as well. We have to bridge those gaps. So we started with building curriculum for the arts, and of course it's therapeutic. We understand that we wanted to build motivation. We wanted to build self-worth. And if I love what I'm doing, if I'm really keen on what I'm doing, then all of these things happen like a byproduct of that process. But the big challenge for us, especially when we work in the space of autism, is the behavioral challenges. The integration becomes extremely impossible. So we said, all right, if the missing piece is that they don't comprehend, and if there is that lack over there, it's because of the primary and the secondary education, we went backwards and we started looking into the mechanisms that we can build programs there so that we could enable them in those formats. A lot of work is happening. We are in the process where we are trying to validate that work. We understand that autism spectrum disorder is very varied, very diverse, has too many different formats. So I think we are in that space where we are trying to put a particular design, a form to it, so that it can be implemented easily. And that's where we are.
Thank you so much, I shared, really helpful. So Dr. Kiran, I'm going to come to you since we're talking about implementation here. So you talked about children in care. So given the systemic barriers identified in implementation, which talks about fragmented services, or what are the most effective strategies or model that you have seen that bring together health, education, and child protection sectors together? Probably if you can shed some light around it.
Yeah, thank you so much. In the as I said earlier also, in the children's homes, children become used to a certain way of being groomed. But when they are returned back to the families, it's very, very difficult to maintain that same standard. So children feel disillusioned, families feel burdened. So at that time, a lot of support, although the policies are there, access, but the problem is how to access those services for the families. So a lot of work needs to be done there. And, children who are in care, as I said earlier also, the number of children who are coming into care with disabilities are increasing day by day. While the government is insisting a lot on children being restored back to the families and get reintegrated into the communities, it's becoming very difficult. More and more families are just giving up their children. So a lot of work needs to be done, and there are a lot of policy gaps. One study that we did, earlier in 2018, which I alluded earlier also, we had covered 5 states and more than 500 young people, and who went out of these institutions. And the idea was to find out more and more children with disabilities. When you become youth, when there is no childcare institution, when you are not able to be restored back to the family, then what happens to you? And where are you? And you won't believe, in our 1 year's research, we could hardly find people with disabilities who had gone out of these institutions. It looked like simply they vanished. So we realized that it's very, very important to work with them while they are in the childcare institutions, so that proper systems and policies can be made available to them, so that when they migrate from childcare to the larger world, they are also able to thrive, like any other normal person. We also realized that, children with, especially with intellectual, impairment, physical impairment is one part, but the intellectual impairment is very, very difficult to handle, and especially girls who don't have any family. So after 18, then what do? Even if you prepare them for jobs, repetitive kind of jobs like, packing or, storing things and washing utensils and those kind of things, we've been able to manage some of our girls to get into factories, and they're doing there. And we've been able to give them assisted living. But the world is fraught with challenges for them. to be on their own. So I think government really needs to look at it. Our study actually paved the way for many new reforms which came into the policy. So I think, for disability also we need to do a lot more than we are presently doing. And I think it's really the call of the day.
Thank you, Dr. Kiran. That's really helpful. Varanan, you talked about I think two successful examples of community-led or say individual-led probably interventions. Can you talk about how these, and also talked about self-governance, local self-governance that working really successfully in Kerala. Can you talk about how these could be scaled up further and made sustainable? What Kerala government is doing great, and what other government might probably want to learn from it to make it scalable.
Yes. If you see, the Panchayat Raj system is same for all the states. But what is unique in Kerala and how they operationalize this is, they started implementing the policy from paper to place. If you see, we have this village health, sanitation and nutrition committee that need to be established in every panchayat. And it is owned by the Anganwadi worker, ANM, ASHA workers and VHM. Because they are the frontline workers and they are the people who know what's happening in every household of that particular cluster. Let's say we have, with respect to differently abled or early detection matters a lot, right? So these people play a big role in identifying them and bringing them into the health system. But what happens is very few does them, and most of them don't do it because of the other burden which they are having at home and also at the community. And how Kerala is doing this is because of sensitization of their rights and the duties. And they were able to scale this up with constant monitoring and evaluation among not just with the authorities, but also with the frequent social audits that which included with the community as well. So this is something that which enabled Kerala a lot, but whereas I don't say that in other states it's not happening, but it happens in one or two villages or one or two municipalities, but it's not scaled up completely. Maharashtra, Tamil Nadu and various other states also have a very robust system. But when it comes to implementation, there comes the challenge. Just I wanted to highlight one more thing. If you see, when you get, there are women-led panchayats, there are women panchayat leaders, but you will see them governing only in Kerala. When you go to even some part of Tamil Nadu or Andhra and some other states like Haryana where I have visited, women panchayat leader will be there. Along with her, the husband also will be coming. Every decision is taken by the husband, not by her. Just imagine how the man who is dominating her whole wife will be able to do, ensure the health well-being of the women and children in that particular panchayat. Even she's an elected representative, her own rights are curtailed there. So this is the situation. So in Kerala, people ask, women ask, she asks if she's not allowed, she demands and she gets out of it. So that's the beauty there. Thank you.
Thank you, Varun. Ankur, so you talked about how to reach communities. You also gave an example of an innovation like self-care kit that might help bridge that gap. Can you talk about some of the key barriers from your experiences and probably other innovative solutions that you have used to bridge the gap between the community, and how important, and I would ask this to everyone, has been the role of evidence in any of that areas?
Well, thank you. I think barriers have become quite clear, I think, from all the other panelists as well. I think with regards to what PATH does using technology, so for example, the advent of digital health, we have improved the shaping of the technology in such a way that telemedicine has become more widely available. So there are populations where health services don't reach, or populations don't want to go to the health services. There, having that magic of telemedicine and getting the same quality of service that somebody living in a metropolitan city would be able to avail is what we are helping the government systems achieve. And then with regards to access issues that may be because of supply chain problems, as we saw during COVID, the remotely located populations were the last to be vaccinated. So we've made sure that there is a supply chain available now, so that if there is another crisis in future, the remote populations are also served at around the same time. And also, it's not just about the geolocation of people most of the time. So for example, even when vaccines, again using the example of immunization, when vaccines are given, generally women who are likely to get pregnant or are pregnant or are lactating mothers and children are the last to get immunized. And that is also something we are trying to change in the regulatory processes, that yes, if there is a risk of involving that community or that section of the population in the clinical trials, the sponsors of the clinical trials or the owners of the clinical trials should ensure that as soon as the drug or the vaccine is approved, they do a quick effectiveness study on that section of the population as well, so that they are not the last to get vaccinated, because they are equally at risk, or in many cases they're actually more. Children are more at risk. Pregnant women might be more at risk. So we've been using technology. On the supply chain front, to improve, most of the vaccines, for example, are cold chain requirement is there. So we are making sure that there are cold chain systems now that would not require very arduous planning, and there'd be solar-powered cold chain boxes, etc., that could be used to supply vaccines to the hard-to-reach populations. And then, as you also pointed out, to the self-testing kits, etc. So making sure that people who suffer from issues such as HIV, which may be stigmatic, or people who may want to, let's say, get access to menstrual hygiene products that they may feel stigma about, especially in the rural communities, etc. We are making it easier through the health systems approach to ensure that they get access, because that also then empowers them to raise their voice and get access to the contraceptives as well. So I think we've seen that there is a link there as well. So I think there are various ways that we are approaching the addressing of barriers that exist. But clearly barriers on quality also exist. A lot of, again, using the menstrual hygiene products, for example, supplied in the rural areas are made in makeshift cottage industry, which are not up to the same standards. And by the way, there are not even international standards on menstrual hygiene sanitary napkins, for example. So just to cite some of the examples, so we are working very closely with different foundations, World Trade Organization, Sanitation Hygiene Fund, et cetera, to make sure that there are international standards set, so that the movement of such kind of critical products can also be made, because those things then ultimately also impact the outcome of the pregnancy. In many cases, preterm births happen because of diseases, et cetera, or the microbiome changes that take place. So thanks.
Great, thank you. We do have good audience now, so it's great. But before I open up for the audience, if they want to ask us, okay, great, please go ahead.
Thank you so much. My name is Smita Sadasivan. I am from Tamil Nadu, and I am part of Disability Rights India Foundation and also Disability Rights Alliance Tamil Nadu. Mine is not really a question but a comment. Like we did a study on direct cost to disability, whereas we took all the 21 disabilities and studied how they are spending a lot, not only for on the health treatment, but the support systems around the health treatment. Like for example, if you have to access a health facility and you have to take a public transport is not accessible, so you have to take a private transport, which is more expensive. So like that, and how if a family member have to be a caregiver, then the family member is sacrificing their job, they are dropping out their job, and then it is again a financial loss. And similarly, my condition is multiple sclerosis. So for multiple sclerosis, it is not only our disease modifying treatment, but the other aspects like the catheters or the diapers or rehabilitation aspect. Like rehabilitation is not covered within the health segment, within the health treatment, or whether it is you say Ayushman Bharat or any health insurance for that part, it is not covering all these rehabilitation aspects. And varied rehabilitation requirements are there, like take for example physiotherapy, occupational therapy, speech therapy, psychotherapy, hydrotherapy, vision therapy. So lot of rehabilitation requirements are there. So when you consider all these holistic aspect of health and also the support system required for health, then we are expected to spend, of course we are spending a lot of cost. And how can we look into the cutting of this cost? If when UHC is talking about no out of pocket expenses, and here without these kind of expenses we are not able to get health equity. So what would be your recommendation on that? That I would like to learn. And since you mentioned about the COVID procedure processes, and in Tamil Nadu, what we did is we advocated the disability segment groups. We advocated with the disability department and the Chennai Corporation, and we came up with doorstep vaccination for people with disabilities, especially people with autism, people with elderly also, and their caregivers, so that they need not go out and get more infection. So it is to get COVID vaccination in a safest environment. So this we actually piloted in Tamil Nadu. And yeah, regarding the cost, because we did a study and the study literally showed a huge out-of-pocket expenditure from persons with disabilities. So I would like to know your thoughts on that.
Thank you so much. This is really a great question.
I'll take one part of that because I understand the autism space and I know exactly what you're talking about, the cost. I feel that at the present moment, education and health are compartmentalized in two different boxes, at least for autism. That's why I said I'll probably be able to answer a part of it. When you're looking at something like that, then it's very important to understand that we need to remove that compartmentalization and try and find ways to kind of bring them together so that that synergy will support what you are talking about, the cost optimization. The work that we do also hinges greatly on the community aspect of things. Now, with autism, we understand that there needs to be consistent rehabilitation. There could be regression, which means that there is a need for more aggressive rehabilitation. And going back into creating sustainability means, again, consistency and the competency to do it. I strongly believe that as far as we don't start thinking about solutions where we bring those two aspects together and we say education and health both have to come into one box, and we don't start training people, we don't start implementing things in those ways, cost optimization is not possible. So looking at it differently and thinking about solutions in different ways is how policies change or how they should change, because then you're literally going and working with the needs of the community. The entire disability movement is anchored in nothing for us without us. I'm neurodivergent myself, and I very strongly believe that you can't do this compartmentalization. You can't say, I'm going to have an OT and that's going to happen over there. I'm going to have speech over there. I'm going to have sensory integration here. No, education will have to bring it all together, and health will have to come into education. That's what I think.
I think you definitely made a great point. I think, and also Akshay mentioned the importance of education. One of the projects that we are currently doing is improving the pharmaceutical literacy. It's not necessarily addressing the disability to start with, but a lot of wrong drug combinations can lead to a lot of different kind of disabilities or diseases or conditions. So we are running a program where we are assessing the pharmaceutical literacy levels in the community and educating them on, how they can evaluate whether the prescription that they have received from the doctors, which in many cases may be influenced by the medical representatives that would offer them all sorts of incentives, but that may lead to very disabling conditions for them. So that's one example. Second, I think I think the starting point of addressing anything is diagnosing it, and we are helping Government of India, for example, set up the comprehensive primary healthcare systems, where, for example, the stethoscope wouldn't just be counting the heartbeat or lub-dub situations, but it would also be able to tell whether the patient has rheumatoid heart disease, rheumatic heart disease, etc. Similarly, non-invasive hemoglobinometers, similarly cervical cancer screening, etc., right at the primary healthcare level. So enabling hard-to-reach populations and communities to get access to these tests, which would otherwise require a tertiary setup for accessing it. I think we're enabling that, and therefore also reducing the out-of-pocket expenditure that you talked about. Thanks.
Great. I would just like to add a suggestion here, since you are looking into the virtual like e-Sanjeevani. E-Sanjeevani is a great program by the Government of India, whereas it is not reaching people with disabilities or people belonging to vulnerable communities, because they are not aware of it. So if we can, if PATH can foster this with the Government of India to enable reach information about these schemes, these brilliant scheme programs to vulnerable populations. More awareness is required, because wherever we have worked, people have started accessing, but many people don't know about it. So if we can increase
Thank you.
awareness.
That's a point well noted.
Thank you.
Very quickly add before I give it to Dr. Kiran. So, one of the ways that you can actually bring a step change into anything is creating a systemic change. And a systemic change cannot happen unless, like you very rightly said, that people are aware about what is happening and the research that you did. So I think it's also about creating the right kind of evidence nationally, locally, with contextualized evidence like you have done wonderfully. And that research needs to be communicated so that could be taken up by the key people to understand that something like that does exist, because probably a lot of time when these policies are being made, such evidence, they are not even taken care of. They are not even read or heard of, and there is evidence out there. So that is one way, I think, make your evidence, probably try and collaborate with other research organizations and make it more heard and make it more talked about. Probably could be one step way. We work with a very good organization. We have recently collaborated, which is Stellenbosch University, which is in Africa, and it's totally on people with disabilities. So I think there we talk about citizen engagement and feedback loop. So a lot of time when we do research for, say, vulnerable population or people with disabilities, they are not even involved when these research are being designed. Those kind of initiatives are being taken up by that particular organization where they involve, and because unless we understand what is needed in terms of intervention, you cannot actually test an intervention. So probably that could be one area where you may want to collaborate. There are a lot of ways we can talk, over coffee, and I can tell you how you can connect with them.
Sure,
Dr. Kiran, yeah.
Do we have time, or can I? Yeah. No, okay. So actually, I would like to just add the perspective of children in care and those care leavers who leave care at the age of 18. So there are so many issues, in reintegrating them back into families. First of all, the child protection functionaries, do they understand enough? Right now, the easiest answer is institutionalize a child when there is no other support is coming. How do you develop, the child protection functionaries to actually review this particular mechanism, because the laws talk about institutionalization as the last resort, and especially for children with disabilities, because parents are not able to look after them, like there are so many costs, and rehabilitation costs are just tremendous. So it's very easy for them to give up the child because they don't get any other support. So what we are trying to do, we've developed training modules, and we are already working with 4 state governments for child protection functionaries to train into family-based care, and especially children with disabilities, how they could be placed back with their families, what kind of support is needed. We are also trying to bring all the different departments to converge together. So we are requesting, DMs to include care leavers in their monthly meetings with different departments, where the care leavers are themselves there. Like you said, nothing without for us without us. Same for the care leavers, care community who are coming out. They don't want, others to be ruling them or making rules for them. So if they are part of these meetings, they are able to bring up some very good suggestions. So I think it's very important that people who are affected the most, they should be given a voice at every level.
Great. Thank you so much.
Thank you so much. And especially when we look at the community level approach, the community primary healthcare centers are not accessible. It's not disabled friendly, not wheelchair friendly and all that. So that also need to be taken up by the government. We are also advocating with the government of India. And I'm happy to share with our share about the link on our study. Please let us collaborate on that. Thank you very much.
Thank you so much. And I think with that, we'll close with one quick closing remarks by each panelist. I would just like to mention that there's a lot of policy gaps. There's a lot of research gap out there. But I think to bridge these gaps, evidence is definitely one of the key bits. There is a lot of good evidence out there around vulnerable population, children in care, people with disabilities. And I think it's time that we collaborate on these, we use these evidence, and we also identify together where exactly the gaps exist. With that, I'm going to stop, and probably very quickly, if each one of you can put a closing remark.
Well, from what I said, nothing for us without us, and to look at different things in different perspectives. The work that we are doing at SENS in Bangalore is very new. The format is very new. I know that it's something that's not being done at all. We run the first autism art college in this country. We run the first autism-specific academic school, which is technology-driven. So I feel that's really important for policy people to start looking at what is new and start engaging with it. Yeah, that's my closing.
Thank you. The evidence that we created for care leavers, the kind of problems that they get, and the gap in the services that are available, even though the policies are robust. One thing in India is our policies are robust, but hardly it reaches. Implementation is so poor. So, but at the same time, when that evidence was created and the research went to these 5 state governments, as well as the Ministry of Women and Child, I think it really made tractions. And a lot of, recommendations that we made there, we found its way coming into the Mission Vatsalya. So I totally agree. Evidence generation is very, very important. But at the same time, research, evidence generation costs money. And there aren't too many people who are ready to fund. We have started with this little disability study in 33 childcare institutions in Bihar, which clearly talked about the state of disability, children and youth who are suffering. But after that, we have made the proposal and we have sent it to so many places. We have not been able to find, a partner to come in. So if Campbell could consider that, we would be more than happy. Thank you.
So with respect to community-driven approaches for strengthening health equity, when I was talking about this local self-government, we have education institutions across the country, everywhere, but if you see their involvement in evidence generation is very limited. only few institutions in key cities are involved in evidence generation, where the local institution of that particular area are not much involved. So these capacities need to be increased, and they should be involved in planning and decision making. If you see, when I was talking about this village health, sanitation, and nutrition committee, they they have well structured policy for that, what need to be done, and there are scorecard and health plan that health worker have to do, but they are not doing it. When I visited one of the village, the book has same resolution, same participant's name for the past 5 years. Not even a change. But they don't even change the name of the panchayat, representative or the panchayat secretary. Same name. It's ditto. So this is the situation in many panchayats. So there is no proper monitoring and evaluation of such things, and even social audits. So if education institutions advocate for these things, as since I am part of an education institution, so I am saying, if they could be part of this, and when they could do social audits, and when they can help PRA, participatory rural appraisal at the village level, that will really help the community to understand where they stand, and it will be helpful for them to empower and take this forward. Thank you.
Yeah, I think we talked about evidence here, and a lot of evidence is required for a lot of things, but a lot of evidence also exists for a lot of things. I think a point was made here that implementation has to be strengthened, yes, but even when the implementation is strengthened, in many cases, communication of that doesn't happen. Like you mentioned, the e-Sanjeevani, I think the communication of that has to be improved, so that's point well taken. I think the other thing is, most of us, or many of us, try to do things alone and in a very siloed manner. But the world today doesn't work like that. I think unless we partner, we leverage complementary strengths, funding would never be enough to fund your siloed effort. So that's why I think partnerships, communication, and of course evidence generation and its implementation, all of it has to be done. But in my opinion, I think communication and partnerships would have to be the absolute must. Thanks.
Great. Thank you so much to all the panelists here, and thank you so much, audience, for patiently listening to us. We're really sorry we couldn't open it up much for the Q&A, because we started a little bit late because this was the first day, but we thank you so much for patiently listening. And thank you so much for introducing all of us here.
करो ना, खड़े क्यों हो? बोल दिया। हाँ, क्या हुआ? ये है कि नहीं कि किरण मोदी इनका तो हो गया, इनका हाँ, आपके पास है ना ये? वो किधर है? यहाँ से निकाल।
और ये सामने वाले टेबल
दो चेयर और दो पोडियम।
Done है, done है.
या
Hello? Hello? Hi, good morning everyone. We'll be starting our session shortly, so welcome you to take your seats, please. I welcome you all to take your seats, please. Good morning. Hi everyone. A very good morning to everyone. I know we have colleagues joining at the back. I welcome you all to take your seats. Please move forward. Excellent. Good morning, ladies and gentlemen. It's an absolute honor to be here with all of you this morning on day one of what will be a very, very exciting World Health Summit, the regional meeting here in New Delhi. Welcome to our session today, From Barriers to Blueprints, Advancing Access to Healthcare. It nicely tracks the overall theme of the summit here today, which is Scaling Access for Health Equity. My name is Madhvika Bajoria. I lead the Health Impact Platform at AVPN. It's my honor to be here with all of you today. AVPN is the largest network of social investors who are mobilizing capital towards impact in Asia. Equitable access to healthcare is not only the theme of this World Health Summit regional meeting, but it is also the central plank of AVPN's health impact strategy. Because we at AVPN believe that this is an integral part of human life and dignity. Marginalized populations become more vulnerable when their locations become hotspots for super spreaders like dengue. With dengue cases surging across India, particularly in urban and semi-urban regions, there is a pressing need to improve early detection, community-driven prevention strategies, and sustainable financing. While vector control and public awareness efforts have advanced, gaps in disease surveillance, healthcare infrastructure, and behavior change communication persist, and this limits policy effectiveness. So to create a paradigm shift in the health system, it is imperative to have a multi-stakeholder approach which involves government, CSR, donors, technical experts, and community representatives. This helps us address different barriers instead of creating parallel systems. And it is exactly with this ethos that we at AVPN have brought the entire force of our network and our convening power towards building and launching what we are calling the EquiHealth Alliance. This is a multi-stakeholder alliance focused on improving access to healthcare for communicable diseases with a focus on dengue. This alliance is housed at AVPN, but we are supported by our brilliant technical partner, ETI Services. And what this does is it ensures independence and rigor in the approach to multi-stakeholder alliance building. We kicked this alliance off in December 2024 and then commenced a series of convenings across Tamil Nadu and Karnataka over the last 4 months. Through these convenings, we develop a structured, solution-oriented roadmap for dengue control, which we are very excited to launch at the end of the session today. We took a three-pronged approach in building this roadmap, which includes, firstly, prevention, timely management, and behavior change. Secondly, data and surveillance systems for effective response. And thirdly, financing and sustainability. So let me not go on and on. It's against the background of all of this work we've done over the last 5 months that in today's session, we are bringing together an absolutely stellar panel of leaders from industry, government, public health epidemiology, community engagement, and behavioral science who are going to help us translate these state-level insights into national strategies. In this session, we will offer actionable recommendations ensuring that dengue response frameworks are scalable, data-driven, and financially sustainable. So without further ado, let me introduce our panel and call them up on stage. As I call your name up, I would please welcome you to join us up here on the dais. We're very honored that our session today is chaired by Dr. Dalbir Singh. Dr. Dalbir Singh is a passionate public health leader renowned for his strategic advocacy and impact-driven initiatives. He is the founder-president of the Global Coalition Against TB, supported by over 4 dozen parliamentarians and expert policymakers. He is also the co-founder of the Global TB Caucus. Thank you, Dr. Dalbir Singh. Next up, it is my honor to invite Dr. Rajnikant Srivastav. Dr. Srivastav is Chair Disease Elimination at ICMR and the former founding director of ICMR RMRC Gorakhpur. A scientist and ex-head of policy and communication at ICMR, he has over 4 decades of experience in public health, specializing in vector-borne diseases, community engagement, and health communication. Next up, it is my absolute honor to invite Dr. Naveen Thakkar up on stage. Dr. Naveen Thakkar is a distinguished pediatrician and global health leader, currently serving as president of the International Pediatric Association. With decades of experience in child health, immunization, and infectious disease control, he has been instrumental in shaping pediatric healthcare policies and strengthening immunization programs worldwide. Thank you, Dr. Thakkar. Next up, can I please invite Dr. Kalpana Barua. She's the senior consultant and former additional director at the National Center for Vector-Borne Disease Control, with over 35 years of expertise in vector control and medical entomology. She has led national efforts in policy development, vector surveillance, and outbreak response. Thank you for joining us today. Next up, can I please invite Annapurna Das. Annapurna brings over 20 years of experience in the pharmaceutical and biotechnology industry across India and Southeast Asia. She is the general manager for Takeda India. Before joining Takeda, she held key leadership positions at various multinational healthcare companies, including Sanofi, GSK, MSD, Pfizer, and so on. Thank you so much for joining us, Annapurna. Next up, we have Dr. Aisha Chaudhary. Dr. Chaudhary is a healthcare innovator and the India Director for Women Lift Health. She has previously served as OSD with the Office of the Principal Scientific Advisor to the Government of India and the Director at the Atal Innovation Mission in the Niti Aayog, where she helped create a science-based entrepreneurial ecosystem in India. And last but not the least, we have Ravi Bhatnagar. Ravi, please join us up. Ravi is the Director, External Affairs and Partnerships at Reckitt, South Asia. Previously, he led the Asia, Middle East, and South Africa region. He is a qualified independent director and co-chair at ASSOCHAM CSR Council and a board member of the Population Services International. Thank you once again to this panel. Big round of applause for them. Now, without further ado, let me actually call up Dr. Rajnikant Srivastav to please come up here and provide the keynote address. Dr. Srivastav has been with us at each of the convenings we've done over the last 4 months. So please, Dr. Rajnikant, over to you.
Very good morning, and thank you, Madhvika. So it's great pleasure, and I am so delighted to be here amongst the eminent speakers and the panelists, Dr. Dalbir Singh, who has been with us in many of the programs, Dr. Naveen Thakkar. So he has also been associated with ICMR. We had one meeting with Dr. Thakkar while we were having a health communication. And Dr. Aisha, she is from the Women Lift. So thank you so much for you being here. Dr. Ravi Bhatnagar, and all the colleagues and friends. So I am so grateful to the AVPN for this opportunity, as well as the ETI, that we are meeting today to discuss very important point, that is the vector-borne diseases. And while we are talking about the vector-borne diseases, today is a very important day because today is the World Malaria Day. And the World Malaria Day we are observing today, 25th of April. And this year, the theme of the World Malaria Day, ki malaria ends with us, how we can reignite, reinvent, and reinvestigate to control malaria. So while we are talking about the vector-borne diseases, so they are the major cause of the infectious diseases. About 17% of the global burden of the infectious diseases because of the vector-borne diseases, causing around 7 lakh deaths across the globe. That is how the vector-borne diseases becomes very, very important. And while we talk about the vector-borne diseases, it is the malaria, lymphatic filariasis, Japanese encephalitis, and the dengue and chikungunya, we all know they are emerging very fast, Japanese encephalitis, Zika. So vector-borne diseases are really a very serious concern for all of us. While on one hand, we have been able to control some of the vector-borne diseases, and we are now talking about the elimination. For example, malaria, we are talking about how we can eliminate malaria by 2030. Similarly, lymphatic filariasis, leishmaniasis, now we are talking about how we can eliminate these diseases. On the other hand, diseases like dengue and chikungunya, they are emerging very fast. And today we are going to discuss something about the dengue, how dengue is causing so much of a problem across the world. It is not only India, across the world, the dengue outbreak and epidemics, they are happening every day. If you go to Brazil, if you go to the Bangladesh, if you go to Sri Lanka, the dengue outbreaks, they have become very, very common these days. And around 40 to 50% of the world population is at the risk of dengue across the world. More than 100 countries, they are being suffering from the dengue. If you talk about India, in India, the dengue cases have increased. We have Dr. Kalpana Barua from the national program. She will touch upon and highlight about the programs about the dengue situation in the country. So in 2010, around 28,000 cases were reported. Now it has reached to more than 2.5 lakh or 2.9 lakh cases are happening, and outbreak and epidemics are happening regularly. And this is not only the cases. The cases earlier used to happen only in a season, and we were all aware that the dengue happens only during the monsoon time, June onwards, July to December. So we were geared up and we were prepared that we have to fight with the dengue. But now from the seasonal, it has become a perennial because of the climate change and the people behavior, travels. So there are many effective, very situations where they are favoring the breeding of the Aedes mosquito and they are causing dengue. It is not only dengue is happening in the urban areas. It has now, there's a paradigm shift. You was talking about the paradigm shift. Dengue is shifting from the urban areas to the rural areas. So that is a big concern. And from land to the highland, we have seen the dengue cases, they are happening in the Bhutan and Nepal. So that is how it becomes a very, very difficult scenario nowadays. The other important point is that we don't have a therapeutic treatment for the dengue. There is no drug identified antiviral for the dengue. And in a country like India, we have a team from the Takeda and they have the Q-Dengue vaccine. We have a dengue vaccine also. So there are 2 vaccines already, they have been rolled out in the world. But in India, we have not used these vaccines, though we are in the preparation of the indigenous vaccine, and some of the companies, pharmaceutical companies, they have taken initiative to develop the dengue vaccine, and ICMR is a partner. But currently, we don't have dengue vaccine also. So main focus is how we can prevent dengue and how we can prepare ourselves to deal with the outbreak and epidemic. So this is how the situation of dengue becomes very, very important. Now, when we talk about the AVPN or the ETI, so during our visit to the 2 states, Karnataka and the Tamil Nadu, so under EQ Health engagements led by the AVPN, so we conducted some programs, multi-stakeholder consultation. There were team from the research institution, there were team from the clinicians, medical doctors were there, NGOs were there, and the team from the pharmaceuticals companies. And we discussed on 3 main important issues, thematic areas: the prevention, timely management, and the behavior change. We discuss about what are the issues, how we can improve the prevention, what are the gaps. And they've identified that, for example, the surveillance needs to be strengthened. The cases needs to be identified. We don't have an integrated surveillance system. Whatever we capture is from the National Center for Vector-Borne Disease Control Program. We don't have control over the private sector. So whether can we develop an integrated data management, whether we can use the artificial intelligence to capture these cases. So that can help in the early diagnosis and early prevention of the disease. Similarly, if we can use the predictive models, suppose in a city like Delhi, it doesn't mean that the whole of the Delhi may be having the dengue problem on the same instance. Some area may be more prone to the dengue. So can we develop some predictive models so that we can take an early action? So these kind of things that came out, that if we can prepare such kind of a modeling, that will be help in the early identification. Similarly, if we can strengthen the primary health care, so that the ASHA workers, if they are trained, so I am so lucky that we have a team from the ground level. I was a director of the RMRC Gorakhpur, so we have a team, Dr. V.K. Srivastava, entomologist, Dr. Angad, he's the district malaria officer, and ASHA. So at the ground level, how we are facing this problem and how we are taking care. So we have a session with the community-based ground level scenario, so they will discuss in this issue, so how we can strengthen our surveillance system, how we can train the frontline workers. That will help in the early detection and the proper management of the dengue cases. And similarly, if we have the rapid diagnostic kits, so that early diagnosis can be done. And the important point which came out about the financing, because for the health, we know that India has always struggled in the GDP manner, 1.3 to now we are talking about the 2.5% of the GDP. So the finance has always been a big issue whenever we are talking about the health for all. So in dengue also, if the finances has become strong, if we can develop partnership with the CSO or the private partners, they can help, and how we can reduce the out-of-pocket expenditure. Those who are really needing the finances, so can take care of some of those issues. So based on this thing, we identified certain call for action. What is needed to do is that it cannot be done by a single sector. If we talk about that only the health department can tackle the problem of the dengue, so we need a multi-sectoral response, whether it is a school, whether it is the education department, whether it is the private sector or the NGOs. So there is a need to develop a multi-sectoral partnership. We can work together and we can fight dengue. Similarly, we have to integrate the climate and the urban development, education and health sector, so that we can develop a cohesive plan, and the national dengue blueprint we can prepare that will help in the management of the dengue. And the cross-sector partnership is also very, very important. Besides this, our interaction at the multi-sectoral level in the Tamil Nadu and Karnataka, I also had one great opportunity having a community engagement program on dengue in Gorakhpur as well as in Lucknow, and later we have a program in the Delhi also, and we try to find out the ground level situation, how the dengue is affecting at the ground level, and how we can improve the surveillance and the prevention, and how we can train the frontline workers in the dengue management. So overall, if we wrap up and conclude, is that dengue is definitely a problem, but we need to tackle it very wisely in a cohesive manner, in multi-sectoral partnerships, and considering the climate change scenario, I think we need to be prepared. And in today's era of artificial intelligence, can we develop new innovations, new tools, and vaccine if it is become available? So definitely, I think we have certain hopes we can fight dengue properly. Thank you so much.
Thank you so much, sir, for setting the context so nicely in what is a very complex problem. So appreciate your opening remarks. Could I please now invite Dr. Dalbir Singh to the podium? He is the chair of our session, and I will ask him to kick off by sharing his background on, our EcoHealth Alliance. Sir, please come.
Thank you, Madhavika. Distinguished dignitaries, delegates, and all my very, very distinguished panelists. In fact, I'm overwhelmed looking at all your title and your qualifications. It's really an honor to be chairing this session today. Over the past 1 year, I have had an opportunity to participate in almost all the AVPN-led EquiHealth Alliance convenings. I think there were 2 of them in Bangalore, Karnataka, and another 2 in Tamil Nadu. And even besides that, we have been interacting. And all these forums brought together a very, very impressive range of voices. We have had domain experts, policy makers, clinicians, researchers, corporate leaders, and even patients, ASHA workers. So putting all of them together, under one umbrella was very interesting. Something that I did in the last 12 to 13 years, where I learned how to collaborate across sectors, across disciplines, in a multi-stakeholder alliance. This, in fact, was born out of a very, very personal adversity. I suffered tuberculosis 2 times over. I'm a 2-time survivor. Second time around, came out of jaws of death. I was treated for 16 months. In fact, everyone had given up except me. And the warrior in me, I'm an old soldier. I fought war for this country. So I survived second time. And then I thought, what is it that makes to get people okay? And you'll be amazed. During that time, I used to go to Parliament and talk to some of the MPs. They said, TB तो बहुत पुरानी बीमारी है, तो खत्म हो गई. And we got the BCG when we were young kids. It's all over. अभी TB कहाँ है? Because the more fashionable at that point of time to talk about HIV. HIV got all the attention. HIV got all the funding. And then polio, then other thing. But nobody thought. Something which has ravaged humanity for 9,000 years. No one is willing to talk about it. And then I got into the root of the problem of what is TB, what is this so-called Bacillus mycobacterium TB. And then I discovered that there was so much of antiquity in our policies. At the core of anti-TB effort, for that matter, any other disease, there were 3 major things I identified. One was you needed very pragmatic reforms in policy. Your policy must be functional and pragmatic. Second, no disease in the world, no disease, okay, it's been tried everywhere. No government, no civil society, no NGO, no community alone can handle it. Okay, it has to be cross-sector collaboration. It has to be harmonizing of synergy between all these organizations. Unless you do that, it just cannot happen. And I'll tell you the scenario. In 2011-12, when I set up my organization, everything seemed to be working in silos. Okay, the private sector was almost untouchable. Private sector did not have the kind of sanctity which the government always thinks it has. And whereas we all recognize and understand, almost 68 to 70% people are treated in the private sector. So somebody had to bring them together. And it took me a lot of effort. I did first pilot in 2016 in Bihar from Patna. And from Patna we went on to Mehsana to Mumbai. And the model that we created, PPP model, is now replicated all over India, almost 80% of the district. The government itself has replicated during the JEET project, JEET Path Global Fund. So it is our model. We started in Patna in 2017. My very dear friend and colleague Sukriti Chauhan was there with me that time. And so we introduced PPP model in India, which is very important. This is a fundamental. If you don't take private sector, treat them as untouchable. If there is no synergy between the private and the government, how do you think you'll ever get hold of something where you lose 1,500 lives every day? And then the greater thing I discovered, and it was an amazing discovery, that for centuries we were relying on serological tests by WHO's own admission. They were 85% inaccurate. God knows how many decades we were relying on the test. And then we traveled all over. We went to many international conferences. We had a lot of interaction. And we took many delegations, parliamentary delegations to Moscow Summit, United Nations, many of these places. And we discovered that the molecular diagnostics is already in use in many countries. Then there were issues of pricing, then there were issues of the cartridges will be expensive, how will we make these available? I said that doesn't mean we go on with the kind of diagnostic which is 85% inaccurate. You have to do something about it. And well, I can tell you very proudly, it was finally when it was Mr. Nadda who became the health minister, and he's back again as health minister. I'm so happy that he's there. And we bought the first 300 diagnostic machines, molecular diagnostics. Now we have something close to about 14,000 or something in the whole country today. Initially our target was just one district per district, but then one per block. Now of course all the major hospitals, private hospitals, bigger hospitals, all have those machines, and which are almost 95 to 100% accuracy. So we introduced molecular diagnostics, we introduced public-private partnership, we banned serological tests, we made TB a notifiable disease because a lot of people still in rural India were doing what they wanted to do. And then we realized that there's no avenue for research. Of course, you have ICMR, my friend Rajnikant is here, but then that's a broad-based research from A to Z. We want TB-specific research organization. So we chased, we did advocacy everywhere, we spoke in parliament. I took a delegation with the President of India, I took a delegation to PMO, we worked on it, and then finally we did manage to get our own National TB Research Consortium. And I can tell you proudly again, Mr. Soumya Swaminathan, one of my oldest expert group members, she became the first head of that consortium. So we set up that consortium, and through our sustained advocacy over the years, we also managed to expand the use of ICT. This is something we learned from South Africa, Brazil, because in India it was not being used. Then Nikshay portal was set up based on our recommendations. And we had been meeting every few months. Idea was to bring all stakeholders together, practitioners, clinicians, everyone, domain experts, policymakers, parliamentarians. Then I involved the MLAs also, all elected representatives. Why not? Because they win elections, they control population of 200, 3,000, 400,000 people, they decide policies. They must get involved in their health. And then I made a suggestion to the government 4 years ago that we have another powerful institution in the country, like local governments. India is one of the few countries with a constitutionally mandated government. And they are highly underutilized. I know for sure, I was a member of National Task Force on Local Governments for 2 years. I know they are highly underutilized in their capacities. So why don't you, because they know pulse of the people. They are the people who are the grassroots. They are the ones who know the local communities. They are the ones who are with the CBOs. And unless you involve them and integrate them. So now, of course, even the government has come out with a slogan, Jan Andolan. What is Jan Andolan? It is a people's movement, okay? You're starting from the government to private sector, to civil society, community, local governments, everyone, bringing everyone, building huge synergy. It's only when you bring them all together, there will be solutions. You can't work in silos and to be able to find, equitable healthcare solutions. So we did all that, and I'm sure I've been for these AVPN conferences, 4 of them, and I think I saw similar spirit, the spirit of cross-sector collaboration. Of course, I would like to compliment AVPN for having done phenomenal work in equitable, accessible healthcare solution, for also leveraging very, very innovative financial mechanism, and also trying to find new ways of bringing everyone together on board. Now, this panel, of course, you're going to hear in the next half an hour or so, whatever our friends are going to discuss. All I can say is, because I think Madhvika has touched the core of what you're going to discuss, stronger surveillance and data system that enable real-time action. Second is gender-responsive and inclusive prevention and finance strategies. Third is public-private community partnerships that move beyond CSR and into co-ownership of public health outcomes. And before I conclude, I would like to make a remark on, I'm deeply inspired by late Dr. Paul Farmer, a very famous medical anthropologist and a distinguished Harvard professor, for his relentless fight for healthcare access and equity, particularly for the marginalized. Today, we must remember his profound commitment that he made. And I'll quote him, "We must walk alongside those who had the most to lose in this world." So today, this spirit of solidarity is more critical than ever before, as to strive to ensure equitable healthcare access to all, particularly for the most vulnerable populations. With these words, I conclude, and may I now hand over the floor to Madhvika to conduct the panel discussion. Thank you.
Thank you. Thank you so much, Dr. Dalbir Singh. That's fine. As we talk about tackling some of the most emerging infectious diseases, especially with climate change that we're contending with in our country, It's so important to hear stories like the one Dr. Dalbir Singh just shared of our own country's previous experiences in taking on and conquering to a great extent other kinds of infectious diseases, whether it be TB, whether it be our experience during COVID-19. So thank you for sharing your journey with, building this broad coalition for TB. Thanks, Dr. Dalbir Singh. So now let me get right into it. We have an amazing panel. I will start with a couple of round of questions, but there will be time at the end for audience interaction, so we will come to you at some point. But let me start with Dr. Kalpana. Dr. Kalpana, we've heard both from Dr. Rajnikant as well as Dr. Dalbir Singh about the importance of data systems and surveillance. So with your extensive 35 years of experience, how can national programs better support integrated real-time surveillance systems for dengue, particularly to bridge data gaps across public and private sectors?
Thank you. I would like to thank the organizer, ABPN and NTI, for organizing this panel discussion in this important forum. And the topic, it is from barriers to blueprint. I was just looking at that. Advancing access to healthcare through vaccine and therapeutic acceptance. The dengue, a disease which neither have any vaccine as on today nor any therapeutics. So everything depends on the control aspect only. So going back to the national program, the national program for dengue, it is not a very, old one. It started in 2003, December. And when the program was started, we have seen that there was no surveillance mechanism. When there was any outbreak at that time, there's no dedicated budget was there, funding mechanism was there for that. So if there is any outbreak out of the malaria fund, so those outbreaks were contained. And then from 2007 onwards, the full-fledged program started, and our surveillance, we have started through a network of Sentinel Surveillance Hospital. So we started with 110 hospitals with laboratory facility, identifying in the endemic states, then went on increasing. And as on today, we are having 848 Sentinel Surveillance Hospital lab, and then 27 Apex referral laboratories are there, which are helping these, which are providing backup support to these network for for their quality of the services. And we are having two types of kits, IGM kits, which is NIV Pune ICMR's institution. It was entrusted the responsibility for development of the IGM kit and to provide to the identified laboratories. Then for early diagnosis, this NS1 kit was there, so that the cases can be diagnosed in this viremic stage. Then gradually it was seen that this network is not getting the entire, it is not capturing the entire disease burden. There are certain gaps are there. And this private sector, as Dalbir also said, that private sector is really a big challenge to getting the data from the private sector. Then dengue was made a notifiable disease in 2016. So that the private sector, within the regulatory framework, they are also they also report, but still it is not like any other this notifiable disease. All the sectors still there are certain gaps are there. Then now we have seen that that integrated disease information portal, this IHIP, IDSP has been using that one. And now National Center for Vector-Borne Disease Control Program, we also started onboarding on that. Certain diseases like malaria, completely onboarded. This lymphatic filariasis, they have onboarded. And this visceral leishmaniasis, because these diseases are targeted for elimination. So they were the first one to onboard. And then next was the arboviral diseases, dengue, chikungunya, and Japanese encephalitis. So we have started. We have started from last year and the end of the year that IHIP, our portal is IHIP VVD portal. So now there are more than 1 lakh reporting units are there. So obviously, if next year you see that there are 4 to 5 lakh cases, don't think that there is an outbreak, because reporting will be increasing, because surveillance network will be increasing. But the thing we have to see the death, the number of deaths. If the deaths are under control, now our there's no case fatality rate is 0.1. So we are sustaining it for a long time, and we have brought down with several effort. But whatever is there, but we need to have some multi-sectoral effort also for increasing these, our surveillance network, so that from the grassroots level also these informations are obtained. Under this, in the ministry, the ASHA is one of the system that that was identified to get the information from the grassroots level. So for dengue also, we are involving ASHAs. ASHAs are there, community health workers are there, then domestic breeding checkers are there. ASHA is the, these grassroots level workers, they can provide us the first-hand information if there is some fever outbreak is there or some changes is there, they immediately bring it to the notice of the primary health center, and from there, the information percolates to top one, so that the rapid response teams can be implemented there before it is taking in the outbreak proportion. Now, another challenge we are facing now, not only the dengue, across the sector, we are facing the problem of climate change now. We have seen that the transmission window has been expanded. Earlier, when in the 90s, dengue was reported sporadically for a few months only, and then it disappears. The decade from 2000 to 2009, there were only 8 states which have reported dengue. And the next decade, the last decade, that is 2010 to 2019, there were 11-fold increase all total in the dengue cases. And all the 35 states and union territories are now affected by dengue. Ladakh, of course, due to the altitude, the vector cannot propagate there. That's why we are not getting the cases from Ladakh. But the way the temperature is changing, maybe it won't be very far away that Ladakh will also have the problem of dengue. Then now, if all these things are there, then what we can have for some early warning signal? We need to develop, we need the database not only for capturing the number. I always say that to my state counterparts, district counterparts, that you don't think that the data which is coming, we just want to capture the figure. We want the detailed information. We call it line list. Line list means it has the address, the gender, it has the total information, when the onset of the fever, when it was hospitalized, and the outcome, everything, it is there. Because that gives the real picture, actual picture for some data-driven decision for the national program if any change is needed. So all this information, and based on this recent development of AI or GIS, all those modern tools, incorporating all those, now we are in the process of developing these models so that we can have some early warning signals. Yesterday only in the office, we are working on how many tools are there, how many models are there, which were developed and working on this dengue. Dengue prediction model. There are many models are there. In India also they have tried and developed and tried. But maybe models immediately they do not, they are not giving the real picture. Some are giving 40% accuracy, some are totally failed. Maybe some other indicators have to be also included, because dengue is beyond the health sector. So all other sectors have to come together. The urban sector, even the rural sector, in some of the states, more than 50% of the cases are coming from the rural community, rural settings. So we need to have the Ministry of Rural Development, Panchayati Raj, Jal Shakti, then HRD, all these ministries have to come together, then only we can have a robust mechanism. Intersectoral convergence will be the crucial, critical component for dengue control in the near future.
Right.
So, yeah, thank you.
Thank you so much, ma'am. And it's fascinating to hear how we're building up capacity for surveillance in the country through a mix of extremely high tech but low tech, like ASHA workers. You mentioned how critical that is, and we're so lucky today to be joined by an ASHA worker who will share her experience on how she's doing some of this surveillance on the ground. So thank you for sharing that. Dr. Thakur, we've had Dr. Barua lay out how we're building up surveillance capacity and getting the full picture of the disease slowly. But one thing we do know that children continue to face a disproportionate burden of dengue in India. And focusing on pediatric dengue in India is crucial because we know children and infants have weaker immune systems. So from your experience, can you just shed some light on what really is the magnitude of dengue on children in India, and how can we improve outcomes for them, especially the pediatric medical professional community? What can they do?
Thank you. Thanks for the invitation. And I'll be referring to my notes because you are, the World Health Summit. I'm on 4 panels, and sometime you forget which panel you are speaking. So don't mind it. Thank you, Dr. Rajnikant. That reminded me, I was invited to ICMR to train young scientists on social media. And I said, why I? But because I'm a social media influencer, and also I was, my lifetime work is on polio. Anandita is here, who GHS has taught us social media. So thank you, nice to see you in AVPN. So, let's just start with the history. Now, everyone may be interested. First isolation happened in Calcutta, 45-46, dengue case. First outbreak in 1963-64. And madam has already covered everything, and everybody has said that dengue is now spreading. It's all across India, it's all across world, Europe, you name it, and they have dengue cases. So, and it's going to increase because of climate change. And if you relate it, South Asia is highly vulnerable to impact of climate change. 17 out of 20 people in India are vulnerable to extreme hydrological and meteorological disaster. And we have seen that already happening. I was also thinking that I will not see in my lifetime. Why should we bother? But now we saw floods, heat. We have never seen such a heat in February. In Kutch is known for the, but it's a really 48 degree. You can't believe it. In February, March. So it's a happening. It is going to increase. You have it everywhere. Now coming to, and thank you very much, madam, for your leadership, and both of you for, I accessed the website, and a few months back it was showing 28,000 only, and data till 2019. And then now it's still not very updated, but this is the picture where we are missing data from very crucial state of UP and all that. So please hope, yeah, this is old, but this is on the website. So that's the, that's the problem. It's now it's showing 2 lakhs and something. But some people have tried to do work. Many researchers, ICMR and everyone, many meta-analysis, studies, modeling, and it was shown that dengue is underreported by 280. The burden is 281 times more what is shown. So dengue is #1 health priority in India. It is also a political disease. I was giving example that when there is a rain, definitely it may be a whole year, but whenever there is rain, our hospitals are flooded. Many of those may be dengue, may not be dengue, but dengue is a real horror. That also a myth that we can treat it, and it's called, bone-breaking fever and all that. It's really a horror, and people line up. They flood the hospital, even they don't need that. So it's a public health problem. Indian children get infected at early age. And this all data is available. And case fatality has gone down because of better health management. And but so economic cost is very high. We have a notion that old people are more vulnerable, children are more vulnerable, but on the contrary, young people are more vulnerable for mortality, fatality, because they have, for dengue, you don't die of dengue, you die of immune response. So if you have a robust immune response like we saw in COVID, you are more prone for the serious consequences. So it's a really, and this generation, this young generation working force is severely affected. So it's a really a very, very serious problem. All four serotypes are seen in India. ICM, National Vector-Borne Disease Control Program, they have 848 unit, and now they are using other sources. But still, it's a long way to go. And again, it only takes dengue positive if it is ELISA, NS1 plus or IgM plus, ELISA test. And it may be that we are still missing many, many cases. So there are children and otherwise also. Dengue is, there is no, madam says very correctly, there is no therapeutic, there is no medicine. And someone comes to me, I diagnose, and I say, this is first day, and mostly we see the severity after 4th day, and we give them a input-output chart, and say, measure the intake and say medicine. We say, no medicine. Then why you are charging your fees? So it's like, and they will go to a general practitioner, a quack, and will get a, drip daily and very happy. And when time comes, they become serious, they don't reach to the hospital. And those who reach to the hospital, they may not need this. So overlapping clinical pictures, say many myths, papaya, and now dragon fruit to suddenly disappears during dengue season because everybody is buying that. It's everywhere in rural area also, no diagnosis, not same facility of diagnosis and management. People panic, get admitted. Uniform protocol are not followed everywhere. Lot of work to do for us medical professionals. Over treatment, under treatment, both very common. They don't know, people don't know, and you have to prescribe some medicine to earn your fees. Otherwise, you say, just maintain input, output, there is no medicine, they will say, then let's go somewhere else. Cases have increased, but deaths have decreased, and I'd say young people are. So what can we do? I fully agree that we have to develop a surveillance system inclusive of private sector. But these kits are not standard. These kits what are available, and most of the people, those, practitioners, they don't know how to interpret that. It varies from the day to day that you have to interpret whether it is a recent dengue, and you must be knowing the secondary infection is more, you have more complication, not the first one. Secondary, you have complication and fatality, not in the first one. Kits are not proper. People don't know how to do that. So we need a community-based cohort study representing different geographical region. We have to fill up the knowledge gap. We have to create awareness, what I am saying. Dengue, everybody knows. They will call it dengue in northern India and we call dengue now, but it's, and everybody knows dengue. And if we make a case with politician at a proper time, during monsoon, when you come to Delhi and all hospital, UP, all hospitals are flooded with dengue, then people will listen. What happened with Japanese encephalitis? Gorakhpur, sir. We brought the vaccine from the China without any. So once government listens, everything will move. We did, you may not be knowing, we wanted to employ monovalent OPV type 2, and it was employed in a, say, like, clinic. We have that example even in COVID, in a clinical trial mode with abundant precautions. So that government thinks they can do anything. There is a medicine, madam. It's a license in 30 countries and maybe more now. There is one medicine, one vaccine, not medicine, vaccine, which is available. Two vaccine, but that is now the Sanofi is not going ahead with that. But we have another vaccine trial going on. So you need a different type of awareness creation. to the medical professional, to the public, don't afraid. This is the dengue, this is the treatment, this you have to do, what you have to do, this is it, and it's a really very correctly collaboration with ministry, with all the ministry, healthcare professional always have a very important role to play because we are the trusted voices. I think I will stop here, and if you have a vaccine, I'm ready to take it today.
Right.
You know, I was first person in Gujarat to take the COVID vaccine when nobody was ready.
Amazing.
So, if you make it available, I will take it.
That's amazing. Sir has thrown the gauntlet. So thank you, Dr. Naveen. Yes, thank you, Dr. Naveen. I think only you can, bring this deep experience, a medical professional's experience of the disease, but then so quickly tell us what that means in terms of translating to actual policy. So thank you for sharing that. Annapurna, let me come to you next. We've heard the private sector brought up a couple of times. We've also heard about the vaccine being alluded to a couple of times. So as from a pharmaceutical company's lens, Annapurna, how do you think industry can better collaborate with governments and communities to increase access to therapeutics, which we heard currently don't exist, but down the line, how can we do it?
Sure, thank you so much, and I'm really honored, and I'm listening to Madam Kalpana, Dr. Rajnikant, Dr. Dalbir, and Dr. Thakkar. I think it's kind of a host of thoughts going in my head, and I'll try to do my best to kind of try to synthesize. I think partnerships have been cornerstone for over the last 70 odd years for shifting the healthcare access in the country. I don't think this is a new concept of public-private partnership. The fundamental has been always that we need to forge the strengths of private sector, and we need to bring the strengths of public sector for only one lens. I'll kind of shift the question a little bit. There is no pharmaceutical industry lens. There is just one lens of public health lens. How do we ensure that the access happens faster, access happens deeper, and access happens, I think Dr. Dalvi talked about it, to the underprivileged, to the majority of the population. Couple of examples before I kind of try and answer how we can collaborate better. A couple of examples, and we have in my esteemed panelist, Dr. Rajnikant. I think ICMR has been a great example of driving public-private partnerships. I think I remember, I think this whole disease surveillance, I think 30 odd diseases that are getting in that, I think is exemplary, the work that has been done to put this integrated disease surveillance. I came to know about the National Dialysis Program. I think that's again a great example of how to make access for dialysis in a meaningful way. I was talking to NHM a couple of times. I think the work they are doing for diagnostics. So the reason I'm giving these set of examples and say it is happening. If I have to kind of underscore one point that it is happening, it's more about the speed and the urgency around it to make it happen scalable, so that we can really integrate with the modern therapeutics or the modern vaccines which are coming in the market. So I think that will be my fundamental idea about how do we accelerate that, how do we speed and scale it up, so that we don't have the same lag in access that we have had historically. I'll kind of summarize the theme. I think also before I talk about what we think as Takeda, I think there are fundamentally 4 to 5 big themes. Everything has been talked about. The first, to partner better from private sector, I think with the public sector, is about having an alignment around the priorities. Okay, I think a lot was talked about vector-borne disease. I think we have Madam Barua here. I think the whole focus around vector-borne disease control, management, and building that, I think we need to have an alignment on national priorities very clearly. I don't think we will need to continue to debate whether this is a priority or versus that's one. So that's why I humbly request that that's where we need to have a priority. The second one is bringing our technology and bringing our tech transfers are a very big, strong way. You know, I'm sure Dr. Rajnikant, you know that as Takeda, we kind of set up our manufacturing partnership with BioE. I think unique. I think much ahead of, we are in the process of kind of Dr. Thakkar, yes, there you talked about the vaccine. We are in the process of regulatory review of our vaccine. But what we have set up already a manufacturing partnership so that we do the tech transfer and be ready for the access. I think that is one big area of manufacturing partnerships because that accelerates access. The third one, I think, which we always talk about, building more sustainable. I think there was discussions about funding challenges, okay, creating equal health. I think that's where we believe, at least I also believe that it is important to have those conversations around sustainable access, which means how do we build a win-win situation between the industry and the payers so that we are able to get whether examples of tiered pricing or innovative contracting with government so that we kind of make it accessible. At the same time, we have the right financial sustainability to keep investing in R&D. That's what we do. We are an R&D company, correct? Okay? We invest in R&D. So that's important that those strategies are clear. The next one, I think a lot has been discussed about the community integration. I think super important, I'm not going to overscore, that if we are able to use the community mobilization for real-time disease monitoring. I think the Dr. Rajnikant also talked about the predictive modeling of outbreaks, okay? So I think this is where the community integration, I think I believe that with the social media, with the access to information being there, it's just not stopping at educating the community. It's more mobilization and using the community for public health delivery. Correct? I think we have to treat community as a very intelligent source. And that's why I think it's not just I need to educate community. I think that's another big piece. I think these are the couple of big pieces that we have. As Takeda, I think we believe that we play our very humble role in creating these partnerships, as I mentioned few of these. I'll just close by saying that, especially from the vector-borne disease, I think we have especially in a couple of other Southeast Asian countries, be it Indonesia, we have kind of partnered with the government for both for dengue awareness and control. We are doing similarly, I think, a big ambition of zero dengue. That's what we want. I mean, it looks ambitious, but that's what we should be talk about. So I think these are the couple of themes that I wanted to talk about, how we can continue to partner. I'll still say it's speed and scale to create urgency for adoption of therapeutics or vaccines and not waiting too long.
Absolutely. Thank you, Annapurna. And this is the right forum to be setting those big visions, right? And I love what you said, that there's no industry lens or government lens, it's a public health lens. It's so true. Also for highlighting how industry, beyond just being a product provider, can actually be this ecosystem level player. So thank you for doing that. With that, let me come to Ravi, who comes from Reckitt, another really important industry player. Ravi, from your experience in leading hygiene and community campaigns, Annapurna just talked about, treating community as an intelligent actor. How have you seen that we can deepen household level behavior change for dengue prevention?
Thank you so much, first of all, for inviting me. I have a very interesting story to tell before I come to the answer. COVID was a time, and we have a center of excellence of entomology in India, in Gurgaon. For our company, that is the biggest center of excellence across the world. India hosts 4 centers of excellences for IT and other things. So we have the entomology also. And Mortin is our brand, which came into existence in India in 1969 or 68. I was given a very interesting task to do. Mosquitoes should not die, and you need to feed the mosquitoes. Whole life I was feeding dogs, cats, elderlies, children. That was a task which was given to me, and I was very I was thinking why I am chosen for this task. So I'm not in the lab. I'm not a science graduate. They said we need someone who is very passionate about the subject and who can drive the purpose. I said fine. I drive the purpose. I drive the purpose on hygiene, on the maternal mortality, on on the drug abuse and many other things we work on. Finally, I was able to do it, and every day my job was to secure a pass from the Gurgaon Municipal Corporation, go to the lab, make sure the mosquitoes are all intact, they have not died, reporting it back, working with the scientists, and coming back. So this happened for a good period of 3 years. And I loved this subject so much. I thought, like, why not to take it forward in the career? And today is a day when in Bhavnagar, with the Bhavnagar Municipal Corporation, we are putting a statue of a mosquito there. Like you have the polio chalk in Muradabad, and you have other important, you have the Statue of Liberty, then why can't there be a, chalk at a place, at a significant place, so that the public consciousness and awareness is generated? Although we have kept it low thing because of the attack, and there were 2 casualties from Bhavnagar. So therefore, there's no much halla gulla. But that's the first thing. Second thing, you talked about the behavior change. It's one of the most interesting subject. And I have shifted various gears in my career. Good first 10 years in Gujarat with the World Bank leading the World Health sector investment programs as a young professional. Second, working with the Oval Office in the United States, working on the global price reduction of hepatitis B, hepatitis C, and for the ARV medicines. I led that programs for APAC. And then the third, the private sector, pure private sector, where I come to Reckitt, and I have now completed a decade here. And the role is external affairs and partnerships. When we started, company asked me one thing, like, how do you see this whole problem of hygiene? I say, I don't see it as a Dettol problem or Lifebuoy problem. I see it as something very differently. I need to drive the national purpose. And the first thing comes as a national purpose, followed by the brand purpose and the company purpose. And I say, I don't come from a sector. I am not the fast-moving consumer good. I want, like, hand washing should stay with the young kids. The education outcomes should be better. The health outcomes should improve. And are there studies? Is there research? How much do we invest? Or it's just a marketing gimmick, like you do some work with 2,500 schools and you say you have done some nation building. We started small with 2,500 schools, and now we are in 1.25 million schools in India on the hand washing. And that has given us a lot of insights, a lot of energy. We tested a lot of models, a lot of modelings. I learned a lot in my earlier avatar when we were doing the projection modeling for the HIV cases, using R and other things, I said, like, can we use the projection modeling here? We have good scientists, we have epidemiologists in our organization, we have good marketeers, we have the good NPDs. Everything is great. We are one of the most renowned brand, Dettol. Reckitt, like, people may confuse Reckitt with the Rickets as a disease, but at least the brands are good. Like, we have Harpic, Dettol, Durex, Lysol, Itchcard, Ringard, and 40 others, all top in the line. So the behavior nudges are very important, and working with 100+ community-based organizations right now in India gives us a very different and a very distinct advantage. Although we work with NDTV, I have my colleague Ambika from NDTV. She is one of the main anchors from there. We curated a programs with 40+ Padam Shris, 30+ Nobels, 8+ Oscar winners, and we did around 700+ hours of live programming every year on 2nd of October, which is called Dettol Banega's First India program. Today, a competition to NDTV also did a big news with Economic Times, and they are also mentioning that this is one of the biggest hygiene campaign in India. And it's at the front page. So I mean, say, when you do good, there is a lot of effort which goes into that. But seeing the problem upstream, it's very important. We need to have the vaccines. It's equally important, like, there's a very important read by Atul Gawande, the Checklist Manifesto. So what is the checklist? What is there? So that, like for the STI treatment, NACO has worked on the color-coded kit for the treatment. For bubo, there is something. For candidiasis, there is something. For chlamydia, there is something. In the tuberculosis domain, you have specific regimes for the XDR TB, for the MDR TB. You have the color coding very beautifully done, blue, red, and orange. So easy to understand. Can those easy things which are being tested and tried there can be brought to this domain also, so that there is a treatment standardization? And how through the media, which is very important pillar for the democracy, takes this further and makes sure stands with the government. We talked about the political will, Dr. Naveen, you talked about it, political will say vaccine diplomacy can happen. I'm very proud, like I saw it firsthand in Gorakhpur on the JE, because I've been working with the government on and off on various subjects from over now 25 years. I saw the JE, I saw like what media wrote, I saw like how that got converted, I saw like how the situation is now. And when Yogi ji calls खिचड़ी खाने के लिए on the weekend to Gorakhpur in his dham, तो वो पूछते हैं बेटा बुंदेलखंड के अंदर कुछ बदलाव कर सकते हो internal health में? So if a leader asks you so basic questions and what you can give back, which also makes you think, okay, we have money, we have resources, huge kitties in India, CSR funds, globally, global accelerator for the money. And then you have beautiful networks like AVPN and very credible line of doctors sitting on this panel and beyond. So with the help of anyone and everyone, if it is a national effort for elimination of something with a definite deadline, we all can achieve it. My best experience is with Ebola. When I was working on Ebola, there are a lot of learnings which I drew from there. Like Dr. Naveen, you just talked about, like, you know, you will be the first one who can take this vaccine, and you have taken it for the COVID. Dr. Dalbir Singh, you talked about, like, you know, twice surviving tuberculosis. So there are a lot of human interest stories which are required. What happens typically when the peak happens, media starts reporting on number of deaths and the casualties and the hospitals are getting filled. No one talks about, like, you have the weather forecast report. No one gives you the forecast report of Pune, Delhi, Gujarat. No, there is no way of doing it. And if there is a solid way, so that the big networks in India, I will say there are two big networks. One is the CNBC and second is the NDTV. And then you have a lot of regional ones also. If they pick it up well in time so that people are prepared enough to fight. It should not happen like you are giving AK-47 or something like that to everyone when, you know, the mosquitoes are just waiting for us to attack. So can the preparedness be better? So the disease preparedness needs to be better if we really need to fight back. And again, like there have been a lot of progress in the Indian public health domain in various disease, on polio, on JE, on smallpox eradication in 80s and all that. Ma'am, you talked about the new R&D in the private sector. There is a lot which is to be done on the newer molecules. AMR is on all-time high. We are one of the youngest populations. If the medicine standardization is not done and if the prototypes and the protocols are not followed well, we will be dying a lot, not because of dengue or with other disease, but AMR will kill us more earlier than anything else. Thank you so much.
Thank you. Thank you so much, Ravi, for bringing your passion and energy. And really, I love the visionary tone of this panel. It's wonderful to hear, you know, programs being scaled and how we can, you know, really achieve scale and go beyond just pilots and things like that. So thank you, Ravi. Let me come to Aisha next. Aisha, you know, Dr. Dalbir Singh actually set us off with a beautiful quote, which actually highlights who are the human faces for whom we're having, you know, all of this discussion here today. When we're talking about any disease, communicable, non-communicable, in your experience, what are the gendered barriers in access to care, especially in the context of communicable diseases like dengue? And how do you see these barriers affect health outcomes and their ability of women and other vulnerable groups to be able to seek timely treatment?
Thank you very much. And I have to acknowledge the fact that it's a delightful moment to be talking about dengue at such a big platform, because it's very rare that you really talk about vector-borne diseases. These are not as glamorous as others where you get a lot of global health funding. So I think it's a big, proud moment for all of us. So thank you so much to AVPN and to IT to really make this happen. And I think when we have to understand about quality access to dengue care, it's important for us to take a pause, step back, and really understand the whole ecosystem. What is it that really drives quality care for dengue? There are three big things in my mind. One is R&D, second is policy, and third is delivery and the access to delivery care. Now, when we really go back and understand R&D, we need to understand, is there a gendered lens applied to R&D, which basically means that do we understand the pathophysiology of dengue, how it differences between men and women? Maybe, maybe not. Do we have gender disaggregated data for dengue? Maybe not that much, as much we should be having it. And when we're talking about vaccines and clinical trials, are we really taking women into the design of a clinical trial? Are we involving pregnant women into the clinical trials? Again, maybe yes, maybe not. So I think it's not just about access to care, but we need to step back and also see if we are really involving gender at the R&D level. Second, when we are designing, second is policy. So when we are designing policies and systems, again, are these designs gender inclusive? Are we really taking into account the lived experiences of citizens, both men and women who are actually facing these diseases during outbreaks? Again, maybe not as much as we should be doing. And third, of course, is the delivery of care, of quality care, and the access to this delivery. And again, this delivery has to be focused, the design has to be focused through a gender lens. So I think what we really want to emphasize is that there has to be gender integration at R&D, at policy and systems, and at the delivery of care and the access to delivery. And when we typically tell this to different institutions and leaders, they come and tell us that, hey, Aisha, how do we do this? We don't have gender experts. And how I would typically tell them is that you don't have gender experts because you have not hired them. And you have not hired them because you have not allocated enough budgets for them. And that's because you, as a leader or as an institution, are not really believing in the power of inclusivity. So I think what I'm really getting to is that gender integration is not rocket science. It does need specialists. However, what it really needs is an intentional leader. A leader who can really be inclusive to the needs of both men and women. A leader who can be empathetic to the needs of both a man who stays in an urban area and a woman who stays in, let's say, rural vernaculum, which is the hotspot of dengue. So I think and also an intentional leader who can probably work at the intersection of health, climate, and gender, because now it's not just about health, it is about looking at health and diseases from a social perspective. So I think in whole, yes, there are lots and lots of barriers. You need gender disaggregated data, you need gender in R&D, you need gender in policy, you need gender in implementation, and only then you can really create systems which are very inclusive and which will improve the quality care for both men and women for dengue and other such vector-borne diseases. I'll pause here. Thank you.
Thank you. Love that, Aisha. In today's world, when we're hearing so much anti-inclusivity narratives, I love that we can be here and send out a strong message saying that it is absolutely a no-brainer to be taking a gendered lens to all diseases, and especially vector-borne diseases. So let me round off with Dr. Rajnikant. Aisha just talked about research and the lack of gender lens in some of our research frameworks. So Dr. Rajnikant, from where you sit at ICMR, how do you see public health research contributing to long-term policy frameworks for emerging infectious diseases like dengue, especially in under-resourced regions?
So research plays an important role. So whenever you make any plan, whether at the ground level, when you have to implement anything, it has to gone through certain protocols. So for example, when we are talking about the dengue vaccine, so currently ICMR is already engaged with the Panacea Biotech for the development of an indigenous vaccine. So once the trials are completed, it's phase 1, phase 2, or phase 3, and if it is successful, safety and efficacy, it is proven, only then it can be rolled out in the national program. Again, there are some regulatory issues also. Similarly, for example, the impact of climate change on the mosquito behavior. That is also very, very important. Only research can showcase whether the climate change is having any impact on the mosquito survival, its longevity, and the vector surveillance also. So climate is also playing an important role. And the third point is now we are talking about the One Health, because One Health has become very important issue, because environmental health, human health, and the animal health. Because most of the infections that they are happening in nowadays, they are happening because of the genetic in nature, from the animals to the human being. For example, the COVID-19, similarly the other CCHF and others, they are jumping from the animals to humans. And because of the deforestation and the landscape changes, these infections are happening. So these kind of a research are definitely needed. They will help in the policy making, and ultimately they will be rolled out at the implementation. Dr. Kalpana highlighted about the CFR. So the credit goes that at least the dengue is rising, but the CFR has come down. It is because the management is happening very fast. And while we were having discussions in the Tamil Nadu and in the Karnataka, then many of the clinicians, they also highlighted that the guidelines, they are not very effective. They want to understand in a very simple manner, and they are very complicated and lengthy. So that is very important, that we can provide the guidelines that the clinicians, they can understand. Even then, it is not very clear because the dengue is from asymptomatic to a highly complicated cases, DHF and the DSS, dengue hemorrhagic fever and dengue shock syndrome. So when you need to be hospitalized, Dr. Naveen was talking about that so much of people, they are going for the hospitalization, whether it is needed or not. So I think there is a need that we can find out when a patient is required to be admitted or not. What is the threshold for the platelet count? Whether 20,000 is the cutoff, 80,000 is the cutoff, when you need to go and consult the doctor and need to be hospitalized. So that kind of a thinking, debate, brainstorming is needed, so we can provide a proper guideline so that the clinician can understand. The third and important point that Dr. Ravi was talking about, Dr. Naveen also spoke about, that I also belong, I started my career from Gujarat. I worked for many years in Gujarat, and he has developed a Center for Excellence in Entomology. We started working in the area of entomology. It is my own fascinating area. So having worked in Gujarat, I realized that, and he is talking about the mosquito sculpture in Bhavnagar. So that we may create some awareness. So creating awareness and is very, very important. But the ownership, because we are talking about the community awareness. So awareness is good. We know something about anything. But unless or until if we are not following that thing. So awareness to ownership becomes very, very important. That is very, I think, is a need of the hour, that we need to take the ownership when we are talking about the dengue management. Then political will, you discussed about the political will, and he also shared about the Gorakhpur experience. And we are having our friends from the Gorakhpur. The political will plays an important role, because the Yogi ji, I was the director of the RMRC Gorakhpur. And in Gorakhpur, many of the people, and particularly the pediatric population, children, they were dying about the Japanese encephalitis. So because of the political will, immediately the infrastructure was improved, the ICMR center was started, and he was regularly taking weekly monitoring. How is the situation? Why patients are being referred to a tertiary care? Why not they are taken care at the primary health care center level? So now they have developed the entomology ETC, Encephalitis Treatment Center, and the ELISA facilities available at the district hospital. So we are talking about how we can strengthen the primary health care. So patients, they are not needed to go to the tertiary care. So here the political will can play an important role, and that has been proven in a Gorakhpur region from 5,000 to less than 100 cases. And Gorakhpur is a model that how we have been able to tackle the Japanese encephalitis. There is big, big success. Now we don't know, nobody talk about the JE is a problem there. Now we are talking how we can eliminate the JE and AES in Gorakhpur. So it is a great success. And here this type of a model, best practices where we have shown, even for the malaria, we have demonstrated through research. I am talking about the research in the Rahulkela area, in the Odisha area, in the Jabalpur area also. So there are different best practices where the PPP model or multi-stakeholder partnership, they are working together, whether the research institution, the state government, or the central government, they can work together, and we can demonstrate that kind of a best practices can be used for the dengue. Last point is about the media. Ravi was talking about the NDTV. So in Gorakhpur also, when I joined as a director of the Gorakhpur, so there was a lot of negative reporting from the media. The children are dying because of dengue, and this is the white elephant. They don't do anything because they don't know what the research institution, what the laboratory of people they are doing it. So having a regular conversation with the media people, because in ICMR, I was the head of the policy and communication. So regular interaction with the media people, so that the media, they can understand how the scientists work in a laboratory and how science is leading research to the policy translation. So media people, they are busy, but they also need to understand. They don't know the complexity of the science. So that the media interaction on a regular level becomes very, very important, and that helps. Now they have understood. We were having a regular media interaction, and we started giving training to our scientists, how they need to behave with the media people, how they need to communicate. If you communicate a complicated science, they will never understand. So you need to communicate your findings to the media people in a simple way so that they can understand, and that helped a lot. Yeah. And now during the COVID-19, I was heading the media cell in ICMR. So I had all the contacts, regular conversation with the media people across the country. So that is how the ICMR became a household name. Yeah. And we did excellent work during the COVID-19. So I think the media can also play an important role.
Absolutely. And thank you, sir, for sharing, thank you. It's excellent that you took on all this feedback and really were able to move from research to, like you said, action. Several times during the course of the session today, we have heard about the importance of lived experiences and community voices. So I'm actually now going to hand over to Dr. Sukriti Chauhan for an interaction with some very distinguished guests we have from Gorakhpur. Sukriti.
I also have the worst job. We have about 7 minutes to go in the session. Anita ji, aaiye. Round of applause. She is the most important voice in the room. Aaiye. Yahan aaiye. So Anita ji has joined us from Gorakhpur. Anita ji, welcome. Thank you हमारे साथ जुड़ने के लिए. बस 2 मिनट आपसे वार्तालाप करेंगे. थोड़ा सा अपने बारे में बताइए, आप कहाँ से हैं, कितनी आशाएं आपके अंडर काम करती हैं, और आशा दीदी इतनी ज़रूरी क्यों है?
मैं गोरखपुर से हूँ. मेरा नाम अनीता त्रिपाठी है और मेरा ब्लॉक है खोराबार. मैं 2006 से ही काम कर रही हूँ और हमारे गांव में आशा बहुत ज़रूरत है. इसलिए आशा की ज़रूरत है क्योंकि गांव में आशा हर एक घर में जाती है, हर एक घर की चीज़ों को पता है उन्हें, क्योंकि उस घर की जो महिलाएं होती हैं, उन महिलाओं से आशाओं की अच्छी बॉन्डिंग बनती है, मतलब बातचीत जो होती है अच्छी होती है. तो हमारे गांव में आशा की बहुत ज़्यादा ज़रूरत है. और अच्छी चीज़ें यह है कि हम गांव में आशा हैं और हर घर की चीज़ों को सुख दुख या स्वास्थ्य के बारे में बताना, उनको स्वास्थ्य की निःशुल्क सुविधा के बारे में, हर चीज़ों के बारे में बता के वहाँ तक जाते.
थैंक यू अनीता जी. डेंगू के बारे में अगर थोड़ा सा बोलना चाहें, जो काम आप करती हैं कम्युनिटी के साथ.
मैम, हम लोग आशा हैं तो हम लोगों के ऊपर हर बार प्रोग्राम आता रहता है और अभी हमारा प्रोग्राम चल रहा है 10 तक, और हम लोग हर घर में जाते हैं. हर घर में जाके उन्हें बताते हैं डेंगू के बारे में कि हमारे यहाँ डेंगू कैसे फैलता है. डेंगू जो है मेरे साफ पानी के ऊपर सतह में लावा अपना छोड़ता है, वो फैलता है, उन्हें कैसे हम ख़त्म करते हैं और कैसे ये पनपता है, दोनों चीज़ें हम लोग बताते हैं. तो हम लोग उन्हें उनके घर में जाके बताते हैं कि जो भी आपके जो बर्तन है, जो बरसात के पानी इकट्ठा हुए हैं, उन्हें आप नीचे गिरा दीजिए और बर्तन को सुखा दीजिए ताकि डेंगू के मच्छर मर जाए. और उनको ये सारी चीज़ें बताने के बाद फिर उनको अगर हम बताते हैं कि आपको निःशुल्क सुविधा मिलता है. निःशुल्क सुविधा भी हमारे सरकारी स्वास्थ्य केंद्र पे अगर किसी को तेज़ बुखार भी होती है या मुझे जानकारी होती है, क्योंकि हम लोग गांव में जाते हैं तो हर महिलाओं को हर घर में अपना नंबर दे के आते हैं कि आपको अगर किसी भी तरह की बुखार होती है तुरंत हमें सूचना दीजिए, नहीं तो वो मेरे घर तक भी पहुंच जाते हैं लोग, और घर में बताते हैं और मैं तुरंत वहां जाके उन्हें या तो 108 एम्बुलेंस से, तेज़ बुखार वालों के 108 एम्बुलेंस से पहुंचाते हैं, या हम लोग अपने अगर कम बुखार है तो उन्हें CHO सेंटर या अपने सामुदायिक स्वास्थ्य सरकारी केंद्र पे पहुंचा के उनकी निःशुल्क जांच कराते हैं. अगर ज़रूरत पड़ती है तो उन्हें हम निःशुल्क चिकित्सा भी प्रदान करने की प्रेरित करते हैं।
अनीता जी टाइम थोड़ा कम है बट आप बहुत लंबा सफ़र करके आई, थैंक यू वेरी मच एंड अ बिग राउंड ऑफ अप्लॉज। आई बैठे। थैंक यू अनीता जी, ओवर टू यू मैडम।
Thank you so much, Anita ji, for all the work that you do. We've heard it's so interesting. We've heard about these large aspirational media campaigns, but we're also hearing, critical. It's a multi-pronged approach to behavior change. We need an Anita ji and we need the NDTV campaigns to coexist, right? Now, I know I promised to all of you that we'd have time for audience interactions. I'm so terribly sorry. We're running short on time, but our panelists, as well as all of us, are available after the session to interact with all of you. But in the interest of time, I'd be remiss to close this session without launching this piece of work that we've really worked hard on over the last 5 months. Our EquiHealth Alliance, through all these consultations we've been doing over the past 5 months, has put together a report. This report highlights... This report is titled Advancing Access and Strengthening Dengue Response, Lessons from Tamil Nadu and Karnataka. This report highlights actionable recommendations that align with broader national and regional health strategies, emphasizing the importance of multi-sectoral collaboration, policy integration, and sustainable financing models. Through these insights, what we aim to do is really inform decision makers like all of you here in the room today to catalyze partnerships and drive long-term investments in equitable and effective healthcare responses. So with that, may I please request our distinguished panel to just come up on stage. We'll hold up the report. And we're honored to be launching this report here right now at the World Health Summit. So thank you all of you. Please, ETI team. Chu Beng, would you like to join us, please? Thank you. Please come in here. Thank you. This report will be available online for all to share with all of you very soon. We will send a link around. In the meantime, thank you so much for joining us today, and may I please request Dr. Dalbir Singh to just 1 minute to just close out this session. Thank you. Thank you so much.
Well, I'll only take half a minute. No, I would only like to thank all the panelists to begin with for very, very valuable, insightful inputs and suggestions that they are given. I'm sure AVPN has listened to them. And today's dialogue also reinforces the fact that dengue is a problem. It's a serious problem. 2024, 235,000 cases, 250 deaths. And while that may not include all the possible data, the things could be much worse. It has become an epidemic in almost every region of this country. It's an annual epidemic now, and it's growing hugely. But apart from touching climate change and a couple of other technical points, one thing I'd like to highlight here, this is something that needs to be spoken. The point is lack of hygiene, lack of sanitation. Okay, there are certain fundamental issues we have not spoken about. We all need drinking water. If there is no water to drink, where are we to? We all need to store water. Like Delhi has almost close to 48% population living in, ghettos and all makeshift colonies and unauthorized colonies. Look at Mumbai. Look at all these metropolitan cities. So what are people going to do? They're going to store water. They're going to have coolers. They're going to do all kinds of things. So let us focus our attention largely on prevention. Why the hell should it happen to begin with? We are all curative. Our mindsets are our chip is so driven that we are only thinking of biomedical curative approach. Why should it happen? At least a thing like dengue must be prevented. It is largely preventable. Okay, as it is, many of you experts have said there is no cure for it anyway. Then why don't we prevent it? Let's focus very large part of attention on building consensus on the fact that it must be prevented. If people need containers, containers must be covered. If mosquitoes have to be taken care of, whether you put a statue or not, Ravi brought out that fact that in Gujarat they want to put up a statue, it's okay. People are frightened enough. People have had this disease for the last so many years. Therefore, I'm very happy that at least it reinforces that all of us need to sit together, work, in all the sectors, bring all the disciplines together, and then find very, very practicable and workable solutions. A lot of innovative ideas also come forward, and I'm sure AVPN will put together and recognize that we need public-private collaboration, sustainable financing, and accessible therapeutics. We need research, we need more money, we need social investors. So I'm sure in days to come, we'll certainly translate this to very implementable, equitable, and pragmatic policy and actionable solutions. Thank you very much.
Thank you so much, Dr. Dalbir Singh, and great conversation. Maybe 30 seconds more. I feel very proud as an Indian too. I think that we have such minds, public health experts, what Dr. Rajikant also talked about, the research that is happening in India for the vaccine. I just want to share one thing. The prevention piece is so important. And I think bringing a complete, holistic, multi-stakeholder prevention and control of dengue, recognition of what needs to be done, who needs to be. I think we just need to remember that as of today, dengue is a VPD. It's a vaccines preventable disease. Okay, I think there cannot be a better accomplishment of science than what we have today. So I just want to say that today the ambition of making a zero dengue, like what we did with zero polio, I think all of us have seen that. I think because it's a VPD, and I think we just need to drive this equitable access for a complete holistic control and management for dengue. I couldn't just stop myself. I'm sorry for it.
Couldn't be a better way to close out this session. Thank you for staying with us, even though I know it's a little bit over time. Please, I'm sorry we couldn't get to Q&A, but our wonderful panelists are all here, so I hope you're able to interact with them one-on-one. Thank you so much.
Yeah, before you leave this room, remember 16th of May is National Dengue Day. Yeah.
NHS, right? And end up in other systems. And part of the reason they choose to leave, sure, there's some aspects of exploring the world, but a lot of it has to do with being able to work at the top of their license, right? So we do try to enable geographies around the world to have technology that allows clinicians to solve problems locally.
Sorry, I think I got disconnected. Can you hear me now?
Hello. Hi,
You're muted,
Manas.
Mana. Sorry, that's why I cannot hear you.
Hi,
Yes,
Yoti.
no.
Yeah, okay.
Yes,
Yeah.
we're there. Yeah.
Now,
I,
so we
Am
can
I
see
audible?
on the screen they can see.
yeah. Mm.
Hi, Manas. Am I audible to you?
Oh my God, I am so big on the screen.
Yes.
Hi,
It's too big.
Manas. Am
We
I
can't
audible?
hear her, so I don't know.
Yeah. I hope they cannot hear us. maybe we cannot hear them, but they can hear us. That will be strange.
We can't hear you.
You cannot hear me also?
No, I can hear you. They can.
Hello, Yoti.
Okay.
Can you hear me?
Yes. Now we can hear you.
Okay,
Yes.
thank you
Now
so
we
much
can
for
hear.
joining in. Thank you.
Sure.
So we'll be starting it in a while. Just wait for some time.
Okay.
Okay. Okay.
Now we cannot see them.
But it's not. Excuse me. ये presentation move हो जाएगी? कब उधर से जब हाँ वहाँ पे मैंने दिया है.
Hello.
Good afternoon, one and all present here. I, Dr. Piyusha Majumdar, Faculty, S.D. Gupta School of Public Health at IIHMR University, welcome you all in this very interesting session on building capacity for implementation leadership, innovation to ensure health equity in the Southeast Asia region. So before we start the discussion, let's just look at this video and find out what IR is all about and how IIHMR, TDR, UGM, University Gajadhar Madhya, they are collaborating with each other to make implementation research and doing the capacity building in the area of implementation research in India. Can you just raise the voice? Can you just work on it?
The whole idea is to find the gaps in implementation that work as barriers and how we can work on removing those barriers and then improve implementation. So this workshop that we are organizing is to develop curriculum for master's program focused on implementation.
What I think will also benefit is that the students who are taking these particular programs, when they go back home, it will benefit their workplace and also the staff that are involved in this particular program.
The future, I think, is growing. There is a huge interest in implementation research. As you see that we have challenged to eliminate many diseases today. So therefore we need this new area to reinforce the disease control program.
Implementation science program, actually it's a unique program that are supported by WHO TDR program, and we are as a cohort one, we should represent ourselves as much as we can.
So I think for young career IR professional, be open mind, because the opportunity can be from everywhere, even whatever your academic.
Pleasure to be here in Indian Institute of Health Management in Jaipur, which is one of the partner organizations, partner university with us, which we call postgraduate training scheme, and it's one of the 7 universities that we work with in
opportunity can be.
Okay, so the video that you just seen here, it tells about the work that we are doing at IHMR University with support from TDR. So the discussion session which we're having it here, we will be discussing more about the regional priority and challenges in implementation research. The esteemed speaker of this panel are Dr. Gary Aslanian. He's the moderator for this session. Dr. Gary is the Manager of Partnerships and Global Engagement, TDR, World Health Organization, Geneva, Switzerland. He manages TDR's collaboration with 6 regional WHO offices and also coordinate with the Essence on Health Research, which is an initiative of Research Funder. He also worked as a Principal Health Advisor and Director in the Federal Government for the Public Health Agency of Canada and Global Affairs Canada in Ottawa, Canada. And he's also the Editor-in-Chief of a new special magazine, which is a publication of UN staff in Geneva, Switzerland. Welcome, Gary. Now I request you to please come to the dais. I request everyone to give Gary a very big hand. Our next esteemed speaker for this panel is Dr. S.D. Gupta. He's the chair of the session. Dr. S.D. Gupta needs no introduction. He's a leading public health professional with a distinguished academic and research career. He has obtained his MD from India and PhD from Johns Hopkins University, Baltimore. He was also conferred Fellowship of Academy of Medical Sciences for his outstanding contribution in the field of public health. He has done pioneering work in the system strengthening. Dr. Gupta is a distinguished professor at IHMR University, adjunct professor epidemiology for Johns Hopkins University School of Public Health, Gates Leadership Fellow, and President Indian Institute of Health Management Board. Sir is also the president of WHO CRO's Southeast Asia Public Health Education Institution Network. Sir has championed the cause of quality improvement and capacity building in healthcare and implementation research in India and Southeast Asia. He's also a recipient of the prestigious Kim Pro Award. Welcome to this panel, sir. I request you to please take your seat on the dais. Our next esteemed panelist for this session is Dr. P.R. Sodani. Dr. P.R. Sodani is the president of IHMR University, Jaipur. He's a distinguished health economist and public health specialist. With a PhD in health economics and a Master of Public Health from University of North Carolina at Chapel Hill, USA. Dr. Sodani has mentored faculty, students, and research scholars for over 2 decades. He's also the co-founder and director of IHMR Foundation and promoting startup and innovation in healthcare. His leadership role includes Secretary General of the Southeast Asia Public Health Education Institution Network, and he's also serving as a member of various expert committees at the national and state level. Welcome to this panel discussion, sir. I request sir to please take the dais. We have another esteemed speaker from University of Gadjah Mada, Indonesia. He has joined us virtually. Unfortunately, he could not join us in person. So Yodi is there with us. Hello, Yodi. So Dr. Yodi Mahendra Datta, he's a dean and professor in health policy and management at the Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia. He leads the Southeast Asia Regional Training Center for Health Research, supported by the Special Program for Research and Training in Tropical Disease. He's also a member for Evidence-Informed Policy Network Global Strategy. He's a scientific advisory board member of the Institute of Tropical Medicine, Antwerp, Belgium, and also a member of WHO Technical Advisory Group of Experts on NCD-related research and innovation. Welcome, Gary. I'm happy that you have joined us virtually. Our next speaker, esteemed speaker for this panel discussion is Dr. Mahnaz Wahedi. Dr. Mahnaz Wahedi is leading WHO TDR program on providing postgraduate training scholarship across 8 universities in the low and middle income countries across the globe. She has successfully led several WHO TDR and Minister of Health joint clinical trial in Cameroon, Ethiopia, Malawi, Nigeria, South Africa, Uganda, United Republic of Tanzania, and Zambia. She has more than 25 years of experience of capacity building and research network, and she's leading both implementation and intervention research. Welcome, Dr. Wahedi. Our next speaker, distinguished speaker for this panel is Dr. Bonta Babu. Dr. Bonta Babu is a director, he's scientist G and head Socio-Behavioral Health System and Implementation Research Division of Indian Council of Medical Research, New Delhi. Sir is also in the WHO expert panel on parasitic diseases and WHO TDR scientific working group on lymphatic filariasis. He's also involved in public health interventions, which is including implementation research in 21 tribal districts in the country to improve access and quality of healthcare in the context of universal health coverage. Welcome, sir. I request you to please take the seat on the dais. And the last speaker of this session is me, Dr. Piyusha Majumdar, and I have already shared my introduction earlier. So as I said that I'm an associate professor at IHMR University, WHO TDR coordinator for postgraduate training program and implementation research, faculty member listed in IR Collect platform supported by TDR. I'm also working as a teaching team member for developing lecture and case study based on the core competency in implementation research. Beside this, I'm also producing a podcast by the name of Ensure Health. Now, after this brief introduction, I request Gary to please take over and start the session. Thank you so much.
I'm not going to go there. I'm going to start here. And just to reiterate again the focus of our session and discussion today, I'm hoping that at the end of this, you'll leave this room with more ideas what you can do in your work wherever you are, in health system, in whichever level or whichever part of it you are in India or in the region. And this will kind of inspire you from the examples and the applied examples of implementation research that you can actually look at it and say, am I doing this right? Can I do this better? Can I apply more implementation research in my work? How do I use more evidence? How do I identify priorities? What are the priorities that are out there? And how can they be more useful in your context? So keep that in mind as you listen to wealth of knowledge that is in front of you, excluding me, and learn from them and ask questions. So for us, at first, to set the stage, I'm going to ask Dr. Gupta to kick off the overall presentation. And then I'll go through each of the panelists with specific questions. Over to you, Dr. Gupta.
Thank you so much. Okay, thank you so much, Gary. And let me welcome you all to this very important session on the emerging area of research, which is so critical. We are quite aware of this fact that almost all countries have sound policies for improving healthcare or making health of the people as first priority and make them productive and live a happy, healthy life. They also have very sound strategies. and they also have good implementation plans. So develop plans, but the key question is, yet the goals are not achieved. We are far behind. And I like to refer to the universal health coverage, which aims at improving access, availability, and utilization of healthcare and reduce inequities. In addition, to protect catastrophic health expenditures. The other thing that has come in on the global scene is the Sustainable Development Goals. And we need to achieve those goals by 2030. What is happening? There are wide gaps in the goal set and where we have come to, what we have been able to achieve. There are wide gaps. There are so many evidence-based interventions are available. They are all tested. They are available, but not integrated with healthcare systems. The uptake is very poor because there is a clear cleavage between the researchers and the health systems implementing workforce. So one is that to bridge the gaps in what we need to achieve and what we have achieved is to bridge the gaps between who know about it and those who are responsible for doing. And that is bringing researchers and health systems, healthcare providers together to promote evidence-based interventions, which are already tested. So to improving the coverage, improving access, improving availability and utilization, thereby reducing inequities is the focus. What we need to do, then we need to implement our programs, health programs effectively. We need to understand what are the gaps. Very important about effective implementation is what are the barriers that do not let you achieve the goals. Those barriers may be embedded in the intervention itself, maybe in the health systems, maybe human resources, maybe logistics and supplies, maybe the community lack of awareness or lack of interest. Now we need to find the way how to make implementation effective and achieve our goals. And the science that has emerged now and IHMR University is focusing on is implementation research. So IHMR University offers Masters of Public Health focused on implementation science. What we are trying to do in that? We are building capacity in implementation research. But implementation research itself is a very complex research. And very important thing about it is very contextual and it is in real world setting. So you need to work down the line, those who are responsible for implementation. So not only that we build capacity in implementation research, but we also build capacity in leadership in implementation research. The whole idea is to reduce inequities in terms of equity, inequity, in terms of access, in terms of availability, and achieving or improving the performance of our health programs. So this program, this panel would focus on implementation research, and we'll go to it. And so very important thing, this is different than what we talk as health systems research or operations research or health survey research. Enough has been done. We have now evidence, proven evidence, with the strong fidelity of those interventions. We need to integrate those interventions in healthcare delivery systems. And how can we do implementation research is the means to do that. And we need to build capacity of people in understanding implementation research, designing implementation research, ability to write research questions. I think half, if the research question is appropriately worked out, then half the research is done. Because you have already set then objectives and goals and the study designs, everything is very clear once you have a clear research question in your mind. So we'll work on this today in this session. And so this is what the context is today to organize this session. Thank you very much, Dr. Kerr.
Great. Thanks for that. So quickly though, if some of the people in the room may say, what are they talking about? Can you quickly give an example, any of you, from your recent experience where implementation research was used in the system? Very crisp and short example. Who wants to go first? Please. Just give people a sense of what are we talking about with a specific example in the health system where IR is making a difference.
Yeah, first I would like to thank the organizers for giving this opportunity. It's two ways. The first is, if we strengthen the implementation in the country, obviously the health system will be strengthened. Once the health system is strengthened, implementations will be successful. The best example which we are doing since a year is, you are aware that particularly the Indian delegates here are aware that the primary health care is the focus of the current government, and we established health and wellness centers. In Hindi it is called Ayushman Arogya Mandirs. It's a new institutions, health institutions or health facilities meant for 5,000 population, and with the new cadre as well as expanded services which are called comprehensive primary healthcare services. But though this scheme is initiated in 2018, okay, much implementation research has not been occurred, and thereby since 2023 I can say that nothing happens seriously. Unfortunately, people don't know what are these facilities and what services are available, and simultaneously the facilities, the human resource in this system are not aware what to provide. Then we initiated implementation research across the country with very technically. The sir said initially we started with developing a research question, and based on that identifying the gaps, then addressing those gaps at system level, at policy level, or implementation level, as well as in the community level. And we could achieve now, to some extent, that people are able to utilize many of these 12 comprehensive primary health care services. This is one of the best examples which India is witnessing. And subsequently, I will also talk about these studies which India has recently initiated nationwide studies. So this way, what is happening, the health system is also strengthening in addition to successful implementation of these programs. Like that, there are so many, because particularly in last few years, we are working on sickle cell disease elimination mission, where the system is unable to perform anything despite of having so many guidelines. But the implementation helped in some of the districts to happen these things by providing what is missing in the system, like training and capacity building in the manpower. This kind of things the implementation research has addressed and could achieve some of the targets. These are some of the examples, and I can in the coming minutes I can explain more.
Okay.
With this I end here. Thank
Great.
you so much.
Any other volunteers quickly? Piyusha?
Can I?
Oh, okay. Manaz, go ahead.
Thank you so much. Can you hear me well?
Yes, yes.
Great. Thank you so much for having me. I'll be very brief. I'm just going to showcase one of the examples of the implementation research that TDR has also been involved in Southeast Asia. Visceral leishmaniasis we know that is close to elimination in the Indian subcontinent with the sustained support of many partners, including TDR, in both clinical and implementation research that shaped the regional Kala-Aza elimination strategy. This research provided new therapies, evidence for country-level strategies, and improved methods for active case detection, rapid diagnosis, early treatment, and vector control. So in a way, it definitely contributed to a strengthening of the health system in the Indian subcontinent. And this was done in collaboration with TDR, with national program. I think Dr. Babu is someone who was involved in this program and who is now in this panel, which led to the effective adoption of new tools, policies, and reducing the disease burden. So over 20 years, this cost-effective, replicable partnership saved millions of lives with an estimated investment of around $20 million. Similarly, in Bangladesh, between 2006 and 2021, this effort averted 5.9 million Dalis. So right now, new efforts been made to eliminate VL in East Africa, and based on the lesson learned and also TDR catalytic role in South-South collaboration. So in other words, this implementation research not only contributed to strengthening the health system, but also strengthened South-South collaboration, and other continents learned this lesson on how to make this elimination strategy specific to their context. So I think this is something example which is very close to our heart in TDR and is very relevant to implementation research in Southeast Asia. Over to you. Thank you.
Okay, great. Good example. And hopefully you got a bit of a sense. Now, unless there's somebody else wants to jump, I'm going to ask Yodi next to tell us, because you've sit on many committees, was a long presentation of all the things you do, Yodi. So you can tell us, are there such things as implementation research priorities for the region? And what are they? Or how is this done? And how do countries identify or regions identify priorities for implementation research? Yodi, you okay with that?
Yeah, sure, sir. Can you hear me, Gary?
Yes, we can.
Okay. So thank you for the questions, Gary. Now, it's a bit challenging to answer because there is actually not much documentation of priority setting for implementation research across the Southeast Asia region, which you can access publicly. So what I can share is based on limited observation of my work through TDR, which is based on a few countries in Southeast Asia, not the whole Southeast Asia region and not every single initiative of IR priority setting, because there are other players also in the ground. I'm working through TDR, but I know Alliance is also working, WHO and city department is also working, so those I do not have access to. But in any case, what I'm seeing is that when it comes to priority setting in some of the countries which we have been engaging on, but there is a variety. I mean, in some places you see it happening, meaning that there are defining IR priorities based on local needs. In some places it's just starting, in some places not happening. Now there are challenges. I think the main challenges is also mainly because the capacity for IR it's still very diverse across the region. I mean, if you don't have that in place, it's very difficult to actually do IR priority setting. That's why the work from TDR is still very much needed in terms of building capacity, because that's the basic, no? When you really need to have strong IR capacity before you can actually do IR priority setting. And that is still varied. In some countries, it's pretty much there. In other countries, it's still very weak and it's more strengthening. So that needs to be there. At the moment, many of the IR capacity building is still very individual based, so individuals being trained. But I think we need to go beyond individual training, go more toward institutional capacity building in terms of IR, because that's the main thing that you need before you actually can get to IR priority setting. That's one. Yeah. The other challenge in terms of defining IR priorities based on local needs in Southeast Asia region, in some of the countries we work with, is of course resource constraint. Because you do have limited resources in many of these countries, and it makes priority setting even more challenging. And also it means that you don't have much control over many things. That means it's limited what you can do and you can actually work with in terms of priority setting. And that comes to the third one that you see also in some of these countries is the difficulty of balancing between local priority and global priority. You see that because with resource constraint setting, many of the implementation research are donor driven. So many of their priorities are still driven by global priorities rather than bottom-up local needs. So that's the challenge also at the local level, to actually balance that, because you have to be able to work with the reality where most of the resources for the IR at the moment is still from the global north and from the donor, and there is still very limited that you can work with. So then you have that challenge of trying to align between your local priorities and the priorities which are coming from globally. So yeah, I think that's the main thing, Gary. So I see that there are challenges of really having clear priorities of IR based on local needs in many of the Southeast Asian countries. Over back to you, Gary.
Okay, so great. But you also mentioned that at the end of the day, of course, it's priorities, but it's also the health priorities that need to be dealt with. And in a way, IR aligns with them. So, and earlier we heard from Dr. Gupta that a lot of IR is context specific. So in a way, perhaps it's also kind of explaining why it's hard to have sort of regional level priorities so clearly defined when some of this needs to be defined at a more level of the country or level or part of the country or a system. So that might be explaining this, what you called limited list or limited list of priorities that we have. So it's not maybe, it's not a challenge. I guess it just explains the reality of what we're dealing with here and how the needs are defined. Another thing you mentioned was different players, and I'd like to ask Dr. Sodani to give us a bit more on how governments, academic institutions, and funding bodies shape these priorities from your experience.
Well, thank you, Gary. And like as far as academic institutions are concerned, the academic institutions have very critical role in implementation research. Academic institutions, there are a lot of scope to work with the stakeholders, and I can divide into 2 to 3 major areas where the academic institution or the research institutions can play the critical role. Like IIHMR University, which is a postgraduate research university, particularly working in the health management research area since last 40 years. We are very closely working with the government partners, non-governmental partners, development partners in the whole domain of the health management and strengthening the health systems overall. As far as capacity building is concerned, yes, we have already initiated 2 to 3 major examples to strengthen the capacity. Number one, we have started a postgraduate program that is known as MPH in implementation science. I think this is one of its own kind program in India, and none other institution than IIHMR. They have thought about it, conceived the program in support from WHO TDR, and we are very happy to share that participants, like the global participants, they come to IHMR to learn the implementation science. And the happy news is that when the student pass out and go to their own country, they are basically implementing the knowledge which they have gained in the 2 years period in real setting, where they are supporting the government and non-governmental partners in their own country setting. So this is one of the example that what as in higher education institutions we can contribute in implementation science, or which we can say implementation research. The another point that what as in higher education institution, we are also thought about that let's plan something for in-service people. Like Masters of Implementation Science, it's a full 2-year program for the fresh graduates, but we also thought that the people who are already in service, they are working with the government for 10 to 15 years. Why don't we should also think about those people, those who are already in the health system, try to enhance their capacity building as far as implementation science is concerned. So we have also conceived a online program of capacity building for the people who are already with the academic institutions in the Southeast Asia region. So as a Secretary General of Southeast Asia Public Health Education Institutions Network, we have a network of institutions working in Southeast Asia, and all these institutions are the public health education institutions. So that is also one way that to educate the public health education faculty in terms of the implementation science, and we have started that online program for CFIN member countries. So around 40 people from Southeast Asia are participating in that particular program. Dr. Gupta is the founder to conceive that program, and we have, I think last month or this month we started this program through online mode. And response is very huge, very great response we received from Southeast Asian countries. Third, we are also working very closely with the Ministry of Health and Family Welfare, Government of India, to support the Government of India's, in a sense that the government is implementing a lot of health systems schemes for the country, like the free diagnostic scheme. It's a very, very important scheme to reduce the out-of-pocket expenditure of the people. And IHMR is contributing to the Government of India to assess the schemes. So we are providing our inputs, technical input, in implementing of such national level schemes. We are also working with the Ayushman Bharat, National Digital Health Mission and National Health Authority, where we are supporting the Government of India in creating a capacity of researchers in India so that they can do much more needed research on the priority areas of the Ayushman Bharat, and also trying to give input to the Ayushman Bharat that what need to be done by the government. So these are the critical inputs what I think as a higher education institution we can provide to the students, to the in-service people, to the government, and also to the implementing partners who are implementing such schemes. We are also working with the like WHO and other such agencies where they are also supporting us in a lot of research agenda, that the government is implementing a lot of schemes for strengthening the health system, but at the same time some research input is required. So research, I think it is one of the essential component when we talk about the health systems strengthening. Since the research gives us, research provides new knowledge. So that new knowledge is very much essential for a strong implementation, and we can correct ourselves, take the corrective actions, and prioritize our areas. as far as low and middle income countries are concerned, I would again re-emphasize that why the research is important. We all are working in a resource crunch setting. We do not have much resources, but we have huge burden of disease and all other things. So the setting or the context is very, very important for all of us, that why we should focus on the implementation research. And we should learn that how we can optimize our resources, how we can take the maximum output of these resources, whatever we have, so that the people can get more and more health outcomes, and we can be more and more provide good health outcomes at the country level. So it's essential for the government as well as the non-governmental partners. Everyone is very, very important for health system strengthening. And research comes with the new knowledge, and that new knowledge comes into the implementation of the schemes that will give us new direction and the correct directions. That's all about it. If there is any question, I would happy to take that one. Thank you so much.
Great. Thanks. I'm sure there will be questions. But just to say that, very commendable to see how you think of not just being an academic institution, but also being linked to these other players in the system and proactively engaging with government. But I wish it was so simple, and it's not. So I'm going to ask Dr. Babu, what are the challenges of using knowledge once it's available, once it's there for the policymakers, for those who are implementers? What kind of tricks or what kind of experiences you had that you can share with us that will be useful?
Thank you so much.
I don't think your microphone is on, or you're not close enough. Just speak to the microphone.
Yeah, it's working?
Yeah, much better. Yeah, speak to it.
Right. It's very challenging and also very interesting area for any implementation research practitioner, because undertaking research is one aspect, and the second aspect is working with the system, health system, or policymakers and health administrators. It's really challenging and very interesting also. Sometimes that led to a lot of frustration also, particularly those who are really working in implementation research. See, I think I need not say again that implementation research play a very crucial role in informing evidence-based policies, and also the knowledge on how to make the proved interventions implementable. This is very, very important. But coming to the barriers in translating this implementation research or the policies or interventions into policy making as well as implementation or execution are very vital, because now the governments, particularly India and other South Asian countries, are now understanding that issue and they are practicing. The first and foremost is inadequate communication and collaboration between the researchers and the policymakers or health system people. See, this is a major barrier which is disconnecting the world of the researchers with the policymakers and implementers. Okay? You are aware that we, the academicians or researchers, are very interested in publication of their research findings rather than targeting the implementers. Most of the time it happens. We will be very happy if our research is published in Lancet or New England Journal of Medicine or any other good journal. You are happy and you feel that it's absolutely done. But that's not the thing. Okay? We have to have a structured mechanism such as policy forums or policy briefs, or developing some kind of a knowledge transformation platforms to carry the message of this research to the policymakers and implementers. That is missing in academia. Now, of course, changes are happening. I will explain that also at the end of this my talk. Because I would like to say that earlier also I used the important program of the country, the primary health care in India, through Ayushman Arogya Mandirs, that is health and wellness centers. They have been started in 2018, the scheme is started, but almost till now, the implementation is not happening, and researchers are working and saying that this scheme is good, but it is not happening the way it should. And also policymakers are also very disturbed that whatever we planned is not happening in the ground level, that is in the health system level. But these people are having solutions, and these people are having problem, but they never connected. This is an important issue, right? The other one is the organizational, lack of organizational readiness. What is the readiness of the system? That is also missing, that health system never feels the need of evidence. If you see any example, right from establishing a tertiary care hospital, because we are witnessing establishing so many new aims, topmost tertiary care hospitals in the country. If you see the places they established, you don't find any evidence or any reason for why they put this hospital among very big hospitals in a city like, you can see any national state capitals. But there is no evidence, no data, no rationale. Just many times we people sit and decide that it should happen like that. We never see that we need to have some kind of, we don't have that culture. That is very unfortunate event. But what I am seeing is to some extent that it is a history, and now slowly changes are happening. That is very positive and very promising. And we can say that the another one is there is no dedicated to what you call manpower or a room for in the health system or policy making system to review the data or to translate the data into evidences. That kind of system is absolutely missed. Right? If you see, of course, in the national level now we have NHSRC. NHSRC give some kind of evidences to the government now. But if you see in the state level, okay, earlier some of the states have started state health system resource centers, but again they closed those, okay, because they never felt that these are important. So that space is not there in the system. Okay, they could not create a space for such kind of what you call evidence synthesis and translating the data into the evidences and to practice. That is missing. Okay, and also if you see the system, that the memory is very less. Today there will be one secretary, within 1 year or 1.5 years he will be moved to another department and another person will come. Even in the district level also we seek frequent what you call transfers, and overall the institutional memory is very weak, and this is because of lack of what you call structured repositories of data or evidences. This is okay, because I told many times that lot of, how much time I have? No issue, right? Okay, 2-3 minutes. Okay, right. See, for example, this primary health care, again I will tell the same example, which is very burning topic in India now. Center has developed so many manuals, but even those manuals or guidelines are not transferred to states to implement effectively. This is the gap. Okay, there is no system of in state health departments or district health departments to analyze what evidences we have to make implementation more successful. This is a big lack in the country, and maybe a similar situation maybe in other developing countries or other South Asian countries. Okay, the third one is the poor translation. I told partially about this poor translation of research findings. Many times we fail to, I told already that we will be very happy as researchers that to publish rather than to make use of these findings in the system, in our own country. Suppose if you work in one PSC, for example, and you find that immunization levels or childhood immunization uptake is very poor, and you don't like to speak to the local medical officer to say that this is the reason, that's the reason your primary healthcare center area is not receiving, our kids are not receiving enough vaccination. Okay, we don't have that culture of informing that what we found in the research. Okay, because many of you are here, many students are there. Suppose if you work in a small area like a sub-district area, and if you do some research, please try to communicate the findings of that research to local authorities. Okay, that is the culture we have to nurture. But that is missing. But always we think that we have to publish that, and that is the indicator for our success, right? So now, ICMR also, because we are one of the, I think most of you are aware that ICMR is premier research body in the country. We are promoting for our scientists that, okay, this is also one of the indicators. If your research is useful for any program or any guidelines, that will be counted better than a publication, right? The next is lack of capacity, time, resources for knowledge translation. I already discussed partially that most of the policy departments and health management or, I mean that health system or program implementers have lack of resources, generally lack of manpower, as well as there is a what you call critical research integration is missing. Okay. For examples, because we know that many people, particularly communities, are not aware of the programs, but at the same time we have the data, but we are unable to use the data. Why it is not happening, why people are not aware, because we have the data, but we are not able to use the data. Okay, these kind of issues are also very high. And last one is the political and bureaucratic obstacles, because the poor perception of the importance of research among the bureaucrats. Because I struggled a lot. I can tell you my personal experience that when I go to the district magistrate, who is the head of the district, okay, to convince that this implementation is very important, the first answer you receive is that everything is perfect, we don't need any research backup. They never acknowledge that things are not happening well. They don't like to accept. Even if you go to district medical officer, he says that, no, sir, our staff are very efficient, we don't want any kind of help from researchers. Okay, and also they think that research is something different. It is very academic, and they are nothing to the implementers. This perception is very, very, very prevalent in the country. Maybe I don't know about other countries particularly, but in India, this is the prevalent perception among bureaucrats and even politicians. Right? They have their own priorities. To address these barriers, okay, countries must invest in dedicated knowledge translation infrastructure within the ministries or within the districts and sub-districts also, maybe in states, in Indian context. This includes setting up of evidence cells, fostering long-term partnership between the medical institutions or research institutions and decision makers, maybe the policy implementers. Particularly in Indian context, we have medical colleges in each district in the country. Across the country, we have medical colleges. The district health system can be linked to the medical college so that they can give, periodically they can inform what is happening in the district in implementation. Right, that is very important. And incentivizing the policy related research. Now it is happened, we started in ICMR that, okay, equally along with the publications, each scientist's work will be seen that to what extent this work has been used in the, either in the policy making or implementation level. Right, that is also incentivizing the policy relevant research in the academia is also important, and embedded implementation research into the programs. Okay, the programs itself can establish. Now we have a lot of manpower. IHMR and other institutes are producing a lot of students who are having IR expertise. They can be put in the program so that they periodically they do enough research and they support the program. These are all the which are the some of the solutions. And recently, ICMR, Indian Council of Medical Research, has started many IR programs with the in collaboration with the state governments and national government, because we identified the issues which are very priorities to Government of India. In a 3-4 meetings with the Health Secretary of Government of India and ICMR, and they informed us these are the problems which the government is facing, and we initiated implementation research programs. And across the country, we are closely working with the state governments. They are yielding some results now. And also, as I said, the incentivizing the researchers also added that people are very much interested to do academic research rather than the implementation research. Now people are also in favor of doing implementation research, and they are not so crazy of publishing, rather they want to put their research findings in implementation. Right? With this I stop here. Thank you so much.
Okay, great. Thanks for that. And I'm sure many of the our audience here would be relating to many of these points, or recognizing your own situations where you've encountered these challenges, but also some of the solutions that you heard that one can employ and adjust and adopt as needed. I mean, these things are not avoidable. They will be with us probably. It's a bit of also a culture of research versus practice. It's perennial, but it does not mean that it has to be with us forever. If we recognize these things early enough, we can mitigate some of this. So my next question is to Manaz to tell us what is the role of international organizations to help with implementation research, either priorities or use or acceptability or application of it to achieve global health goals.
Thank you so much, Gary, for this very important question. In my opinion, international organizations and development agencies play a crucial role in supporting region-specific implementation research needs by providing a variety of catalytic roles in providing resources and expertise. Professor Yodi and also Professor Babu earlier mentioned that this is extremely complex, both at the national and also at the regional level. One area that I think is critically important is international agencies can provide direct seed funding. Organizations like WHO, TDR, UNICEF, the Global Fund, Gavi, Gates Foundation, NIH, Wellcome Trust, and various national development agencies offer grants and funding mechanisms specifically for implementation research projects in different regions in low and middle income setting. These grants can support the design, conduct, and dissemination of research findings. For instance, TDR has been doing this for over 5 decades. And we have been a leader in research to address infectious disease of poverty and building capacities of people, community, and institutions in those settings to equip them to perform research. And the other area is providing technical assistance. But before we go to the second point, I just want to emphasize that the international organization and aid agency also have to be very careful so that they don't create an area or environment of aid dependency. The recent changes in the global health architecture, where some funders are withdrawing or channeling their activities to other areas, is a good example where the national agencies and national research institutes, for example, governments needs to take leadership role, and they need to be on the driving seats. Also, providing technical assistance and capacity building is another area that international organization and development agency work. And this is by producing or providing training material, such as short courses, which it was Dr. Sodani mentioned, for healthcare professionals, and also for research, for the researchers, including developing courses for leadership programs. And this is another area that many of us have been working on. And most importantly, also, we have to ensure that we strengthen the capacity of the countries on priority settings, implementation research, and ensuring that they have enough capacity to have evidence-informed policies. And this is the key, not stopping at the research level, but taking it forward at the level of the decision-making. We in TDR have also been very much working directly with the implementers, social innovators, alongside researchers to help democratizing research and empowering people tackling their health issues on the ground. And along that, also ensuring, contributing to a new generation of public health leaders. The very last point that I want to mention is the role of international organization in enhancing networking and collaborations, which will help to bring together researchers, policymakers, implementers, and other stakeholders from different countries and regions to foster collaboration and knowledge sharing. This can facilitate the identification of common implementation challenges and the adaptation of successful strategies across contexts. And again, the key word here is context. Contexts are different, and that is exactly what Gary mentioned. It's not a challenge, but it's a reality that we need to work on. Thank you, Gary.
Great, thank you for those insights and important points. Let's hear from Piyush, from your experience in different socio-political settings. What are the challenges to sustainability, to scaling up of some of this, and build on some of the insights from other colleagues already to help us understand more?
Okay, so thank you so much, Yodi, for this question. As you know, during the last 1 hour, we are just discussing what implementation research is all about, how it is important for us, especially you know, the low and middle income countries in Southeast Asia, to find out the implementation challenges. If we, you know, the countries who are really striving to achieve sustainable development goals, they wanted to achieve universal health coverage. The key is to do implementation research. And one of the core component of implementation you know, research is to get the implementation outcome. And as Gary said, what are the, you know, challenges of scalability and sustainability? So sustainability is one of the core component of the implementation outcome and implementation research. And there are a lot of barriers, as you know, there are numerous barriers, there are numerous challenges when we talk about a diverse socio-political setting here. So there are multiple things. The first and foremost is the political instability and the changes. So we all have seen, you know, in Sri Lanka and Bangladesh, if there is a frequent shift in the government, the policy priority will change. And as a result of this, if there's a lack of political will, it can also hamper the long-term research project. And we also discussed how knowledge translation become really difficult here. So if we really wanted our project, our intervention, our, you know, programs, public health programs to be successful, to be effective, we really you know, need to work on our knowledge translation. The second thing that I would like to talk about here is you know, community mobilization. So in implementation research, stakeholders are the key to success. Lack of community ownership, if there is you know, lack of community ownership or inadequacy effort at any level, local level, because here in implementation research, we are trying to find out the implementation challenges at the local level and try to devise or develop the strategy that can help in, you know, mitigating those challenges. So the community mobilization is and engagement is important here. The third important thing here that actually hampers the sustainability of a program is lack of knowing the cultural and social norms. So, as mentioned by most of our esteemed speaker here, it is very important to understand the context if we really wanted to implement a program here. So our interventions, our programs may not be successful, may not be acceptable if they are not aligned with our cultural beliefs, the practices that are going on, and as well as the social structure. So if, and these act as a barrier, and if we really wanted to address, these things where if we do not, understand what are the cultural things happening here, we are not being able to adapt those changes in a program. And another thing is community involvement. So all these things affect our, the sustainability part. Then coming to the scalability. So scalability is also one of the important core element and implementation outcome for implementation research. So we have, resource constraint. We all know that, and Dr. Bonta Babu also mentioned that we have financial limitations. We have, the human resource constraint. So when we talk about scaling up of any intervention, it requires significant financial investment, especially for the human resource, for infrastructure, our operational cost. And if we have in Southeast Asia, we have different socio-political setting and competing priorities also, that makes it even more difficult to, scale it. Then human resource capacity. If our project demand, often more skilled individual, we need to provide them the certain skill. So if there is a shortage of these individuals, we won't be able to scale our program to that level. And as a result of this will complicate this the entire scalability thing. Now, fidelity. We also mentioned how important for us is to maintain the quality and fidelity of an intervention. So if we really wanted to ensure the scalability of the program, we need to ensure there should be a consistent quality of services. It should adhere to the original intervention model. We should check, is there any implementation challenges with respect to the fidelity? So if we really wanted to scale our program, we need to focus on the quality control mechanism, supervision, and we need to finalize our protocols separately. Now, when we talk about the scalability, we also need to think about adapting interventions to a new socio-cultural context. And as a result of this, very careful planning, executions, and all these things are required. So the first thing, we need to involve our stakeholders. Second thing, we need to build the capacity of the people. So if we do that, we can make it more scalable. Thank you so much.
Great. Thanks for that, Piyush. So just to circle back to all of this input and ask Dr. Gupta to kind of provide a couple of reflections. And then let's make sure we have at least 10 minutes to see if our audience has questions. Can you please? I'll give you the mic. Do it. Would you like to do it there? Okay, sure, do it there.
So, I'm back. And we have heard Dr. Menas, we have heard Dr. Babu, we have heard Piyusha, Dr. Sodani. And I was also saying in the beginning that implementation research is very contextual, very complex, and also in real settings. It's not lab. This is where you work. What you need. So the challenges shown as described by Dr. Babu, building partnership with the government. Researchers go with the data, and the healthcare providers or the managers at the district or state level say, no, our data says this, we don't agree with you. This is where the conflict starts. So, and then we are doing it in isolation. Researchers in their silos, they don't work with the communities. Important thing is to building partnership with the communities. So what I am trying to come to quickly, and I think we are left with not much of time, so in next 5 minutes, I'd like to share with you some mantras of leadership. What is leadership? Very difficult to define, but people have defined it. And this is a set of skills for nurturing change. Remember, nurturing change. Leadership is all about nurturing change. Now, how can you nurture change? What is that you need to require? I think your ability to think strategically, what we call as a strategic thinking. You have to address 5 questions. What we want to happen? That is first a strategic question. What we want to happen? Leaders always ask this question. What do we want to happen? We want to eliminate TV by 2030. Our Prime Minister says by 2025. One of our Prime Ministers said India will become an IT power, number 1 power in the country. And India became number 1 in information technology. Somebody dreamed of it. That's what leadership is. They give ideas, they see the future. So ability to think what you want to happen, what change you want, that's what is required. The other is, next strategic question is to where we are. So what is the current situation? So we want to bring down zero, or we want to eliminate TB, where we are in TB program. I was looking at the incidence rate of TB is around somewhere 400 per 100,000 population. No, not per 100,000, per 1 million population. That's what the incidence is. So, and what we want to achieve? We want to eliminate it. It's our dream. We want to eliminate what people, so we need to really see where we are and where we want to go. Now the next question, why is this gap? In my vision that we want to eliminate and we are not able to eliminate, why? Why this is not there? What are the problems or barriers or challenges? And then the next question, once you analyze that, is what we can do. What are the strategic interventions, using evidence-based interventions to take care of those problems. So this is called strategic thinking. A leadership skill is developing strategic thinking abilities or skills. That, if you go into the jargons, means this is ability to have a vision, ability to have a strategic thinking, ability, no intervention will succeed unless it is done in a scale. And a scale will happen only when you have partnerships with the government and with the community. So building partnership is so important. And I think we in public health and in the medical profession, we do not understand this, that partnerships are so critical. So building partnership is very, very important, and collaboration. A leader should have that. We need to build partnership at the government level, we need to build partnerships at the community level, and we need to build partnership with the health systems people with whom we are going to work to implement the programs. So that is very, very important. And of course, to achieve this, you require breakthrough in the attitude and in the mindsets of people who are working with you. One of the major human resource problems, people talk about shortage of the staff, people are not coming for job, the positions are vacant and all this and that. I don't see that as problem. What is the problem? This is lack of motivation, lack of drive. The attitude, the mindset is not there. What is the role of the leaders? Bring change in the mindsets of the people. Create a positive culture, positive mindset, positive thinking. Now, these might sound very hi-fi words, but if you want to bring change, you have to have them. You all have come over there, here in this summit. What are you doing here? You are doing networking. This is one of the skills you require, networking. One of the skills, some people are talking about collaboration, working together. That's what the leaders are required to do. Lastly, I would like to say, there are many things, not a classroom, so I don't like to speak much, but I would like to address one question what Dr. Babu raised. There is a lack of leadership at the top level to translate evidence-based interventions into healthcare delivery through the health systems. I think this is where the researchers need to work. We need to work on leadership development at the top level as well as the community level, so they come together and you are able to see the change which you envision. So leadership can be developed. Leaders are not born. Leadership skills can be developed. And we are doing it for last 25 years. Dr. Sodani is with me, and we have been doing it, and we see a change in the mindsets of the people. So it's doable thing. I'll stop here. Thank you very much. So I leave 6 minutes.
Okay, great.
Gary,
All right. So next 6 minutes, we have 2 questions we've selected. One is to Piyush and one is Dr. Sodani. Dr. Majumdar, how can digital health initiatives be leveraged to bridge the urban-rural health gap? And wait, for PR Sodani, what funding models have proven successful in, half of you are doctors, I can tell, in supporting implementation strategies in low resource settings? Then there is a package of questions. There's no way we're going through this. However, my suggestion is that if you've written a question, come find your question, take that question and go to the person that you're asking that question during the coffee break. How's that? Okay, 2 minutes, and 1 minute of goodbye from me.
Okay, Gary, can I just read the question once again?
How to leverage digital technologies for IR or for disparities, urban-rural divide.
Okay, so as implementation research is complex, so the same, this question is also extremely complex. The thing is, you are asking 3 different questions in one question. So the first thing which I understood by your question is how digital health interventions can be leveraged, right? And by dividing rural, urban. So we all know that there is a huge urban-rural digital divide that we are having in our country, and especially in the low and middle income countries. So the only thing that we can do is, forget about the digital intervention. Even if the intervention is a simpler one, implementing it in a country like India and other, it poses many implementation challenges, right? So in order to bridge those challenges, it is very important to build the capacity in the, in the major area of implementation research. Then only we will be able to find out what is our challenges. If there is any digital intervention, so we should be, trying to find out why people are not adapting to it, why they are not adopting the technology. Digital rural, urban divide is there. But there are certain other factors also. So we should focus on these factors and then come up with suitable strategy to address it.
Thank you so much.
Okay. And 1.5 minutes here. We already read the question.
Okay. So,
Funding models.
what funding models have proven successful in supporting implementation strategies? The answer is very simple. You take a course at IHMR.
Okay. So the secret is he stole that answer from me. But I think it just says that some of these questions are very difficult to answer in such a short time.
But just I would like to say that it's not a very, there is no any fixed model. It
Right.
depends on context to context,
Okay.
organizations to organizations. So it depends on many factors that how to get the funding. Thank you so much.
Great. So, yeah, half minute. Take your microphone is there. Go ahead.
Let him complete here.
Now, ICMR, Indian Council of Medical Research, is very keen to fund implementation research projects in the country. But they are not very academic. They should focus on specific national programs or state level problems. Okay, we are very happy to fund. We have different kinds of schemes. You can go to ICMR website and we can see. In fact, we are eagerly waiting for implementation research projects. Okay, we are prioritizing that one.
Okay, your half-a minute question.
That I told already.
The story of our lives.
Anyway, Varsha, let me answer your question. These days, I live with army personnel in army cantonment. And every 2 years, or even less than, it's a routine that they are transferred. The commanding officers are transferred. The heads of the units are transferred. It's a huge, huge establishment. What is there? The officer comes, new officer comes. He has the SOPs with him. He doesn't have to, what's going on, follow the SOPs. Systems are like that. So building systems based on standard operating procedures and clear-cut rules and regulations, this will transcend to the next level. Otherwise, there is no way other way to really carry forward what my predecessor did.
Okay. Oh. Okay, so this is very interesting.
Yeah.
Real life, clearly, but we're out of time. I'm going to ask you to give a round of applause to everyone that was here and encourage you to come back, get your questions, and corner everyone here and ask those questions directly, and don't let them go before you get an answer. Thank you very much.
Thank you, Gary. Thank you. Cheers.
Bye-bye.
I'm just going to take all these things.
Fast, quick, quick, quick. Thank you.
Daman.
क्या बात है तुम्हारा प्रेम बता ठीक है
Hello. 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 Hello.
सर ते मागे नंबर लिहिला आहे सर व्हॉट्सॲपवर हो नक्कीच सर प्रत्यक्ष आता सध्या नागपूरला सर भंडारामध्ये जांभळी नावाचं बाबा मग तिथून ते प्राचार्य होते सर इंजिनिअरिंग कॉलेजचे
Good afternoon. How are you? All good? Yeah, good to have everybody. Good to have everybody here. Thanks for having me. My name is Arjan, I'm the deputy representative in UNICEF. Very privileged to be here. Some of the panel members I know from before, some of them new, and we just had a brief chat. This is going to be an amazing session, so looking forward to it. First of all, welcome, also on behalf of the organizers, the host supporters. Panel discussion hosted by Sushena Foundation and Rishi University, supported by Divi's Foundation for Gifted Children and UNICEF. Again, welcome on behalf of all of us. Inclusive early childhood development is not a luxury, it is a right. And indeed, it's also a smart investment for today and for tomorrow. And I think that's very much the theme that we're going to explore today. So again, inclusive early childhood development is not a luxury. It is a right, an obligation, and indeed, it's a smart investment for tomorrow. We see that children with disabilities can face stigma along with negative attitudes and beliefs that place them at increased risk of violence, neglect, abuse, exploitation. Indeed, these children are among the most vulnerable, and often they are the most vulnerable of the vulnerable. It's not about a lack of policies, guidelines, even global commitments like the Convention of the Right of the Child, that clearly states that every child, not some children, but every child has got a right to survival, development, protection, participation. The Convention on the Rights of Persons with Disabilities, which is for all persons with disabilities, that includes children. It calls upon us to promote, to protect, and to ensure full and equal enjoyment of all human rights for all persons with disabilities. You see, these global agreements, it's all about non-discrimination. And being India, I think we're all proud that India has ratified all these global commitments and has got done a lot more national policies, guidelines, commitments as well. But also more indirect commitments, commitments like the Convention on Climate Change. Because climate change impacts all, including children. And especially, again, the most vulnerable children. It affects access to education, it affects access to health, especially among the most vulnerable children. So today's panel has got a very wide variety of experiences, areas where they work, policymakers, pediatric leaders, donor foundations, grassroots implementers, people with first-hand experiences of what it means. And together we will explore today what it truly means to build a system where no child is invisible, no family is unsupported, and no potential is wasted. Because indeed, inclusive early childhood development, it is not a luxury, it is a right, it's an obligation, and it's a smart investment for tomorrow. It's not about me, it's about the panel, but also it's about the co-chairs that we have today. Let's start with Sri Suresh Prabhu, a distinguished Indian politician and policy strategist. He has held multiple union cabinet positions, including Minister of Railways, Commerce and Industry, Civil Aviation, Environment and Forest, and Chemicals and Fertilizers. And currently he is the founding chancellor of Rishi University and a visiting professor at the London School of Economics. So I know that you cannot stay the whole day with us, the whole session, but really looking forward to hear your introductory remarks. Thank you very much, sir.
Good afternoon, friends. I am really, truly overwhelmed by the fact that such a distinguished experts with so much of field experience, so much of knowledge, so much of competence are there on this panel. So I decided that I am going to leave this panel discussion subsequently in the good hands of a very competent officer who is currently the Chief Secretary of Government of Maharashtra. And I'm a beneficiary of that because I'm a citizen of, I'm the resident of state of Maharashtra. If she had chosen to be in some other state, I would have lost an opportunity to benefit from her expertise and her knowledge. So I'm very fortunate that she's there. So I will leave it to her to take the session forward. But let me congratulate the organizer for focusing a session, especially on a topic like this. And I must congratulate my colleagues in Rishud University for really taking this idea forward. We normally are worried about global problems. So who creates the problems? We feel the problem just happen like that? The problems are created by some human being somewhere. You'll always find a fingerprint of a human being on all problems of the world, including climate change. So climate change is a problem which is human-induced, greenhouse gas emission. So human beings create problem, but where was the human being first? What happened when he was growing up? When he was born, was he born with this problem? This happened subsequently. But just imagine, if you had laid a good foundation for the human being's growth, whether it's emotional development, spiritual development, physical development, and if it had happened in a right manner, there's a good chance that a grown-up human being will not really be prone to making so much of mistakes of creating so much of global problem. For himself, I understand. But for the rest of the world also is a challenge. And therefore, how do you address this is a very important issue. And nature has already, there was no reason why the nature thought that from conception to delivery, the child has to remain in a mother's womb for so long. Because that's the time the nature wants the child to be ready to face the real world and get all kinds of nutrition, all kinds of support, all kinds of inputs that are necessary when it actually steps into the real world. And that's why that particular period of conception is the most important period when the woman is going through a pregnancy period. And that's why that's a period when we must focus a lot in terms of development. When a child gets born, the millions and billions, I was just talking to the experts, they told me there are few billion neurons which needs to be connected. Because what is the point? I have so much of things and I have got all different things, but they don't fall into place and the jigsaw puzzle doesn't really work. So to make that happen, how that process will happen? I was talking to my friend in UNICEF, my colleagues in the Rishud University, and they said that's a period when this synchronization, the working together of neurons happen. Just imagine, we have a fantastic orchestra. Everybody is a fantastic playing violin, somebody can play different instruments, but it doesn't work because there is no maestro who actually can make it work. What is the use of all this? So just making these neurons work together towards a common purpose to realize the true potential of what the human body, the human mind, and that particular being who is now born as a child is capable of. And that period, which is the most crucial period, which is ignored, then of course the child suffers, but I was just saying earlier, not only child suffers, but the child grows up into a wrong human being, the world suffers. Sometimes we say, don't act childishly, as if childishly means foolishly. In fact, most of the time we can realize that child is acting in the right manner, we are not understanding what the child is trying to say. And that's the problem. Not understanding the child, his own behavior, his own action, is a failure on the part of the so-called grown-up adults. So mother, the father, the grandparents of the child and so many other relatives have a role to play in ensuring that they understand the child when he's growing up. And in the may nourish him, not just with physical comfort, and also that is very important. Like sometimes you say that even a dog, when you go and just tap him, just to try to take him, he also feels good. And even the person who's actually doing that also feels better. So trying to do all this together is an important function that is necessary for a growth of a child in a right manner. And today we are seeing, and as you correctly pointed out, my friend, that is an early investment that will reap good results. It's always the case. Even in startups, the first investor gets maximum return. And a so-called angel investor, they not necessarily come always as angels, but whatever it is, they reap the maximum benefits. And therefore, early investment in a child's growth is the best investment one could make in terms of societal development. And therefore, we must focus on this in an adequate manner. I was just thinking about that, and all of us are knowing, particularly those who have lived in India. In fact, my friend from UNICEF, I asked him which country you belong to. He said, I belong to India, but he's actually born in Ethiopia, so he's an Ethiopian. The first human being was an Ethiopian. Of course, when the first human being was born, Ethiopia was not born. That's a different thing. When the first human being was born, Africa was not born. That's a different matter. But still, the first human being, and therefore he has some good ability, that's what I try to understand. But just imagine that in today's world, if we invest in a right way, we would reap the maximum benefit for the whole of society. The child will realize his true potential, and every child has infinite capabilities. Many of them never get realized, even probably not even a fraction of percentage, like a supercomputer. Bulk of it we never use. In sometimes we buy now another Apple 17, Apple 18 or Apple 100. So many things come and we don't even know what functions are there in these Apple. And therefore, we really must focus on that huge capability, development, potential of the child to be developed. And for that, early years are very important. Focusing on all that process. So I was saying, those who are born in India, I was talking about Abhimanyu. In fact, those who are born in India, they know this story very well. That is so-called warfare and the statecraft Abhimanyu learned when he was yet to be born. But of course, he only learned half of it, therefore he could never come out of it. He got trapped into the very war machine of the opponents. But just that again proves the fact that you must know everything. And knowing everything means you must allow you to blossom. The flower has to blossom to its full bloom, and that's what is the child development is all about. I am very happy that such very good experts, someone who is like Dr. Thakkar, we should be proud of the fact that he now is the head of the global pediatricians of the world. Just imagine an Indian, and that too coming from where he actually lives in Kutch. Many people in India would ask me, where is Kutch? Many people ask me, I know, where is Kutch? But he's born there. But I don't know why you did that. Why you could accomplish that. You must thank your parents for that. His childhood and the investment that went into that by his parents, by his grandparents and by everybody is the reason why he could really top the world. So just imagine, there are many Thakkars who are waiting to realize their true potential. And that is not happening only because we are not investing enough attention, giving proper nutrition, paying proper possibility to develop the child. And that's why I think this is the right panel. As I talked to you about the Chief Secretary of Government of Maharashtra, she has handled many important portfolios, and now she's doing that. So we really look forward, and I request her to take the discussion forward, but not just discussion. I hope it culminates into a concrete action leading to every child getting right attention. My wife, who is a journalist, she was with Times of India, she was with Z News Group, and many things. So she had done a story some years ago about child warriors. Children are forced to fight wars. Just imagine, at a time when they are supposed to play some game of their choice, whether cricket or football or whatever, they are now asked to take gun in the hand and start killing people whom they don't even know. So just imagine, this is a child abuse of a different kind. And therefore there is a child who could have become somebody, is now dying early death only because he's become a warrior. So we all become warriors for the children, rather than children became warriors themselves. And therefore, if we can do that, we would achieve a great lot for the betterment of the society. And that investment that you talked about, the returns will be manifold, not even imaginable. And it will not happen like Wall Street, it goes down sometimes and few times goes up. This will be a real wall that will not hit or head against, but it is the wall that will really take us forward on the right street towards a better future. Thank you very much.
Thank you so much, sir. I really appreciate it. Wow, that's an energizer. That's a wake-up call. Thank you so much, sir. Thank you. Let's give a hand again. Okay. Okay. Yeah, please go ahead to thank her. Sir, before you go, it is a little recognition and thank you. Thank you so much. Thanks so much, sir. Thank you, Ma. Thank you so much, everyone. And Ma, you have almost already been introduced. I still add a little bit, if you allow me. Mrs. Sujata Saunik is a 1987 batch IES officer, and I understand the first woman chief secretary of the government of Maharashtra. Over 3 decades of public policy and governance experience in public health, healthcare, finance, education, disaster management, and peacekeeping in the district, state, and federal levels, and international organizations, including the United Nations. She's also an Takemi Fellow from Harvard University School of Public Health. With her background, she really brings this convergent, multi-perspective around many different issues. Ma, may I ask you to give some introductory remarks? Please give her a hand. Thank you, Ma.
Be careful.
I'll be careful.
I think it's this.
It's that one. No. From now on, I'll know.
We can't have injuries in a session dedicated to health, right? So, wow, that was quite an opening made by ex-minister Suresh Prabhuji, and Aryan, a good friend and partner. Over 2 decades of my work has been with UNICEF. Distinguished panelists, all my colleagues, some of you I know I've worked with, and some who are probably here for the first time, and partners in inclusive development. First of all, I want to compliment you because you are those who really are genuinely interested in this topic. That's why you're here. So welcome to all of you. I'm privileged to share this platform with our chair who just left and made me the chair, so happy to do that. And I'm also very privileged to be in the company of this esteemed panel with Mr. Aryan, the Chief of Nutrition at UNICEF, as the moderator. The early years, from birth to 6 years, are a defining period for cognitive, emotional, and physical growth, as we all know. Some of it starts, in fact, most of it starts in the womb. Yet, millions of children across the world continue to fall behind due to undetected developmental delays. The Lancet estimates that over 200 million children globally fail to reach their developmental potential, impacting not only their future, but also the well-being of the entire society. The cost of meeting those delays and treating them later on are huge. So for any country that aspires to be an economic superpower, investing early on in sorting out these developmental delays is actually imperative. It's not just a matter of choice. The Nurturing Care Framework, which was co-developed by WHO and UNICEF and the World Bank, underscores 5 essential pillars: good health, adequate nutrition, responsive caregiving, early learning, and safety as part of this matrix and framework. Inclusive early childhood development is the cornerstone of this framework, a powerful lever for equity and long-term resilience. In Maharashtra, the state I come from, the commitment is evident through our implementation of the Rashtriya Bal Swasthya Karyakram, the RBSK, under which over 1.66 crore children have been screened, and children identified with health or developmental anomalies have been referred to district early intervention centers, the DEICs, which are now functional in all 36 districts of the state. These centers, run by multidisciplinary teams, address a wide spectrum of child development needs. I don't know why we have such complicated names for schemes and centers, but that's how it is. At the front line of this effort are our ASHA workers. Through home visits under newborn and young children care program, they often serve as the first point of contact for families. Their local presence and trust with communication and through communication with communities make them the backbone of our early detection system. We also have a biannual system of visits to schools to screen all the children who are going to school, and there also the mobile units, whatever abnormalities they notice, they refer those children for treatment to the referral hospitals. Therefore, the effort must be kept sustained by a strong supervisory ecosystem, block facilitators, medical officers, the RBSK teams, the mobile medical units who ensure effective referrals, follow-ups, and family support. It is their coordination really that transforms the early detection into timely interventions. Support from civil society organizations, some of you may be here today, have been equally crucial. Their work in community outreach, therapy, caregiving education, and inclusive education serves as a force multiplier, especially in the underserved areas. We are further strengthened by an ecosystem which integrates special newborn care units with DEICs, that is the district early intervention centers, and formalizing partnerships with private pediatric super specialists, ensuring commitment of care regardless of geography and socioeconomic status. One particular disease which caught my attention early on in the state was the level and spread of epilepsy, which often goes unnoticed, unreported, and untreated, unfortunately. And it's really important that we destigmatize some of these issues and allow for the family to receive care. Through data collection on impact, we are trying to find out more and more evidence, and our own experience has been that underscoring the compelling economics of early intervention, as I mentioned earlier, every rupee invested yields manifold returns in health savings, educational outcomes, and economic productivity. I would also like to pause here and say that having 100% coverage of vaccination is equally important for children to achieve their full potential and not come back in their later years for treatment of various diseases. That is an outcome of missing a dose. Inclusive ECD is not just a charitable act, it is a strategic, imperative policy intervention, and it builds resilient communities, inclusive economies, and also a very just society. As we begin this important discussion today, I look forward to the insights from all the distinguished panelists. Let us recommit to a shared vision where every child is nurtured and every society is strengthened. Thank you so much, and I'll stop here for now.
Thank you. And I'm not going to stand up anymore. I think let's sit down and take it from the panel. Okay. This one works. Thank you so much, Ma. Also emphasizing inclusive early childhood development is not a luxury. It's a right, an obligation, and indeed a smart investment for tomorrow. And that brings us to the panel. We've got some amazing panel members. Let me introduce them first. First, we have got Dr. Cobragada, a distinguished senior IES officer of the 1993 Kerala Cadre. He's presently the additional Chief Secretary of the Department of Health and Family Welfare, Ayush and Culture Affairs of the Government of Kerala. Please welcome. Then we have Sri Govindarayan. He serves as the Commissioner for Persons with Disabilities under the Ministry of Social Justice and Empowerment of the Government of India. His work focuses on promoting accessibility, equal opportunities and social justice for individuals with disabilities across the country. Again, welcome, sir. Then we have Dr. Murki, a highly respected neonatologist with over 30 years of experience in pediatric and neonatal care. As president of the Sushena Health Foundation, he is dedicated to advancing child health and development initiatives. Thank you very much, sir. And then as last, but again not least, Dr. Thacker. He's a distinguished pediatrician and global health leader, currently serving as president of the International Pediatric Association. He has served on the CAVI board, the PMNCH board, and he was listed as topmost influencer of polio eradication in the world in 2017 by the United Nations. Wow, thank you, sir, for joining us. So let's explore the theme a little bit further. And we are going to have, if time allows us, we're going to have 2 rounds of some questions, and then Ma will summarize and bring it all together. The first question, that's to you, sir, my apologies, Govindrayan. As someone who has navigated life with blindness since birth, could you share how early support systems shaped your development and access to opportunities? What were some of the key enablers or barriers you faced during early childhood? And yeah, what advice do you get from, would you give from that experience, sir?
Yeah, very pleasant evening, one and all. The valuable question posed towards me. Marking that being an experiential person as a visually challenged. And I could tell my personal experience that when I was become visually challenged or blind, I was not aware as that I am blind or others are sighted. Right? The basic understanding was not, because it happened in the childhood. You know? So there was, since my blindness or in the childhood when it occurred, I didn't have any difference in my understanding or in the way of life. Though it sounds positive, but practically several difficulties had been experienced due to lack of some facilities or some accessibility issues. But those were not that much found very hard at that time because we didn't have any expectation at that period. But analyzing the past and comparing with the present, really the current arena is much, much better with the technological advancements and scientific developments, which we were lacking at that time. And the difference we could see much better. And even our juniors or the current students are enjoying better facilities than what we had. So every generation, I believe, would get better prospects, as before the previous generation would have been suffered without even the exposure what we had. So difficulties gets reduced generation after generation, and as the technology or the understanding of the general public and the attention of the social and political understandings gets developed and is attended properly towards its progress and prosperity. This could be my first explanation. Thank you.
Thank you much, sir. And I really appreciate the positive forward looking, that generation after generation we improve. That is very positive. Dr. Kobragada, Kerala has often been seen as a front runner on ECD, and including ECD for children with disabilities and developmental delays. Can you share some experiences, best practices that you have taken that you think that also other states and other countries can learn from?
Some of my colleagues are in the hall. They and my team back home, in fact, what we do, the work in this one particular sector and in this, I will try to answer in two parts. First part will be some of the examples, what we are doing, what programs we have, rolled out in the state. And second part, what are our, strengths based on which, we have done a good tapping those core competencies and going forward. So when we talk about child health, in fact, first thing comes to our mind is infant mortality rate. And we are all already known of the fact that the Kerala is having the lowest infant mortality rate in the country. What was happening 1 decade back is we were having a double-digit mortality rate. We analyzed the data and we identified that the majority kids or the babies were dying because of the congenital heart disease. In spite of all our effort, in fact, it was happening year on year. So after this analysis, we have done a very well thought out program of Ridhyam program, which is giving a treatment to the congenital heart disease babies, even if they are, very 2 days old or 3 days old. So we have identified which baby is requiring a surgical treatment, and all this treatment is provided free of cost by empaneling the hospitals which are in place. So since 2017, what we have done, after that 8,118 surgeries have already been done, and we are following all these children. So this is the way this program is going forward. So our IMR has come down in a single digit. Now, of course, the challenges are different now, because when you reach to the 6 and 5, then you are having another very difficult challenge, that is a rare disease and all, but I will talk about it subsequently. Second example is, what we are talking about related to child development. So newborn screening program, what Madam also spoke about, for detection of disabilities and development delays. So we are having a very good structured Shalabam program. So right at the birth and within next 3 days, we do the visible birth defects detection, functional defects, metabolic disorder, and a newborn neurodevelopmental at risk. All those things are done, and based on the diagnostic, what all management pathways on which we should put that baby, those things are done. So if I have to give a data related to that, in 2024, we have done more than 86,000 screening, and out of that we could identify 5,649 were having visual birth defect, positive cases. And all those respective cases, then we have taken it on a treatment track and management track. For an example, we were having a cleft lip and palate, it's 57 cases, clubfoot 76, then CHD 427. Why I'm saying this data is, unless and until we drill down and identify what actually is happening to the baby, and at the earliest, we will not be, doing justice, and at the same time, the intervention becomes very, very difficult, and perhaps because of this, defects, they may not also become fully productive individual as we go forward. Third intervention, what we have done, UNICEF is our partner. They are, we are already established a center of excellence in Child Development Center in Trivandrum. And there we work on the fetal medicine. We work on early simulation, habilitation and development assessment. And based on this development assessment, we do the intervention. Another example, which if I have to put it, it is related to clubfoot. Kerala government has declared there should not be any child with the clubfoot. We are having excellent partnership with Cure India, and we go ahead with the Ponseti technique, and without any surgical intervention, we are going ahead in this. So these are some of the examples. Now, how Kerala could do this, there are few points which come to my mind. One, we are following this SDG metric very, very, meticulously, and we don't try to invent any other metric, but we work on this and look at where we stand, and then we break that into the district and the sub-district level. So we go up to the panchayat level. So that is one. Second, Kerala is having a very multi-pronged approach, like social determinant of health. Not only health department, but all our line department, in fact, they work, and that integration happens at the panchayat level. So therefore, Kerala has generated a huge social capital in terms of literacy, in terms of then women empowerment, their involvement into all the activities, and this is really helping us. Third important thing is we are having a grassroots level governance structure in the form of Panchayati Raj system, which is really one of the strongest in the country, and perhaps if we compare any other geographies, because they annually get almost 25% of the plan grant, and then they decide what are the problems in their particular panchayat and they do the intervention. So whenever you want to roll out such a massive program related to child health, unless and until we reach to the community and their community-led structures, it is not going to give us any kind of a result. So we find whatever the multiplier result what we get is because of this grassroots level structure, and then we have built a partnership platform. Now IIP, sir is of a global head, in fact, but in Kerala, we are having a Kerala chapter IIP partnership. So every once in 3 months we meet and we discuss why our kids are dying, what actually is the cause of the death, and in what way we can bring in the intervention so that this can be safeguarded. And then we roll out what is to be done in the next quarters. So this is something fantastic. And the last point is, in Kerala Health, everything we do is based on the evidence. Whatever is evidence, and we are having a concurrent analysis and a feedback loop. Based on that, we tweak our programs and the schemes, and we go ahead. So I will stop here. Thanks a lot.
Thank you. Thank you so much. And really emphasizing that early detection, early management is critical, and that you need systems, you need partnerships, you need the frontline workers, and that all needs to be connected to have that continuum of identification all the way up to management and support. So thank you so much, sir. Dr. Murki, as a neonatologist, and through your work with Sushena Foundation, you've witnessed firsthand how nutrition and care can shape developmental outcomes. Could you share a bit of your experiences that have deepened your commitments around early childhood development, especially for the most vulnerable newborns?
Thank you. So I think I'm one of the person wearing double hats here. I'm a neonatologist, a pediatrician, and also the president of Sushena Health Foundation, which is an NGO organization. So when I think of from a perspective of a neonatologist, I think when we talk about newborn or the fetus, we're talking about the structure of the brain, how it develops. There are two important things for the brain to develop. One is the nutrition, and the second is the health. That means we should be free of diseases and deficiencies. The second important thing is once the structure is developed, to get it to the right function, we need right stimulus. So the second aspect is stimulation. So what happens over time in the first 1,000 days, we work a lot of government organizations, all of us, our primary aim has been to develop the structure. But now time has come to develop the stimulation aspect also. So in this, we already work on some of the nutrition aspects, which already we know that there are a lot of programs in the country where nutrition is promoted. But our aim is to provide the correct nutrition for the infants. So we work on providing ensuring that every newborn, every infant gets only mother's milk or exclusive breastfeeding. Exclusive breastfeeding for the 6 months is the best nutrition for any child and is the best nutrient for the brain of any child. It is not just the protein, calorie, it is more than that. There are more than protein, calorie. There are new molecules which are identified will help us to help the baby to prevent from diseases and deficiencies. The other thing is the bonding. The baby develops a bonding with the mothers, and we have been talking about the stimulus. The baby's best stimulus comes from the mother and the family. And if breastfeeding can be promoted for 6 months, not only nutrition, health, but stimulus also comes the best way in that manner. So that is why Sushena Health Foundation is working a lot on developing comprehensive lactation management centers, which work to develop the milk banks, but that is one of the offshoots. But our main area is on promoting breastfeeding, ensuring that lactation problems are being addressed, and at the same time, ensuring that every baby who is at the risk of, maximum risk of having childhood developmental problems is the baby coming from NICUs and SNCUs. 20% of babies who are coming from SNCUs are likely to have developmental challenges and disabilities. And that is where we feel that getting mother's own milk or donor human milk will help us in preventing those disabilities in the most vulnerable population, that is the babies coming out from the SNCUs and NICUs. And in this area, we already realize that RBSK, district early intervention programs are already there, but we work closely to ensure that every baby coming from SNCUs and NICUs are screened for hearing, vision, and also for the brain. And these three things we want to prevent ROP, which is the most common preventable blindness in this country now. And then we want to avoid hearing deficits. We know Kerala model where they worked on, Goa model where they worked on ensuring that every child gets a OAE screening. And these at-risk babies, we need to want to get them BERA or brainstem evoked response audiometry for the at-risk newborns. Thyroid screening is very, very important because it's doable. These three combinations, hearing, vision, and thyroid, should become part and parcel of every screening in this country. Not talking about the metabolic disorders, but we are at the right platform for these three screenings at least. And the other two screenings, which Kerala government has already said, congenital heart disease screening, which is the pulsar screening, which doesn't require any investment. It is just that every baby, before they're discharged from the hospitals, they get a small pulsar screening. And based on the oxygen levels, you can say that this baby doesn't have a heart disease. The last component of the screening is developmental dysplasia of hip, which sir has suggested of clubfoot, but this is something which may not be present immediately after birth. It can start in the first few months after birth, and that screening needs to be done by all the pediatricians, all the neonatologists in the first 6 months. Sushena Health Foundation is working in state of Maharashtra, where we are trying to develop the ROP implementation program, hearing screening program, so that every baby gets these 5 screenings, which are doable, which can come as a compact package. The other important thing is we believe that, as Suresh Prabhuji told, that it is the fetus which needs to get the right stimulus. And there, in at least in Hyderabad, we have tied up with Ramakrishna Mutt, where our aim is that mother gets the right physical, mental, as well as spiritual development in utero. So the baby mother needs to get mental health, physical health, and spiritual health. And towards that, we are working on, we developed a program where we can ensure that the baby gets the correct type of growth, health, as well as stimulation. And we are also working with National Neonatology Forum on developing a habituation program, which is exactly similar to stimulation in utero, growth and nutrition immediately after birth, and taking care of the at-risk newborns which are coming out from SNCUs and also from the NICUs. So thank you. I think we are a small startup. We have been there for last 8 years, but our goal is to ensure that we prevent all these childhood disabilities. Thank you, sir.
Thank you so much. And I wouldn't call this small. I mean, thank you so much for the amazing work that your foundation is doing. And also for emphasizing the importance of breastfeeding. It's about not only nourishing the growth, it's brain development. It's literally the IQ and making the connections in the brain. It's nourishing the future of a child. So thank you very much for emphasizing that as well. Dr. Thacker, as a president of the International Pediatric Association, can you share some of your reflection around early childhood development and where you think that programs and also systems need to be strengthened based on your experiences?
Thank you so much. Thanks for the invitation. This is my 3rd panel since morning, and morning I was lost. First I picked up the wrong notes, and thankfully, and in 2nd panel I reached to the wrong room. So. Yes, and this is the right place and right people, and I'm so honored to be honored with everyone. So my position as I said, first Indian to be International Pediatric Association president. We have one umbrella organization of all pediatric societies in the world. we from 175 countries. And that gives me a chance to visit different countries, meet health authorities, health ministers, pediatric societies. So some of the example which I picked up and where we can do even, India doing excellent job, but how we can do better. So first is from the Chile, from the Latin America, Chile, CRES Contigo, they call it the program, national initiative that integrates early child development into health, social protection and education system. And what is unique is that beside development, screening and parental support are part of child's routine health visits. So this is something good, that you also have part of the routine health visits, which may not be we here we are doing in, but it's still not across the India, and parenting support. As Suresh Prabhuji said, that it is parenting support which is very important for the early child development. And they are not only identified, but they are given support from very beginning. They don't have to, it's a part of the system. Second is Rwanda. We have our IPA Congress. It was last year in Gandhinagar, next week in Mexico, and after that in Rwanda, Kigali. So I had an opportunity to go there twice, meet with their very active young health minister, which first name starts with Sabine. So and we didn't recognize him. And so, then we had a very good meeting, and we learned. They have trained community health workers and educators to create inclusive early learning centers in rural areas. Rwanda is a small country, but cleanest country in the Africa, or even they claim world, and very, very, very friendly and very good health indices. So children with disabilities are included in mainstream pre-primary classroom. See, I remember we used to do that you need a special education. So the training modules for caregivers and teacher include not only their, how to teach, but sensitivity to various disabilities, including neurodevelopment conditions like autism. Despite being a low-income country, Rwanda has made ECD as a national priority. And that's what we, in some of other panel, we talked about the political advocacy, political, leadership. Finland is a different word, but they have transdisciplinary teams and everyone work together. In Vietnam, UNICEF has supported rollout of development milestone tracking tools with maternal and child health services. So there are many countries, even in India. Indian Academy of Pediatrics, with support of UNICEF, has rolled out a program. They have done 200 workshops across the country. First, you have to teach the pediatrician, and then they can teach others. First, you have to recognize. First, it should be on your antenna that you can recognize, and then we can definitely do even more in neonatal screening. Last year I spoke on there during the World Health Assembly, and we have very good example from Indonesia, where the health minister is still a banker, and he did a very small investment, and he presented in World Health Assembly. Universal neonatal screening, everything. Cost is a major barrier, but once India touches everything, the prices go down. The best market shaping, I served on Gavi board, is done by India. India decide to roll out any vaccine today. We seen with hepatitis B, we seen every other. So I know these systems are very costly, but India can do it, and we should make it universal newborn screening for everything. And if Indonesia can do it, why not we? We can do it, and that's a very, very interesting, and he's a good friend of our former health minister and maybe new health minister, the health minister of Indonesia. In spite of the change in the regime, they retained him as a health minister, and he's a banker. He is not a doctor or public health person. So we have many things, Poshan Abhiyan, RBSK, NEP. We have very good system. I know in Kutch, if you have anybody, they will take it through RVSK. But before that, we have to invest in where do you recognize. You have to invest in parents more and more. I was in Moscow exactly 1 month back, and there they were presenting all these things. You would give early stimulation. If mother touches the baby in NICU and someone nurse touches, how much is the difference? I said this we are doing for long, our system. And second thing I want to say, when we talk about development, particularly autism and these things, developed countries and developing countries are totally different. Our system, mostly because we have a lot of support in the family, joint family system, we are still good. Children suffered during pandemic, very badly suffered, and many of them, they progressed to say developmental delays and autism spectrum say scale, but still our system is better, and we cannot learn from the Western world. And that we have said for even polio and everything, that you cannot apply everything in India. We have Indian Academy of Pediatrics is my mother organization, and we have through IPA have connected them from Kenya, from Uganda, Indian Academy, they are interacting. It's very important we have South to South collaboration, and that was very clear agenda during my tenure to say that we have priority for the South. You don't mind, you had your time. This is India's time, which will finish next month in next 10 days in Mexico. And there also in Mexico, we are keeping, Dr. Vivek is invited there. Hope he will be given permission to travel. So to showcase the same topic, every plenary has one speaker from India. Showcase the immunization, showcase the, say, ECD, showcase other thing, every panel which we have. So I really, I would say that India, which I was discussing with Suresh Prabhuji, that there is a vacuum at global level. And India has so much to share. I know just 2 weeks back, Royal College given me a fellowship, honorary fellowship. I was there, and they said, we have program in Rwanda, again on ECD. And once the US had withdrawn, China came in. India has capacity and leadership. Many states, Maharashtra, I know I worked with the, many years back with the Chief Secretary and for neonatal resuscitation program. So we should give this leadership to the world. And one of that item is ECD.
Yeah. Thank you so much.
Thank you.
Thank you so much. Amazing. Sir, you're definitely in the right room. Thank you for that. Thank you for sharing experience from across the world, but also emphasizing the South-South. Also emphasizing that it is not only the rich South that we can learn from. You gave some examples from Rwanda, some of the poorer countries, and that shows it's about commitment. It's not just about money, it's about commitment, it's about leadership, it's about the willingness to do. Also, I really like India standing up and saying it's time for India to share experiences, influence on what works, and sharing that to other countries in the world. So thank you so much for that one. That brings us to the second round. First, to Sri Govindarayan. Based on your, in the first round we did a bit of exploration, a bit of the experiences, some of the reflection on what is happening, where should it go to. Now a bit more on policy impact, what is needed, policy change, what is needed, program change, what is needed. Sir, based on your experience and the current landscape, what key policy actions or systemic changes are most needed to make ECD truly inclusive for children with disabilities?
Well questioned. I believe for a strong national promotion, as we believe in industrial development and lot many things, we advocate for public-private partnership, right? Likewise, same 3P system could be executed to prevent, for the prevention of disabilities. That is what we are discussing much over prenatal, perinatal, and postnatal care. So this observation, this awareness could drastically reduce or prevent the disability at large. And the policy towards the screening during these that two early stages should be legally and medically be viable to everyone. That means not only at the urban arena, it should be served in all rural places to control the population with a disability. Likewise, once the child or the growth during the pregnancy is identified, the right to decide by the mother should be provided legally, so that there could be a drastic reduction or proper treatment can be carried out with the consent of the mother. As we all rightly take forward, the 0 to 2 years, that is the first 1,000 days, are the essential and crucial period to decide the destiny of the child. So we cannot be the reason because of lacking the policies or the practices for the development or increase of in the disabilities. And moreover, we have to encourage and develop the concept for the healthy family system and psychological comforts towards all these practices, because we talk about so many medical practices for the disabilities, but we need to accept that we need a lot of education in the family practices and the psychological, the mental health to bring up the child, or to to make the world healthy. We need to make the mother and baby healthy at in the home level itself. With this, I conclude my.
Thank you so much. And thank you for emphasizing that children live in families, they live in communities. So what is really needed is to support the parents, the mother, the communities. I think also recognizing that it's not always about the lack of policies, it's about often the implementation and the reach of the programs and services to every individual, every child that needs it. Dr. Kobarakara, from your experience as and your work, you're very broad. Can you give a bit of from your experience looking at policy shift, but also multi-sectoral, multi-departmental kind of strategies that you think might be needed to bring the ECD response, inclusive ECD, to the next level?
If we take a look at all the policy documents, in fact, historically, everywhere we have given emphasis on convergence, so that always there is a multi-sectoral approach which is required. But this, it is very difficult to achieve that at the implementation level. So buck stops at how we are implementing. And even today, if we don't analyze that there are good policies in place and where we have mentioned that there has to be a convergence, but if we are not looking at, if it is not functioning, it is not happening, what are the reasons? Then again, I think we will repeat the same thing what was happening in the past. So our experience in the state with the multi-sector approach, etc., is relatively it is easy when you break it down and take it to the grassroots level. Nearer to the field, if you go, then that aggregation is happening, and it happens very nicely. So if we take a common, structures, what is required for ensuring this aggregation happens at the grassroots level in a country, there are 2-3 things which I will carry forward. What I briefly mentioned while responding to the first question is, one is engagement with the community is non-negotiable. It is not that, we have understood that this is a problem and therefore we are going there. On the contrary, if we tell them that, look, if we work together, it is your problem we all face, so therefore you come and be a part of this implementation. So community engagement has to be extremely strong. The moment we do it, and when community owns it up, then their political representative have to own it up, because the community is demanding that this is what we would like to do. So at a grassroots level structures, when we work it out, so if that community in that panchayat, when it happens, then that panchayat political executives, everybody comes and then they formulate the policies to take it forward. I'll give you a small example. When we would like to work on extreme poverty families identification and ensuring the livelihood support and plus other help to them if they don't have homes, they give them home, etc. on a priority basis, that there will not be any political executive who will be saying that, okay, let us not do it, let us defer it because there are other competing priorities. So this is the way it works out. So first and foremost is engagement with the community, and second, we should have this decentralized governance structure. Now I know that in Kerala they are very strong, in other parts of our state perhaps they are not that strong, but we need to think through then that what kind of a governance structure is required at the lowest level. We cannot just work from the state, or we cannot also work from the district. We will have to have what kind of a structures we can put in place so that at the panchayat level, at a village level, all this, this structure is in place, and we should have a processes to empower them. They may be from the community, they may be some social activists, they may be from civil society and all, but that structure should be empowered if you don't have a formal structure. In our country, in fact, Panchayati Raj system is there, but we have not done that empowerment enough in other parts of our country. So therefore I am saying that what should be the alternative in other states where at this point of time this structure is not there. And third and fourth are logically for any social development programs are constant, that is a capacity building, and which has to be a continuous, it cannot be one time. And second is, we are having now BCC, behavioral change communication strategies for each of the stakeholders so that we will continuously go on a path of progression. Now how it happens at the state level, I have given one example of extreme poverty families. In our state now, based on the indicator, that number was above 1 lakh. It got reduced to 72,000. Now it is 68,000. It is further coming down. We have identified another layer of severe malnourished children in the state. They are around 8,000. So that line list now we will work out with all the panchayats. And from this happens through local self-government, that what is, and WCD, Women and Child Development Department. And from Health Department, we usually are having a health assessment. We do the health checkup of total universe. But out of that, we will give priority to these extreme poverty families and also these 8,000 children. And based on that diagnosis, we will, link it them to all what is required and then follow them through. So what is our plan is next 1.5 years or 2 years, we don't want anybody in the panchayat this. Now how you encourage? You tell that panchayat that you start working on it, and start declaring that my panchayat is free of extreme poverty families and free of malnourished children. Now what happens, it creates the ripple effect, and then other panchayats also come through, and that becomes a movement at the grassroots level, at the political executive level, and that political advocacy, what sir was talking about, that becomes a reality. So I would like to see that there should be, we will still talk about convergence. Even today, when we will do policy formulation, we will do convergence. But for convergence, I feel we should also give some funding to the state level and also the district level small units. And then that unit will get linked to all the line departments related to that particular problem, be it a climate change or be it a child health related problem or be it, like nourishment or any other aspects or the mother health, etc. Then that will work out. So I feel, there we are having a gap because we do expect within the line department, they should start doing the conversions. And then each department is having their own competing priorities. And in that process, this convergence aspects be something they keep it on a back burner. But some of us who are conscious that we hammer it down and we try to get it done. So wherever there is a capital, social capital involvement, there it happens. But otherwise, if there is no program, this. We are having a successful stories in some of the programs where this convergence was made as a systemic effort by giving some funding, having some of the small units with the state and the sub-district. I think that can be thought through so that we will have an improvement, and as per our stated objective of the policy, it will get fructified, and what we are all discussing and planning, that will become a reality. Thank you.
Thank you, sir. What I really liked in your reflection, you're actually building on the previous speaker who really focused on the family and the community, and you brought it from there. Hey, how do we get that government system to support what needs to happen that side? Dr. Murki, given your perspectives on the intersection of clinical care and community health, what are some of the investments that you think are needed? What kind of recommendations do you see for ECD to make it more inclusive, in particular around the neonatal period, as priorities for India?
So I think we have done significant improvement in the implementation of SNCUs. So I think that is the area, because 20% of disabilities are going to be coming from SNCUs. This needs to be targeting this area, the babies coming from NICUs and SNCUs to be need to be screened for the developmental disabilities, and they start early identification and early treatment. So this is a huge area. I think that's one thing which I would like to go on with.
Thank you so much. And thank you, because I get signals from somebody in the audience about time. So I really appreciate your very focused answer in that sense as well. So maybe you got the same signal. Somebody there was signaling me. Sir, for you, from a global pediatric and public health standpoint, what do you see as the most urgent priorities for the government and international agencies to ensure inclusive ECD? It's not just ECD for all children, it's about inclusive ECD, so that indeed it becomes a cornerstone of child health strategies, not only in India, but worldwide.
Yes, so 4 priorities. Number 1, we must make developmental monitoring and early identification as core component of all child health platforms. I know in immunization we take weight, we take height, and we don't have the developmental assessment. So all child health programs, we can use WHO Care for Child Development Package or our own RBSK development checklist. But it should be for any reason child comes to you, it should be there. First, that was first. Second is, once you have identified, but you need capacity building among frontline workers and families. It's not that you diagnose and you refer. Many of the things they can do on their own, they can advise family, and they can do, how to do that. So that's a very, very important capacity building of ASA worker and families for this. Third is integrate ECD in national financing and policy priorities. As of now, it should not be longer to be, only in education or child protection, which is the case now. Ministries of Health or Education. It has to be integrated in all. This should be a topmost priority because this is the best investment possible. And fourth is, we must invest in data and accountability. Data is very important. Most countries track survival rates in schooling, but very few track how many children with developmental delays or disabilities are accessing early intervention or inclusive education. If we don't measure inclusion, we don't make it a priority. So these 4 are the priorities. Also, it should be included in Sustainable Development Goals progress indicators for shaping global norms. And as I said previously, we should start from India and we have a, we are leader and we can become leader. And if we are not sharing with the world, we are doing injustice.
Thank you so much. Ma, it's up to you to try to, not to summarize, but what are some of the key things that come out? What do you see as the way forward? And I've heard some things about community level, families, policies, programs. At the end, it's about every child. Over to you.
Thank you. Thank you. I think wonderful ideas have come forward. I mean, I can already see a pattern in what could possibly happen going forward. So each of the speakers brought their own unique experience to bear upon this subject. And their experiences are very individual, but then there are so many meeting points. So starting with what Mr. Govindrajan talked about, you know, the PPP, so prevent, and especially ensure that in prenatal, perinatal and postnatal, was that a fire alarm? I hope not. You know, he emphasized the need for having a legal and medically proven care program that can ensure that early childhood disease is detected and treated. You know, and he wants a guarantee on it, and I think that's a wonderful thought. And he also talked about how it should be linked with education and mental health program. He also hinted at how important it is for families and the first point of contact to be able to provide the support required to handle this. So, and his own experience has led him to believe that today there's so much of technological improvements that it should not be so difficult. You know, it's getting better over time. In addition, Dr. Rajan Khobragare not only showcased Kerala's way of handling ECD, but he emphasized how important it is to really take it to the next level, and how in Kerala they look at, you know, constant review, discussion at the Gram Panchayat level, and then feedback going back to improve the system. And I think he emphasized the point of having you know, the approach at the Gram Panchayat or at the community level. So while Mr. Govindrajan was talking more about ensuring that you know, it's legally and medically taken care of, Dr. Khobragare insisted that it should be something that a decentralized governance model that looks at community approach, especially at the Gram Panchayat level. Mr. Murki's you know, points were very, very valid, saying how all children in SNCUs and NICUs need to be taken care of and screened before discharge for any kind of ECD that could possibly you know, affect that child moving forward. And he mentioned the work he's doing as part of his lovely health foundation called Sushena. They're also working in Maharashtra, so that's a very, very encouraging. And I hope we can sign an MOU with you to you know, to develop a model for the state. And of course, Mr. Thakkar, he took us around the world, didn't he? I mean, he took us to Chile and then Rwanda and places you don't normally go to, Finland, Indonesia. But he came back to India in a very big way. And he said that, you know, why can't we create a model that can become the model for the whole of the global south? And I thought that was a wonderful thought that you presented. And, you know, he talked about how we should make it a core component for all child health programs. And I think now with the 16th Finance Commission coming up in a big way to seek inputs from states, I think this is something we could leverage. And maybe we could send them on a little world tour to go and understand how other countries are doing it. So that's a wonderful way of putting it. I think to summarize, it would be good if we as a group and you who are here today to participate in this session can come up with a kind of a paper which could be like an SOP that talks about why is it that we are not able to really institutionalize this at the local level, whether it is a ULB or an RLB, that's a rural local body or an urban local body, and why is it so difficult to really mainstream it and bring it as a program. And I think with the advent of AI and machine learning, We have so many of these tools today, ChatGPT being one of them, though I personally don't use it. But it could be easy to run all your programs through that and have a simple step-by-step kind of a guide which can be scaled up on national level. So I'll stop here. And over to you, Arya.
Hey, thank you so much. Wow, it's really about inclusive early childhood development. It's not a luxury. It's a right, it's an obligation, and indeed it's a smart investment for today, for tomorrow, and for the future. And I'm very happy that we're all in the right room. And actually that allows us, now could we have a bit of time? And thank you for everyone to look at the time. If there's anyone who wants to share, we might have one or two. I see 1, 2, 3. And there won't be time beyond that. So we go with 1, 2, 3. Please mark some comments or questions you might have. And I've got a microphone here. Okay, no.
The lady first.
Thank you for the wonderful panel. I'm Mahua. I'm a scientist at Indian Institute of Science, and I work at the newborn screening. And my question would be regarding the dried blood spot screening by Robert Guthrie, which started in 1960 and has been sort of used in universal screening in US, all the developed countries since long. And in India, Kerala uses it for quite some time now, and very small other projects around the country. I'm trying to understand why it has not been implemented yet, despite being in RBSK since 2015. So, if some thoughts on that, that would be really great.
And first take the questions, and then we're going to get to any responses. Let's first, I think there are 2 more questions here.
Hi, this is Santosh, and I'm from Sushena Health Foundation. And I have a quick comment, and not a question, and probably a question around probably someone, especially Rajan. Probably Mr. Rajan can take that. See, I mean, one of the important parts of your conversation and your comments were that how we can take this to community level and how community can actually own this up, and institutions like Panchayat actually can take this ECD. And you also spoke about very, very important thing, which was BCC, behavioral change communication. And I was just remembering that in our childhood days, whenever if a mother gets pregnant, and we used to have something called, in our Andhra and Telangana, we have a very big program where they are given bangles and everything, but most important, they're given fruits and absolutely what is necessary for the nutrition. And it's a happy environment that is created. And second thing, when the child has to go for, complementary feeding, we have called Annaprashan, exactly at 6th month. And Annaprashan was exactly at the time the complementary feeding had to start, and everyone knew this. It was no-brainer, and it was there in the community. Similarly, if a child flips, in Andhra and Telangana, we had to do something called Bobbattu or Obbattu. And if the child crawls, we have Burilu, another kind of sweet. And everyone knows these milestones. The milestones are documented in every mother, every community, every village. So, and this was there as an institutional memory for thousands of years. How can we take this sort of ECD program into the community, some of it which is already existing and some of it which needs to be given in the colloquial language, probably with cultural understanding and cultural moorings, and how this BCC, ECD, and our institutional frameworks, especially in the community, can be married together. Thank you so much.
Thank you so much for this wonderful panel discussion, and it's really heartwarming to see all the initiatives. My name is Anil Joshi. I'm an IT professional, a parent of a 31-year-old beautiful woman with Down syndrome, and exhaustively volunteer with the National Network of the Parents of Persons with Intellectual and Developmental Disabilities. My really heartfelt thanks for all the beautiful endeavors the panel has shared with us. Just one finding about the congenital birth defects being screened. I mean, I somehow didn't get to hear that, if that could be considered. For example, Down syndrome is easily detectable even by observation and to be confirmed by karyotyping. Now, the families which can't afford, possibly the governmental system could support that, and the families who can afford can support it to themselves. Most of them result into different kind of intellectual and developmental disabilities, possibly, yet there are beautiful possibilities of how the support systems can help these individuals attain their fullest potential, and we have more than 1,000 cases across India, because we work across India with the parents and families in mentoring. My request and suggestion for all of us to consider in different states, because Kerala has presented a wonderful model, if we can have a first information kit along with the diagnosis, because more often than not, what is found is the medical system gives the diagnosis to the parents, and then parents are possibly groping in the dark. So if they can be given a first information kit about the possibilities, about the possible support, including even the congenital heart defects. More than 70% of our children have congenital heart defects, and they do not know where to go and seek help. That will create yet another wonderful world for us, because these children are innocent and they're loving. So that, in the smartest way, is going to be the best investment for better tomorrow, for the inclusion to happen. Thank you so much.
And thank you so much, sir, not just for asking a question, but actually also giving direction in that sense. I appreciate it very much. Let's make it a rapid fire response. Let's go for the panel. Rapid fire.
Yeah, the last thing first. What we do in CDC is, I'll now mention Trivandrum Development Screening Tool. It happens from 0 to 6 years. Language Evaluation Scale, LEST, 0 to 6 years. Trivandrum Autism Behavioral Checklist, 2 to 6 years. So we are having this taste which are in place. We have given the capacity building. We have given this information. So the families, they come, and we are having clinics not only for these individuals, but also for the families. So there are special clinics which related to development evaluation clinics, development therapy clinics, speech therapy clinics, etc. So we have linked, as you rightly said, after detection, what are the intervention we should be doing, that we have put it in place. And I also said that we are practicing fetal medicine in CDC. Sir may be knowing MKC Nair and all. In fact, they have done huge, humongous work for last 2-3 decades. So in this, we go for this amniocentesis, and also we go for a chorionic villus sampling. But these two tests we are outsourcing. This year we will have an infrastructure and we will do it. Thereby we will be able to identify many of these congenital diseases, which also we can work it out. So there are thinking that what next, and I think based on that experience we can scale it up all across. So thank you very much for your inputs also, because it is required. And this engagement with the family is very, very important, because if anything, even me being a doctor or anything, if something is there, I may not be knowing.
Suggestion, there seems to be an information gap typically, because since I work across all the states, so if there can be a seamless communication and a follow-up, as you rightly said, sir, Parikh sir, Thakkar sir, the follow-up, so that the inclusion ultimately happens beyond the age of 6 years. Thank you so much.
So as all three questions arise and our analysis happened, see, in our country, we cannot deny that development is under consideration or underestimated, right? So India, like a vast country, needs some time to reach the total area as well every citizen. And as the Santoshji told, the past glory has to be brought in to the practice, analyzing their values and the significance which had achieved its greatness in the past needs to be practiced in the present too. And as Anil Joshi told, see, we have reiterated several times, the medical and legal aspects has to walk hand in hand to develop a lot of policies which may be advocated the for and against, and it might take some time to realize its greatness. So, as all three questions have been answered to the greater extent by this panel, so that I shall thank the panelists and the viewers for accessing the concept very keenly. Thank you.
Thank you. Dr. Moriki or Dr. Tucker, any last comments?
So
Rapid
I just
fire.
wanted to answer her question of why newborn screening is not part of all the newborn screening for everybody. Because one is the logistics, second is the cost, third is the follow-up. So one is that we cannot afford for all the babies now. Probably time will come when Kerala will take a lead and then start it. Or Goa has done it in some of the screening. So you will start developing one by one. So like Gavi doing immunization, we may start doing that. The second thing is false positives. So once you get a false positive, then a lot of counseling needs to be done and see that repetition has to be done and diagnostic tests have to be done. The third is, if you diagnose, do you have a treatment? So many of these metabolic disorders, we do not have diets or the supplements which can be given. So these are the reasons, but I'm sure time has come that we need to start somewhere. That's why I said that at least at the at-risk where babies are getting out of the NICUs and SNCUs, those definitely needs a good newborn screening.
So I slightly differ. The main barrier is cost. And let me tell you, the owner of that company who makes these machines in Germany is Indian. So I can connect. I met him in Geneva. And no, there is no excuse. We have to, because if Indonesia can do it, we can also do it. And we have to do it for everyone. And once the India decides, the cost will go down. And
Thank you.
the second, and thank you very much, sir, for that. There is my fourth panel will be on 27th with Down Syndrome Federation of India. I'm staying for that because, you know, to show my solidarity. Thank you.
Thank you. Any last comments from your side?
Sure. So, I just wanted to say very quickly, because again the bell will go. So, I'm a great believer in the 1,000-day program. So I feel that after a baby is born, we need to track it for 1,000 days. And when we're talking about capacity building, it has to first happen for the front care workers. So, the entire burden of actually search and then referring them and giving them information is falling on contract workers. All the ASHA and Anganwadi workers are all contract workers. They are not the regular health workers. They are not trained. So the capacity building needs to happen there first. And secondly, I feel that all along India has been working on manual data systems. And now we have built capacity to work on digital systems. So the moment you start looking at data and you're able to identify where the problem is occurring, I think you can take the solution closer to that place. Yeah. Thank you.
Thank you so much. Inclusive early childhood development is not a luxury. I hope you're going to remember the slogan. Let me do it once more. Inclusive early childhood development is not a luxury. It is a right. It's an obligation also. And indeed, it's a smart investment. I think that's what we said. Dr. Santosh, please help me to thank everybody who was in the right room. Please help me to thank all of them, to welcome them for the contributions that we had today. Thank you so much to the panel. Thank you so much. Yeah.
Yeah. Just as a sign of token of gratitude and respect to all the panelists, I request Sanjay Singh ji, the Chief of Field Office of Maharashtra UNICEF, to give a memento and a shawl to Chief Secretary, Madam. Yeah, photo. Dr. Santosh Kumar Karalati from Sushena Foundation, Honorary Secretary and Associate Dean of Rishiwood University, to give the memento to Aryan, our Deputy Representative from UNICEF.
Thank you for having us.
I request Dr. Sanjeev Upadhyay to give the memento. He is the Vice President of Sushena Foundation, to Dr. Rajan Kobragade, our Additional Chief Secretary from the Government of Kerala. Say here. Yes.
Thank you. May I request Mr. Sanjay from Rockwell to kindly come forward to give the shawl and the memento to Mr. Govind Rajanji, the Commissioner for Persons with Disability. Big round of applause. Sanjayji, please. Please look that side, towards the camera once. You can see that side, towards the camera. Sridhar, can you just... Yeah, may I request Dr. Sridhar to kindly felicitate Dr. Srinivas Murki. Yeah, thank you. Last but not the least, may I call upon Dr. Z, Dr. Zalaman. Please go to the end, otherwise, yeah, Dr. Naveen Thakkar, thank you so much for being a part of this forum. Yeah. The memento, please. Yeah, thank you. May I request all the guests to please just hold this ECD, a poster for the pic, for the group pic, kindly. May I request Dr. Z to kindly stay there. May I request Dr. Sanjeev and Dr. Sanjay to kindly come onto the dais. Dr. Sridhar. Right. May I request Geetanjali and Natasha also to join. Sure. Sure. Srinivas, Dr. Srinivas. Good. Took your phone, Dr. Sridhar?
Check. Hello.
Hi everyone, I'm Kirti from Dasra and we'll be starting with our next session on climate and health policy. No worries. Climate and health policy is very soon in another 5 minutes.
Hello.
Yes, you
Hello.
are audible.
आणि माझं म्हणणं हे आहे की पैशासाठी न करता
Hello. 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 Hello.
Hi Aparna, we'll be starting in like around 5 minutes, and that's when we'll kind of notify you as well. We are
Okay.
just like waiting for the rest of the panelists and for the audience members to come.
Right, sure.
Thanks,
Thank you.
thanks Aparna.
Thank you.
Hello. Hello. Angit.
नहीं नहीं मैं कह रहा हूँ पीडी पीडी क्या है
Okay. Thank you so much. Am I audible? Perfect. Thanks. I think this is the last session of the day across, so it's going to be a little more enthusiastic for all of us. I am Pranay from Dasra, going to be a moderator of this session. I think I'm tasked with introducing the luminaries on this dais. I think it could run in pages if I could just go on talking about the work that they have done. If I have to talk about Dr. Soumya, it's been 4 decades. I think my existence wouldn't even match to her work experience. So prior apologies if I end up missing out on some of the work that you have done in the field. I'll do justice and give more time for our discussion rather than spending time on introducing you. To begin with, I think we have the audience who are interested and enthusiastic about understanding how climate and health intersects. And I think the interesting part of this conversation is going to be about the policies that the government or the civil society or as an individuals we are interested in looking at the intersect of this. Over the next 50 minutes, the conversation or the takeaway for us is going to be like, what are the climate considerations or meaningful integrations that we can look at having it in the policies that we all talk about, and what are the existing efforts that are already happening in this space. Moving on to introducing the panel for today, we have Dr. Soumya Swaminathan. Like I mentioned, her work spans over 4 decades. She has seen a lot more changes in climate as we speak, literally, figuratively. She is a pediatrician and a global expert in TB and HIV. And on a recent past, she has been also a chief scientist on WHO. Her work also covers leading the ICMR in the past. Thank you so much, ma'am, for joining this panel. We look forward to a conversation today. We also have Dr. Haya Khan. She's a consultant on infectious disease and One Health at Khushi Baby. We had a very interesting conversation this afternoon in the round table, and we look forward to having more such conversation with you, Dr. Haya. Welcome to the panel, and I hope we get to speak more about what we couldn't speak in the afternoon, so welcome. We also have Aparna Roy joining us. Unfortunately, she couldn't travel and be here in person, but thank you so much for joining us irrespective of all the challenges at your end. Aparna, she's lead fellow in climate change and development at ORF. Dasra and ORF is also working on so many other things, so happy to see you here. We look forward to all your experiences from the state of UP that we are working. So lot more realistically speaking about your experiences and all the narratives that we could share during our conversation. We also have Dr. Vishwas Chitre with us. Again, we've been working on so many things together at Climate Rise Alliance Dasra. So we look forward to hear more from you in terms of your experiences of working on the climate plan. Dr. Vishwas is a senior program lead at CEW. Thank you so much for joining this panel and look forward to having more the conversation as we go in this. And I am Pranay. I am part of Dasra. I lead Climate Rise Alliance team. Dasra is a secretariat and anchor this alliance where we work with all the partners who are in the space of climate change. Thank you so much for attending this session, and we get into the conversation. We will keep 15 minutes or 10 minutes of time for Q&A towards the end, and we will have audience asking questions during that time. I will quickly go to my first question to Dr. Soumya, if I can start with you. Perfect. I think what we kind of thought is that when we get into this conversation, it would be interesting for us to discuss what is existing at the moment. So we will start with the existing mechanism that are there. By that I mean, Dr. Soumya, you know that a climate in a silo or a health in a silo, maybe for years that has been happening. At some point of time that the line got blurred or they got integrated. There are certain efforts that are already happening when it comes to NAP, CCHH. Would like to hear from you your experiences both globally and at MSSR. Is any meaningful interdisciplinary framework or institutional mechanism in place that are starting to bridge these silos between climate and health in India? Are there any signals that we have? Are there any meaningful conversations or early victories that we are seeing of blurring these lines or integrating this together? Over to you, Dr. Soumya.
Yeah, thank you. So I certainly don't claim to know everything about the systems, the data systems that exist. But maybe we can start by, acknowledging that it's only quite recently that globally, and of course then nationally, this climate and health has become, now it is a hot topic. Everyone's talking about it, but it hasn't been that way for too long. Even the work of the IPCC till the COP28 in Dubai did not really focus on health at all. And it was only in Dubai that there was a health day for the first time. Of course, WHO had been the one agency, I think, that had been really advocating and doing a lot of work around climate and health and trying to raise the awareness and the political attention to this. But really it was, climate has really been about mitigation, and the whole adaptation conversation is happening much more recently. So whether it is agriculture, which means also nutrition, or whether it's health and climate, I think these are recent global conversations. Now, of course, we've had initiatives like, the Lancet Countdown on climate and health. That's been going on now for many years, and they have developed a set of indicators and a framework, and they do report out every year, and they also report out on regional level indicators. But there's still a lot of conversation going on about what are the best indicators to track, regionally relevant, that could indicate not just the impacts on different aspects of our health, because climate change does impact directly or indirectly on so many aspects of our health and well-being and our lives. So we undertook a review of the evidence just from India alone last year, and that too focused only on women and children. And this was done for the Ministry of Women and Child Development, where they said, the minister actually wanted to know, because she said that she was not aware of any exercise to bring together all the data and evidence on the impacts of climate change on women and children, because policy needs to be driven by data and evidence. And so just the scoping review that was basically published literature, but also some primary research looking at putting together things like the NFHS data and overlaying that on, let's say, the Climate Vulnerability Atlas developed by CEW, to see whether drought-affected or districts that are repeatedly exposed to drought, for example, does the health indicators change? And we did find that there was significant association between several maternal and child health and nutrition indicators and living in a district that has been repeatedly exposed to either drought or floods over the last 10 years. So I think it's not just the acute impacts of climate. We all know that when you have a flood or a hurricane or there's a heat wave, that people are directly impacted, they're displaced, there could be deaths, there's a lot of physical and mental trauma that occurs. But the slow onset impacts of climate change on mental and physical health, and particularly the gendered aspects of that, where women are disproportionately bearing the brunt. And because women bear the brunt, the children are also impacted. Of course, education is also impacted by disruptions to schooling, I think has not been well studied. Mental health is a good example where I've spoken to several psychiatrists who see that, yes, there is a lot of theoretical data to show, for example, that heat does impact psychosis. It worsens it, but it also has an impact on how drugs are acting. So if you're exposed to heat, then some of the antipsychotics that people are taking, they start behaving differently, and therefore you can have an exacerbation of psychosis during heat. There's a lot of anxiety, eco-anxiety or climate anxiety as people call it, especially amongst young people, school children and so on. Psychiatrists are beginning to see the impacts of this. Of course, if you're exposed to a hazard and you've had to leave your home and be displaced, that's one thing, but even without that, there are impacts. So I think it's an area where there is still a need for a lot of research, but not just data collection, which is important, but different types of data need to be brought together. I think there are efforts in that direction, but I'm not aware of any good pre-existing database that's really bringing climate and health data together. A lot of plans are there, a lot of national level and state level plans on heat and climate and health, but the implementation of those really has not been well thought through and integrated or financed, I believe, but I think those things have to change fairly quickly.
Thank you so much. I think very interestingly, you did talk about equity in your conversation. I would definitely come back to you in a later part of our conversation on that. But moving on to from the existing infrastructure now to ability of policy system to integrate and understand what's happening at the ground level, I think I would like to move to Dr. Haya and her experience at Khushi Baby. If I could ask, do you think that the policy system are currently structured to pick up these climate health linkages signal from the field? And if you could help us from your experiences at Khushi Baby, what you're trying to do of collecting this data and working with the last mile workers at the moment.
Thank you for the question. So first I would like to quote some existing policy mechanisms which are addressing climate sensitive diseases, such as I would say National Action Plan for Climate Change and Human Health, and then climate sensitive diseases such as NVBDCP which is taking care of dengue and malaria and chikungunya, and then there is IDSP which is also taking care of waterborne and vector-borne diseases, and mental health, of course, it is there. So the existing policy mechanisms which are like designed to collect the data. So we are talking about the last mile field experiences. So to get the picture from the field, we need to strengthen the community-based reporting. So if we go to IDSP, it is collecting data from the field in the form of S-form, which is like syndromic approach of various diseases, which also covers the climate sensitive syndromes. And if we go to the NVBDCP cell, it is also collecting data in terms of vector densities, vector larva survey things, and line list of positive dengue and malaria cases. And our frontline workers are involved in malaria testing, slide testing, all these things. So yes, to a certain extent, we have the policy where the frontline workers are involved in some climate-sensitive diseases. But to get a linkage on the field, we need to locate these diseases at where they're occurring and the climatic data at that point of time, the hyperlocal level distribution of the diseases and climatic factors, one thing. And another example is heat-related illnesses. So the lowest reporting unit is healthcare facilities, which are reporting heat-related illnesses. And we have skipped the frontline workers. It's true that the exact diagnosis of heat-related illness is not possible by the frontline workers. But if we see the symptoms, altered sensorium, high-grade fever, vomiting and diarrhea, they're already reporting on S-forms and IDSP. But in heat-related illnesses, heat stroke cases, the syndromic approach can also be utilized, and we have completely skipped the community-based reporting in heat-related illnesses and air pollution-related illnesses. So the existing mechanism, there is a gap where we can collect the data from community. So if we talk about, your question was, are there relationships, So yes, there are relationships in the service delivery and at the field. The disruption in the service delivery or the interrupted health outcomes because of the climate, it is there. It is well addressed in the policy mechanism. But to get the real insights, we have to support the community-based reporting first. Then we can dive in and we can find the minor gaps to address. And another point where I always emphasize we are generating data. We do not want to, raise the point of entries of the data, but whatever data is being collected, we have to see it is of quality in terms of completeness and timeliness. And then the access to the data and sharing with, to get the proper linkages. If you want to, generate evidences of the linkages, we have to have the data, quality data of both sectors, climate and health outcomes. Thank you.
Thank you so much. I think in later conversation, I would also like to hear more from you in terms of the policy structures that are needed to kind of further strengthen the last mile health system. I would come to you later, but now moving to our next panelist, Dr. Vishwas. I know your work in city level plan and of course closer to my house, which is Thane. I think you've been a lot more active and working with that city. What I would like to know more from you in terms of the inclusion of health in the city level climate adaptation plans. What are the barriers or what are the enablers that are there? And if you could also help us understand what has been missed out while the incorporation happens and what have been successfully integrated when we are talking about these city level plans so far in your experience of working on this.
Sure. Thank you for having me on the panel. So I think if we talk about the action that happens at the city level, I mean, there are of course these climate action plans that are being developed across various cities. But again, these climate action plans are more focused on mitigation focus of action of the climate change as a whole. And which means that how we are establishing energy efficient buildings, what are we doing with our current city level emissions, etc. So there is much more focus on those. But if we look at issues such as, like, as Dr. Soumya also highlighted, that adaptation should not be an afterthought, but it should be the mainstreaming of climate action. So if we look at what different cities are currently facing, cities are facing heat wave impact, cities are facing urban flooding related challenges and air pollution, etc. But if we look at climate change linkage, I think urban flooding and heat waves are the two most impactful disasters that almost all the cities in India are facing. Now we must look at how current climate action plans can address that challenge. And again, when it comes to, say, any city administrator to prioritize on where I should put my maximum resources or where I should put my immediate response mechanisms, I think we will need an assessment of which ward in your city is at the highest risk of urban flooding, which ward in your city is at the risk of, say, heat wave impacts, etc. And for that, then of course it all boils down to what level of data you have within that city which is available at the scale of a ward. So currently, I mean, as you mentioned, the Thane work where we worked on ward level heat risk assessment, as well as with another team once from CW, we worked on flood risk management plan also for Thane, which is also a ward level first of its kind of plan on flood risk management. So we have identified that 3 wards in Thane are at the highest risk of flood, and 2 wards in Thane are at the highest risk of heat wave. Now, if you look at out of these 9 wards, those 3 wards that are prone to urban floods are different from the wards that are at the risk of heat wave. So it is very important that we should go to the granular possible scale in a city and identify this multi-hazard approach of looking into climate change adaptation. That's how we will be able to identify local specific adaptation solutions that can address this challenge. And that will only happen when we will have either hotspots of various different disasters that is going to impact the city, and then that will help you in developing the adaptation plans. So currently I think there is a bit of mismatch in that sense, but also, like, I mean, at CW I lead this climate resilience team, so for me mitigation doesn't really matter. There is a separate team that deals with that, and we should focus on adaptation is my thinking.
Thank you so much. I think I will also loop you in later to hear more about some of the global practices and if there are any learning for us. But for now, I'd move on to another panelist, Aparna. Thank you so much for joining us online. I know there's a lot more work that we're already doing between Climate Resilience, DASRA, and ORF when it comes to UP as a state. Why I'm bringing this again is that partly I would request if you could cover this in your next question, which is about at the beginning of this panel, we did talk about how the lines need to blur and the silos from integration need to happen between climate and health. So in that context, Aparna, institutions and the coordination structures that are helping to bring this climate health integration in your work so far, if you could help us understand the key nodal institutions, both at the national and state level, or at least at the even also at the local level, that are currently playing role in driving the climate and health integration. If you could throw some light on that.
Thank you, Pranay. I hope I'm audible. So a very good question. But I think that in India, it's you can't bring in just UP because we have started work there, and you can't talk about a state in particular, because the challenges and also the good things about integrating climate and health begins from the top at the national level, and then it trickles down. So I'll try to cover whole of it, but I'm also very pleased that ORF, DASRA and Climate Rise Alliance have started deeping dive onto this integration of climate health challenges and how to overcome the institutional bottlenecks. And we have started off with the state of UP. But overall, you are absolutely right. I think strong institutional architecture, Pranay, is the bedrock of any effective response that seeks to integrate climate and health, right? And in India, we have seen commendable strides that are happening in recognizing climate and health linkages. It's not that this is not happening at all. But the problem is that our institutional response is still at a very nascent stage and is still evolving, right? So at the national level, we have the Ministry of Environment, Forest and Climate Change and the Ministry of Health and Family Welfare that are the two primary nodes. The National Action Plan on Climate Change through its health mission and its state level counterparts, the SAPCCs, have begun incorporating health as a cross-cutting theme. But I think much of this integration is still siloed. The MOHFW, for instance, have launched the National Program on Climate Change and Human Health, NPCCHH, which is a positive step, right? It mandates health surveillance, training of health professionals, and even infrastructural resilience. But the program is limited in scope and funding, and yet is not mainstreamed across other line departments. State governments too are beginning to build this momentum. You go to Tamil Nadu, for example, that has launched a dedicated climate change mission with health as one of the verticals. And Kerala has been working on climate sensitive health indicators following the devastating floods that had happened in 2018. But when it comes to the need to institutionalize these efforts, embed them within departments of urban development, agriculture, water resource, disaster management, I think that is where the gap remains. They are not fully integrated and embedded. But where I see the biggest gap is, and like Vishwas has thrown light on it already, is at the city and local level, which was the primary purpose of us getting into a project to explore these gaps in much detail. So despite cities being at the front line of response resilience, being at the front line of climate health impact, be it air pollution, be it vector-borne diseases outbreak, or heat stress, I think urban local bodies rarely have the technical capacity or the financial autonomy to respond. For instance, if you look at the air quality management, that still remains highly centralized, even though municipal corporations are much better placed to act on the sources, like when it comes to waste burning or mitigating the effect that are coming out because of the construction dust. As for the interministerial coordination, again, it's still weak and at a very nascent stage. We don't have a formal mechanism, whether in the form of a task force or a mission mode program that brings together, say, an MOFCC, MOHFW, Mahua, or Niti Aayog to develop a unified vision on climate and health. The Prime Minister's Council for Climate Change was primarily, at one point of time, was meant to enable such cross-sectoral integration, right? But its functionality has waned a lot. But instead, what we often see, which I also count as a good thing, is this periodic episodes of collaboration, such as if you go back to crisis during the COVID-19 pandemic, or when it comes to extreme heat events, right? So we do respond, right? But that is not a sustained institutionalized coordination that we often see. So definitely, Pranay, to answer that, now to round off, we need a national climate health program ideally hosted, say, under one department, Niti Aayog, or any other platform. It could also be the National Health Digital Mission, which can act as a convening space, a platform which have the data repository and which could act as an incubator for these integrated solutions. And just as important, we must empower district level health officers, municipal planners with the right data, with the right training and budgets to act on local climate health vulnerabilities. Yeah, Pranay.
Thanks so much, Aparna. I think I'll bring you in later in discussing more in terms of how do we strengthen these governance structures, capacitating, or bring more accountability and all. But for now, I would like to bring in Dr. Soumya again. I think in our earlier conversation, you did try to touch upon the equity, and you have long emphasized your efforts and bringing this conversation on in terms of equity-centered policy design is something that need to be spoken and not kept at the periphery. So what are the kind of institutional reforms, incentives, or accountability mechanism that need to put in place for this to happen, and the whole equity-centered design is at the center and not at the periphery? If you could just throw some light on this.
Yeah, thanks for that question. I think that's not for climate alone that we need to do that. All of our policies, and particularly government programs, must have equity, and they're designed, to have equity, but that also means that you need to monitor and you need to be able to look at some indicators to tell you whether it's serving the purpose. Because especially when you look at social safety net programs, India probably has some of the largest safety net programs, like the ICDS, the school meals, the PDS, and so on. And they are meant to cater to those, who could be the vulnerable or the marginalized. But in the delivery or the operationalization, there could be issues which come up And therefore, I think these indicators, to make sure that you're reaching everyone and that you're not the same group of people are not being unreached or left out of programs, I think that's very important. Climate change is one more stressor which will exacerbate the existing inequities. I think COVID was one, and we saw very clearly during COVID in every country that existing inequities were amplified and that people who were already disadvantaged actually face the brunt of both higher infections and higher deaths. So climate is going to do the same. It's already doing the same, right? If you live in a hut on the edge of the river, you are going to be the first one that's going to be affected by the flood. And who lives there? It's the people who can't afford to live anywhere else, and they put their huts, and every year when the floods come, whatever little belongings they have, are gone. The people who have to work outdoors, regardless of what the temperature is, because they have to earn their wage. So like Vishwas was talking about mapping, the blocks or going down to very granular level in terms of climate impacts, we also need to map the vulnerabilities. So in every city, in every town and village, you will know where those most deprived populations are living. And they usually have the worst housing, the worst air quality, the worst sanitation, the worst everything, right? Access to nutritious food. So we've got to start with that group then. So whatever we are trying to roll out in terms of a policy, whether it's solid waste management or reducing air pollution or improving buildings to be more heat resilient, let's start with those who don't have currently the means to protect themselves. So those who can already afford air conditioning, fine, deal with them later, but those who can't do anything else. So I think that in the latest CEW map, I think you have included socioeconomic vulnerability. So I think you need that layer, right? You need the climate vulnerability, you need the geographic mapping of who's susceptible to what, and then you need to add the third layer of socioeconomic vulnerability, and then narrow down on those places which have all the three intersecting.
So true, I think not only climate, but anything and everything, it is differently affecting different individuals or communities, and vulnerability mapping is so important in that case. And thank you so much. I think the efforts of CEW that you have started doing, and I think we should continue doing these things. I think I'll move to next question to Dr. Haya. It would be very interesting to understand from you in terms of how this climate health policy need to be structured to support the last mile health system. I mean, what are the features or the things that need to be kind of accounted for so that it's not top down, and at the same time it rather than imposing, it's liberating or helping the last mile to do this better. So what are these things that basis your experience need to be accounted for or thought about?
So I would like to tell you one thing right here, that if you open the National Action Plan for Climate Change and Human Health and you search for the word for frontline workers or ASHA, A&M or Anganwadi, you will get 1 or 2 hits. In the whole action plan, the involvement is like quoted less than it should have been. Why I'm saying this? Because they are already working on climate sensitive diseases. They are working on, as I have said it earlier, they are working on vector-borne diseases, they are working on syndromic things. It's just that we have to make them aware, the link, that what work they are doing and how it is linked to the climate. And not in the context of linkage of the health and climate, if we want to strengthen the last mile, we have to create an environment where their awareness generation, capacity building, motivation and incentivization should be there. Then only they will be motivated or aware enough to link things. They have to be aware enough to understand that, okay, if this person is suffering from cardiovascular diseases, there are high risk to go, if he goes out and he will faint or he will have a cardiac arrest. And if someone is like pregnant ladies, these are part of their task, taking care of the pregnant ladies, taking care of the newborns, supporting help. So we have to make them aware of the context of these services in climate change. And apart from this, the bottoms up approach is there in reporting, where the field-based reporting is done and it is being analyzed by the top authorities, and the top-down approach is also there. But there should be a platform where the pain points of these frontline workers must be heard. So we have digital apps for our frontline workers, and we have a poll feature for that. So you can run any questions on that poll and they will answer. The accuracy, the response is purely depending on how aware they are, how motivated they are. So that can be questions which can be answered rightly or wrongly, or there can be their opinions on where they want to, show their pain points. So if we want to empower our frontline workers who are working in the field, we have to empower them in terms of awareness, capacity building, and then motivation. Acknowledgement of good services or incentivization of certain things which are highly required in the context of climate change.
That is so true. I think they are the first one who are directly connected to the community or having ears to the ground, if we say so. So cannot be ignored for sure. I think I'll move on to the next question to Dr. Vishwas. And if I could hear more from you in terms of some of the international best practices that could inform India's climate health policy. Are there any that, maybe that are there that you've been hearing, understanding, witnessing, and that we need to kind of deep dive more into?
Yeah, thanks. So I think, rather than looking at externally outside in the world, I think within India also, as some of us talked about different examples from different states, I think we should internalize and reflect on which are the best states in this kind of performance across Indian landscape, and what are the learnings from these kind of states. Like, for example, I think Aparna talked about Tamil Nadu, Kerala, etc. These have been doing amazing work in the space of climate change. Now I know that Tamil Nadu also has opened a climate change and One Health hub for the first time probably in the country, which is going to look at impacts of climate change as a One Health perspective. So even if we just do a stock take of what kind of best practices exist within the country, and just reflect on those and maybe bring out, okay, what are the current gaps in our national policies and processes, and what should be the way to address those based on the learning from within different states in India, I think the problem could be very much solved. Because I think the rate at which in the Indian landscape, again, like the rate of growth of technology, the rate at which different aspects are of development are seen in other sectors, I think health I think health tech and climate tech both are growing individually in that space quite a bit. So it will be just about also linking them together in order to see what is that intended outcome that we want out of it. So I don't think that we really need to look at externally, but even if we just reflect internally and learn from these processes, I think that's going to be an immensely useful exercise. And also, like as I was talking about in the earlier panel as well, when we talk about National Adaptation Plan of India, which is currently being formulated, I think, adaptation is very local specific. So we cannot generalize that whatever will be suitable for Kerala will be also suitable for, say, Maharashtra. So those local specific adaptation needs have to get reflected in the state level policies and processes, and then eventually they should get reflected in the national level processes as well. And that's how we can achieve a bit more of this interagency coordination between the different departments, like climate change, talking to human health, or health and family welfare department, etc. At the state level, same can happen much more proactively at the national level as well, so that we can break these silos and be able to bring together all the departments that need to work together. I mean, I also understand that individually all these departments have their mandates, so it's not like a easy job to ask them to work together. But I think approaches like One Health, or even approaches like, say, NPCCHH itself, which has been doing this in the past, I think if we put more proactive efforts on bringing the different agencies to work together, we should be able to have a successful outcome.
Totally agree. I think even before we go and understand global learning, there's a lot more to learn from each of the state. And agree on your point in terms of the hyperlocal reality or contextual reality. And without that, I think just copy pasting is not going to help for sure. So thank you so much, Dr. Vishwas, on that. I would like to bring in Aparna here. I think in your earlier conversation, you did help us with understanding in terms of a lot of these structures that are there who are kind of helping integrate climate and health. The extension of the same question here would be from diagnosing problems or identifying what the challenge is now to bringing the whole solutions and working on the solution. In that case, what are the mechanisms in terms of capacity that are missing or capacity that need to be built? What are the accountability that need to be inputted to kind of bring both health and climate sector together? If you could just help us understand that more.
So Pranay, I think, yeah, I mean, how the conversations have been flowing, I think this question rightly shifts the focus from diagnosis to design. And so I think to strengthen, as you rightly said, collaboration between both climate and health sectors, we need two interlinked pillars, right? So one is capacity building, that is very important, but it won't happen without accountability mechanism. So it won't be able to solve its problem on its own without a very strong and effective accountability mechanism on ground. But both has to be tailored to India's federal multi-layer governance structure. And like Vishwas was saying that I completely agree with him that the challenges are a lot local in nature. So my resilience and my capacity to build resilience might not be your capacity to build resilience. So, but first on capacity building, I think there is a significant knowledge asymmetry that exists between the climate experts, the public health professionals. So we have looked at a 2021 Lancet Countdown policy brief. I was just going through it, specifically on India. So it found that only 17% of medical institutions had reported, including climate change in public health training. And in the meantime, many state climate cells operate without a public health expertise. And I think to bridge this gap, what is needed is the need to institutionalize the climate health curricula in medical colleges. Many of the, medical, I'm also associated with the Berlin Medical College. I think a lot of these medical colleges are now bringing in a curricula where they're putting on these training modules on the interlinkage of climate change, social determinants of health. So these cross-cutting themes and introducing them in medical college as well as a public health training program is very important. So I think Public Health Foundation of India had piloted modules on environmental health, and these kinds of things need scaling. And at the administrative level, I think it is also very important to embed these modules where we teach them about the climate health integration as well. And capacity building programs must also be started even at our Lal Bahadur Shastri National Academy of Administration and state administrative training institutes, so that even at the level of a district magistrate and municipal commissioner, we understand the risks in a holistic way. And at the frontline level, as Dr. Haya was mentioning, I think ASHAs and ANMs, who are extremely central to our primary health system, must be trained to recognize and respond climate-sensitive illness. And India's success with a decentralized health system during COVID shows the power of what our local capacity can do. And we need a similar mobilization for heat wave, for flood, for air pollution events, everything. But like I said when I had begun that capacity won't be able to achieve anything without accountability. But today, neither the Ministry of Health nor MOFCC has shared indicators on or outcome-based targets on climate health linkages. So this leads to diffused responsibility in many times. One way forward is to include climate health resilience indicators in the National Health Mission's Performance Index. For instance, if we track down reduction in heat-related hospitalization or prevalence of respiratory illness during peak pollution seasons, that would inform these indexes a lot. And another mechanism, I think, is to institutionalize joint planning and reporting, which is not yet started. I'm not aware of, and if there is any, I would want to learn from others. But we need annual climate health assessments at the district level, similar to what the IMF, Indian Meteorological Department, does for seasonal outlooks. And this could be coordinated by, say, state climate health task forces, but made publicly available, because it is very important to access data to ensure transparency. And I think you were talking about international examples, and I think we also have a lot to learn from international examples. In the Philippines, for example, the Climate Change Act mandates local climate change action plans to incorporate health considerations, and there is a legal requirement to report them. So the question is, could India move towards such legally mandated cross-sectoral planning under Environment Protection Act, say, or through a revised Disaster Management Act? And I think finally, responsiveness to emerging health risks requires an early warning system that links climate models to health adversaries. And Tamil Nadu State Health Department's integration with IMD heat alert is a promising example. But these kind of things need to become the norm, not just scale up and not just an exception. So in short, I think the way forward would be to embed climate health capacity in people, in processes and in plans, and to ensure that we are tracking and reporting outcomes, not just inputs.
Thank you so much, Aparna. I think a nice way to, because you did mention the way forward, and before I open the floor to audience for a question answer, if I can have half a minute, a quick from each panelist, a call for action or a one sentence, be it for policy, be it for government, be it for the entities that are working in this sector, in terms of what is that one thing that you'd like to either get reflected in NAPS, CCHS, or in the policy, or in our work as we speak about climate and health. And if I could start with Dr. Soumya, anything for call for action for us to get started with?
I think data sharing, we collect a lot of data. It all sits in different departments, ministries, and it's very difficult to bring it together or even share it. And then we do a lot of unnecessary duplication, and it's not the most efficient way. So I agree with what Aparna was saying, and I've also been advocating for looking at our laws and systems and institutions that we have to address environmental health risks. It's not just climate change, but we are exposed to a lot of environmental health risks. And I'm not sure that the Central Pollution Control Board and the authority that it has is adequate to address the challenges that we are faced with currently. So I would really look at having an all-encompassing environmental health regulatory agency that could address many of the issues which are contributing to climate change and which are a consequence of climate change, with health at the center of it.
Yeah, thank you so much. We hope to see that happen soon, for sure. And we do definitely should continue sharing data. And if Dr. Haya, if you could come in with your call for action.
Thank you. So coming from an organization which developed digital health solution, I would also have said data sharing, but thank you, ma'am, has already said it. So yeah, so I would like to add to the data sharing. I would like to also ensure the data quality, what data we are already collecting, ensure the quality, and then I would like to say that empowering our frontline worker, motivating them, and generate awareness that okay, fine, you're already serving so many services, and that is related to, again, the climate sensitive diseases, and make them aware how important role they are playing and how important that services are, and how important the correct data, if they are providing it, if they understand that the hyper-local data, which is not possible from the labs or hospitals. So they can be a brilliant source of that data, but the least they have to be aware that what this data will do for the community.
Dr. Vishwas, anything other than data?
Yeah. So I think what's most important is also interagency coordination and more such national policies and programs in terms of say formation of task force, which can bring people from various ministries to work together on a common goal. And if we can have such a national level task force on climate change and human health, and within that there could be different groups on say heat related illnesses, other disasters, etc. So something like that would be able to also bring the data that these different departments host together, and then working on a common goal of achieving reduced health outcomes. I think this task force or some working group should be formed that can facilitate better interagency coordination.
Yeah, I think that would also an effort towards overlaying health and climate indicators. I think that's also very interesting area that most of us are already engaging with for sure. Aparna, if you could quickly come in with your call for action.
So Pranay, my call for action would be that whether it's climate action in terms of mitigation or resilience, whether it's an urban heat action plan, a clean energy rollout, or air quality emissions, health co-benefits must be measured, funded, and reported. And this single shift, I think, would force ministries to talk to each other, make policies more people-centric, and catalyze the kind of systemic collaboration that we urgently need and that we have been talking here about. I think my last words would be that health isn't just a co-benefit of good climate action. It's a powerful entry point that can drive ambition, create public ownership, and catalyze intersectoral collaboration. So this is one change that I would want.
Thank you so much, Aparna. I think the floor is open for question answer if we have a couple of questions from the audience.
Thank you. My name is Arjatara and I have a question. Think from one of the previous climate sessions and from this one of the points that stands out is interagency collaboration and a nationalized federal level platform where data can be looked at, can be tracked, surveillance basically. But it sounds like these things might have been talked about before, but what, according to all of you, are the barriers to such things because it hasn't happened yet? And something to learn from a different country would be one of the programs that the US has is the National Environmental Public Health Tracking Program, where they track environmental and health indicators over time. And this started after a Pew report in 2003. And now we're in 2025, so they've come quite far along with doing so. So just something to learn from, and then what are the barriers right now that things haven't moved in that direction already? Because we're quite late in the game. Specific question, I guess Dr. Vishwas and Dr. Soumya, whoever wants to take it.
Yeah, no, it's a great question, but I don't think there's a easy answer. It's the way the bureaucracy functions, the way that government departments function, the way that data is collected, stored, analyzed, and used. And I think, yeah, we need to think about, there are good models and examples in other countries and in our own country as well. The NFHS is a good example of very systematic data collection survey where the data is also then made available for secondary research. And so there are a few good examples like that, but I think, yeah, I can't pinpoint one reason why this has not happened, but I think it is probably time for us all to collectively advocate for this to happen now.
I think, as Dr. Soumya said, there is no particular reason, but that's how things have been working in the past. But also, if we, just while thinking about it, I was thinking now we talk about heat-related illnesses, right? So there is an health outcome because of some climate-induced impact that we are seeing. There is waterborne diseases. So we have to look at how these systems have evolved due to impacts of climate change, and why now we are in a need of more of interagency coordination. So maybe 20 years back, we were not seeing so many heat waves or so many heat-related impacts on health. So there was no need to work together on this particular aspect. But because of adverse impacts of climate change, the need has now evolved in last few decades for better coordination among the different agencies, especially focused on adaptation. And that's why probably we need to put much more focus on interagency coordination.
We could take a couple of more questions from
yeah,
the audience.
Hi, I'm Atmika. So my first question is to Dr. Vishwas. Department of Science and Technology and Council of, CEW also came up with a vulnerability assessment district level. So based on the same framework, but the results were different for both of them because CEW had an added layer of context-specific spatial temporal indicators as well. So, and now we have multiple VNA reports coming up at different locations, different geographies. For example, Kushi Baby is doing it as well. So you have multiple locations coming up with these very high resolution context-specific VNA assessments. Do you think there is a need for standardization? Because again, very limited resources, very limited funding. So when it comes to policymakers, they would need something very standardized. So I'd like you to speak to that. I just one more question,
okay,
please. So my next question is to either Soumya ma'am or Haya ma'am, either one y'all could take it. So Soumya ma'am, you mentioned about global level talks about climate change regarding health came out much later. I think probably COP26 was maybe the starting point of COP28. But having worked with tribal indigenous communities through MSSRF for climate smart and climate resilient agriculture, do you think these talks have always been happening at the community level through their lived experience? And if yes, do you think there is still a drive for it if we made them the center for all of the climate adaptation activities, if so? And this also applies to Kushi Baby for the maternal and child department. You kept saying frontline workers, but as you know, frontline workers are already overburdened with the kind of work that they've been doing at this point. So is it an exploitation, is my question? Or do you think that's the only way to go about it?
Thanks so much.
Sure, thanks. That's a very important question because we have also observed that in the past few years, there have been many more vulnerability assessments, etc. But I think now the syllabus has changed. So it was a time when we used to use keypad-based phones. Now the time has come that we start using smartphones. So as we go along in the climate change also, IPCC's older framework referred to vulnerability as the final assessment, but there was no assessment of hazard impacts on the vulnerability. Now after that, in the AR5 framework, assessment report 5, they came up with the risk assessment approach where hazard is a separate component and vulnerability is a separate component that comprise of sensitivity and adaptive capacity. So moving on from vulnerability, I think we all should focus on risk assessment, which is a much more sector-oriented approach. So in the current NAP that India is developing, also various sectors are doing this risk assessment to identify what that sector needs, how that sector is getting impacted by climate change, rather than looking more of a landscape level vulnerability indicator. Of course, till that time we didn't have any framework, so everybody was focusing on that. And as we humans evolve, I think our technologies and methodologies should also evolve. So now we have moved into risk assessment approach, and whatever we do at CW is also following the risk assessment approach. So we are not going back into vulnerability approach. So I think that brings us an enormous advantage of identifying sector-specific risks. And again, when we go down to, say, for example, we supported State of Maharashtra to develop their state action plan on climate change. There we did the risk assessment for 2 sectors, agriculture and water sector. That was to identify out of, say, all the districts in Maharashtra, which are the districts that have highest risk to the agriculture sector in that particular district, or which are the districts that have the risk to the water sector particularly. So when the state action plan on climate change is formulated, the adaptation strategies can give a focus on, in agriculture sector you need X, Y and Z in these 10 districts. So it becomes much more focused and much more oriented towards linking that risk into adaptation.
Maybe one last question and then we'll.
Yeah, hi.
But there's a pending answer and after, yeah.
The question on communities is very important because often we neglect to include them actually in these conversations, which often are happening top down. So yes, at the MSSRF certainly we try to be as inclusive and participatory, including in the research and in the data generation, and bring that learnings or experiences from the community back up to have some impact on policy and practice. So communities clearly can very clearly describe and spell out what they're experiencing. So currently we're doing a survey on heat exposure specifically for women, working women in particular, different occupations, to see what kind of impacts they've experienced, where are the gaps in access to healthcare, and also what happens to family relationships, tensions, livelihoods, etc. So it's a nationwide study. We should have the results by next month. But in terms of agriculture also, when you speak of fisheries, when you speak to the communities, they can tell you what they've seen over the last few years. They may not use the word climate change, of course, but the fact that they do their sowing a little bit earlier because they've seen the patterns change, that heat comes earlier and so they want to sow it earlier in the winter. And fishermen are clearly seeing the impacts of climate impacting their livelihood, but there is one confounding factor here, and that is what we ourselves have done. So we cannot blame everything on climate change, and that sometimes we have to remember that, because if you blame everything on climate change, then it's like, okay, we're helpless, this is what it's going to be like, let's accept it. A lot of it is things that we've done with the intended or unintended consequences that have had. So the fish population declining partly could be, of course, due to the sea temperatures going up and the environment changing, but a lot of it is due to the overfishing and the unsustainable fishing practices that have happened. So, and this is not specifically for India, but across the world, biodiversity loss, the pollution, all of that is, that's why this era is called the Anthropocene, because we're having, human beings are impacting climate and weather much more than natural, and it's a cycle, of course, it's a vicious cycle. So I think our whole approach to development, which is, of course, we have to focus on development and health and education and basic living standards for our population, but what pathway are we going to take? In a previous session that I was in, the Bhutanese gentleman there was talking about gross national happiness, and Bhutan for many years has practiced they don't talk about GDP, they talk about gross national happiness, which is a very different kind of a concept, because it really encompasses your the environment. I suppose one could describe it as a One Health in practice over there. So yeah, so I think it requires a discussion. While you want development for sure, because there's still a lot of people who don't have the basic access to things that they should have, but at the same time, the model that we want to follow of development, the people living in cities now aspire to cars, not one car, but 2 cars per family. So the apartments that are being built now are with more and more space for cars and parking slots. Whereas what we need is transport, public transport that will transport people, not cars. How many roads can be built? How much, so we need to change the paradigm of development, particularly urban development, so that we're looking at minimizing the damage to climate and environment but actually focusing on things which could have win-win solutions. And I think Aparna talked about health co-benefits. But I think if we put health at the center and look at other policies, then we can look at what each policy, whether it's going to really have a positive or a negative impact on our health.
Thank you so much, Dr. Samir.
I
Dr.
would
Haya?
like to respond on that exploitation point. So exactly that's what I'm trying to bring on the table, that these community health workers are already serving. They just they are just not aware of the context of climate change. So I would like to share a story that I went to a PHC where I communicated with Asha and I said that, okay fine, now heat is there, heat wave is there, अब किसी को लू लग जाएगी तो आप क्या करेंगी? And she said, हम उनको बताते हैं कि आपको हेल्प चाहिए, आप PHC पे जाइए और हम उन्हें ORS देते हैं. So they increase the supply of ORS. They are like, they have to be aware that now where the heat is rising more than earlier, so they need to know that if the people are like having cardiovascular diseases or infants, or there is a risk of there is a threat to the high risk pregnancies. So they are aware, they're already delivering services in these things, but they are not aware of the context of climate exposures and threats. So we are not putting them in the center and giving them more workload. We are just trying to tell you they are already working on these things. We have to make them aware and we have to acknowledge their services in context of climate change. We have to encourage them, motivate them, and we also have to incentivize their services in context of climate change.
Already 13 minutes extra, but one last question, and whoever do not get to ask question, please catch hold of them if their flights are not there. But one last question maybe we can take.
Hello, I'm Ananya Dasgupta. I just wanted to say that we talk about segregation of waste, but actually is it practiced everywhere? In my area, segregation of waste has not been so prevalent, and every day I tell the Kurawala to segregate the waste and go ahead. And waste disposal is properly not done. They put them in the landfills and burn them. And due to that, polluting gases are coming and creating climate change. Special use of incinerators have to be made aware of to the general public through social media.
Agree. I think zero waste.
And can we have early warning systems for the weather, for the climate changes that happen?
That means time off, so yeah. Anyone? I mean, if
so, ma'am, you have highlighted a very important point, that waste separation and their disposal, and their burning without filters and incinerators, they really create they pose a threat to the environment in terms of air pollution, which has to be addressed. It is a due cause. And regarding the early warning signals, yes, we can create early warning signals, but the accuracy depends on what data you feed in. Because whatever model we develop for the forecasting, if we will feed garbage, we will get out the garbage. So if we want to have the early warning systems accurately, at what level, what geography level? If you want to get early warning signals at state level, we have to feed the data on state level. But if you want it in a granular or sub-district level, then you should have the data, climate data at the granular geography. And if you, there are also mechanisms where we can calculate the vulnerability in terms of climate and health conditions and socioeconomic factors, but that also need an accurate data set.
thank you so much. I know there are a lot more questions that are in the audience. I'm so sorry if we couldn't take your question, but if you do get an opportunity, please talk to them during their corridor tea break or something like that. To begin with, I think, how do I summarize the last almost 70 minutes of the conversation? But what I can tell you is that the takeaway from this session was if we could, and we should definitely have a health system or a health policy that is more adaptive, equitable, and resilient. I think if we could blur more lines, integrate climate and health, keep health at the center and everything that is accounted for, learn local context, have hyper-local data, incorporate for contextual realities. I think these are the conversations that happened. I think there were a lot more granular discussion that happened. I would not repeat that, but thank you so much for taking your time out and being part of this. Climate Rise Alliance, Secretariat, Dasra, look forward to work with you, continue to work with you on the efforts that we are doing. Thank you so much for the audience for being very attentive towards the last session of the day. If we could just take a group photo and call for a, yeah, maybe we can, if Dasra team, if you could just join us for a photo. And thank you so much, audience. I think without your participation, this wouldn't have been a success. Thank you so much.